Like the bone is broken or it isn't, the boundary is
Yeah.
clear.
You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, well, there it is. But then you look at something as ubiquitous as diabetes, and suddenly that x-ray machine is broken.
Yeah, completely broken.
We are looking at a diagnostic landscape that is incredibly murky, mostly because we try to diagnose this massive, complex disease using just a single number.
Which is really the core reason we are doing this deep dive. For you listening, especially if you're a nursing student grappling with the realities of diabetes mellitus, or just a curious learner, we really need to look past those tidy diagnostic numbers.
So they can be super misleading, right?
Absolutely. Our focus today is unraveling the actual pathophysiology. We want to understand the profound biological differences between type 1 and type 2 diabetes.
So, okay, let's unpack this. Currently, the American Diabetes Association, the ADA, diagnoses diabetes using strict lab thresholds. Like they look for a fasting plasma glucose of 126 milligrams per deciliter or higher.
Right, or an A1C of 6.5% or higher.
Yeah. But there is a fundamental flaw here. You could have two patients standing right in front of you. They both just got their lab results back, and they both hit the exact same A1C of 8.2%. From the number alone, they have the exact same disease.
But clinically, they arrived at that 8.2% through completely different, almost opposite biological mechanisms. Diabetes mellitus isn't actually a single disease.
Wait, really? It's not one disease?
No, not at all. It is a broad group of metabolic diseases that just happen to share one final symptom, which is chronic hyperglycemia. That just means persistently elevated blood glucose.
So because the medical field historically only looked at that final symptom, they just slapped one overarching name on it.
Exactly. To really understand why we rely so heavily on the end result, we actually have to look at how humanity first discovered this disease. This takes us way back, thousands of years before anyone could look inside a pancreas.
Oh, this history is wild. We are talking about the year 1550 BCE. The Ebers Papyrus in Egypt describes a condition characterized by just relentless excessive urination.
Yeah, and the terminology evolved much later. Around the 2nd century CE, a Greek physician named Aretaeus of Cappadocia observed patients who were desperately thirsty. They were seemingly wasting away as fluid just passed straight through their bodies.
Which is horrifying.
It is. He coined the term diabanon, a Greek word that means to pass through, as if through a siphon.
It paints a very vivid and tragic picture of the end stages of the disease before modern medicine. The body is desperately trying to flush out this excess glucose it can't process, and it pulls massive amounts of water with it.
Right, the kidneys are just overwhelmed.
And for over 1,000 years, physicians were just trying to figure out what was happening using observation, which led to some fairly gross diagnostic methods.
I know exactly what you're going to say.
In the 17th century, doctors were literally tasting their patients' urine to see if it was sweet.
Yeah, literal taste tests. So in 1675, an English physician named Thomas Willis officially added the Latin word mellitus, which translates to honey sweet.
Just to differentiate it, right?
Precisely. The medical community needed a way to distinguish this sweet urine disease from another condition called diabetes insipidus. That one involves very dilute, non-sweet urine caused by a completely different pituitary hormone issue.
Wow, that was the absolute limit of diagnostics back then. You just observed the output.
Yep. The ability to actually look inside the body and see the mechanics came in a very tight cluster of discoveries in the 19th and 20th centuries.
Like Paul Langerhans, right?
Yes. In 1869, this 22-year-old German medical student, Paul Langerhans, was looking at pancreatic tissue under a microscope. He noticed these unusual clusters of cells scattered throughout the organ.
He had no idea what they did he?
None at all. But they were later named the islets of Langerhans in his honor. Then 20 years after that, in 1889, two physiologists, Oskar Minkowski and Joseph von Mering, were actually studying fat digestion.
Okay, so not even diabetes.
Right. To figure out the pancreas's role, they surgically removed the organ from a dog. Weeks later, a lab assistant noticed that flies were suddenly swarming the dog's urine.
Because it was absolutely saturated with sugar.
Exactly. By taking the pancreas out, they proved for the very first time that this specific organ produces a substance essential for controlling blood sugar.
Which sets the stage for arguably the most dramatic medical breakthrough of the 20th century. In the early 1920s, at the University of Toronto, surgeon Frederick Banting and medical student Charles Best finally isolated a pancreatic extract that lowered blood sugar in diabetic dogs.
And then a biochemist named James Collip purified it for human use. On January 11, 1922, everything changed.
They had a 14-year-old patient, Leonard Thompson, who was actively dying of type 1 diabetes at Toronto General Hospital. Before insulin, a type 1 diagnosis was a guaranteed death sentence, usually within a year or two.
Physicians tried to buy these patients time with strict starvation diets, which reduced sugar intake but left the children skeletally thin. It was incredibly grim.
The first injection they gave Leonard Thompson was actually too impure, but a couple of weeks later, they gave her a purified batch. His blood sugar dropped, and he began to recover.
Insulin turned an inevitably fatal disease into a manageable chronic one almost overnight. It's an amazing story. Banting actually split his Nobel Prize money with Best because he was so furious the Nobel Committee excluded the medical student.
That's some great medical drama right there. But as incredible as the discovery of insulin was, I think it created a massive clinical blind spot.
Oh, it absolutely did. Insulin was a miracle cure, but it treated the symptom of a failing system. Because it fixed the end result, the high blood sugar, it heavily masked the fact that there are two very different ways that system breaks down in the first place.
Which brings us to the actual starting lines of these conditions, the first principles. Let's start with type 1 diabetes, which is fundamentally an autoimmune fire.
That's a great way to put it. In type 1, the immune system, primarily the T lymphocytes, goes rogue. It mistakenly identifies the insulin-producing beta cells inside those pancreatic islets as foreign invaders, and it systematically destroys them.
When a patient gets tested for this, they often see an alphabet soup of autoantibodies on their lab chart. Things like GAD65, IA2, or ZNT8. What are those actually doing in the body?
Well, those acronyms represent the specific targets the immune system is attacking. GAD65, for example, stands for glutamic acid decarboxylase.
Say that 5 times fast.
Right. It's basically an enzyme that naturally exists inside the beta cells and is essential for them to function. But in a type 1 patient, the immune system's threat detection software glitches. It tags GAD65 as a hostile pathogen.
So the presence of these autoantibodies in the blood is basically the smoke billowing up from that autoimmune fire.
Exactly.
And there is a genetic blueprint for this glitch, right? The HLA genes?
Yes, specifically the human leukocyte antigen genes like HLA-DR3 and HLA-DR4. These genes code for the major histocompatibility complex. That is basically the immune system's threat display window.
So if you have these specific variants, your immune system is highly sensitive and prone to friendly fire.
Yeah, but genetics alone aren't enough to start the destruction. Something in the environment, very likely a viral infection like an enterovirus, appears to act as the trigger. It tips a genetically susceptible person into full-blown autoimmunity.
The terrifying part is the silent progression. By the time a patient actually starts showing symptoms like intense thirst, 80 to 90% of their beta cell mass is typically already gone.
It's staggering.
I've often heard the analogy of a factory making keys for a lock, but that feels a bit passive to me. To visualize what's actually happening at the cellular level, I like to think of a massive city transit system.
Oh, I like that.
Yeah, glucose is the passengers, and insulin is the train fleet that moves them out of the bloodstream and into the cells. Type 1 diabetes is like the city's own military bombing the train yard. It's an absolute deficiency. It does not matter what your diet is or how much you exercise, the trains are gone.
That captures the absolute nature of the deficiency perfectly. Type 2 diabetes, however, starts from the complete opposite direction. It begins with insulin resistance.
Okay, so how does that look in the transit analogy?
Well, the transit system is fully operational and the trains are running.
Yeah.
But the stations, the peripheral tissues like your muscle, liver, and fat, refuse to open their doors to let the glucose passengers inside.
The stations are refusing entry because of ectopic fat, right? But
Yeah.
I always hear that term thrown around without much explanation. How does fat actually stop glucose from getting into a cell?
To understand that, we have to look at the Randle cycle. Sometimes it's called the glucose fatty acid cycle, which was described in 1963. Ectopic fat refers to lipid storage in places it shouldn't be, primarily inside the liver and muscle cells.
So they're just getting stuffed with fat.
Right. When these cells are overwhelmed by excess circulating free fatty acids, they start metabolizing the fat for energy instead of glucose.
Which makes sense on a survival level, I guess, but what does it do to the insulin signaling?
Burning all that fat generates high levels of intracellular metabolic byproducts, specifically things like diacylglycerol. These byproducts are physically disruptive. They interfere with the insulin receptor substrate pathways.
Wait, so they just block the signal?
Pretty much. Insulin arrives at the cell membrane and binds to the receptor, swiping its badge to open the door. But the electronic signal gets scrambled by these fat byproducts. The door stays shut.
And the glucose passengers just build up in the bloodstream. So what does the pancreas do when it senses this massive crowd of glucose going nowhere?
It compensates through brute force. The beta cells pump out massive amounts of insulin to try and force the signal through. This state is called hyperinsulinemia.
That sounds exhausting.
It is. For a few years, this works. The blood sugar stays roughly normal because the pancreas is working intense overtime.
But the beta cells can't pull overtime forever. The cellular stress must be immense.
The stress is terminal, honestly. Over decades, these overworked beta cells suffer from literal chemical damage caused by chronic exposure to high glucose and high lipids. We call this glucotoxicity and lipotoxicity.
So they basically poison themselves trying to keep up.
Exactly. The oxidative stress overwhelms the cell's internal machinery until they literally undergo apoptosis-programmed cell death. The insulin secretion eventually crashes, falling far behind the massive demand. And that is when the clinical hyperglycemia emerges.
So type 2 is a relative insulin deficiency layered on top of severe resistance.
Exactly right.
This mechanical difference isn't just theory. It dictates exactly how these diseases show up in the real world. I was looking at the concordance rates for identical twins, and the split between the two diseases is fascinating.
Oh, the twin data isolates the genetic variable perfectly. If one identical twin develops type 1 diabetes, the co-twin's risk of developing it is only about 30 to 50%.
Which proves they have the exact same genetic threat detection glitch, but an external environmental trigger is absolutely required to ignite the autoimmune fire.
Yep, spot on. Contrast that with type 2 diabetes. If one identical twin develops type 2, the co-twin's concordance is commonly cited in the 70 to 90% range.
Wow, that is a massive jump.
It really is. This reflects just how heavily type 2 is driven by a shared genetic architecture for fat storage, combined with shared lifestyle and environmental factors.
This biological difference becomes a literal matter of life and death in the ER too. For the nursing students listening, the emergency presentations for these two diseases look very different because of the underlying chemistry. Let's talk about DKA versus HHS.
Good idea. DKA stands for diabetic ketoacidosis, and it is the hallmark emergency of type 1 diabetes. Because a type 1 patient has virtually zero circulating insulin, their body thinks it's starving.
Even if their blood sugar is sky high.
Yeah, because the glucose can't get into the cells. Without insulin to act as a braking system, a specific enzyme in the fat cells called hormone-sensitive lipase goes into overdrive. The fat cells release massive amounts of free fatty acids into the blood.
And the liver tries to process all that fat, right?
The liver takes those fatty acids and rapidly converts them into ketone bodies for emergency fuel. The problem is that ketone bodies are highly acidic.
So the blood turns acidic.
Right. They flood the bloodstream, overwhelming the body's natural buffering systems, and the blood pH drops dangerously low. This acidosis disrupts enzyme functions body-wide, creating a life-threatening crisis. Sometimes DKA is the very event that reveals a type 1 diagnosis in a previously healthy child.
That is so scary. But a type 2 emergency plays out entirely differently. They usually don't go into DKA because they still have that struggling train yard pumping out a tiny bit of insulin.
That residual insulin is the key difference. A type 2 patient might not have enough insulin to control their blood sugar, which can skyrocket catastrophically to 600, 800, or even over 1,000 milligrams per deciliter.
Oh my gosh. 1,000.
Yeah, it can get that high.
Right.
But that tiny trickle of insulin is usually enough to keep that hormone-sensitive lipase in check, so they don't experience the massive fat breakdown, and they don't produce significant ketones.
Instead, they present with HHS, hyperosmolar hyperglycemic state. The blood sugar is so high, it essentially turns the blood into a thick syrup.
Yeah, syrup is a good way to picture it. This hyperosmolarity pulls water directly out of the brain and surrounding tissues, leading to severe dehydration and altered mental status, but without the extreme acid buildup.
The underlying mechanism completely dictates the clinical reality you see in the trauma bay. If the mechanics dictate entirely different emergencies, the historical labels of insulin-dependent and non-insulin-dependent diabetes must have been incredibly frustrating for clinicians.
They were deeply misleading. Until 1997, the World Health Organization and the ADA classified the disease based on the treatment you were receiving.
Which tells you nothing about what's actually wrong with the patient.
Exactly. Because type 2 is a progressive disease driven by glucotoxicity, plenty of quote-unquote non-insulin dependent patients eventually require insulin therapy as their beta cells undergo apoptosis. The label said nothing about the actual disease process.
So in 1997, the ADA's expert committee formally anchored the categories to the etiology. Type 1 became the label for autoimmune destruction, and type 2 became the label for progressive insulin resistance.
And this understanding of progression really crystallized with two massive clinical trials in the 1990s, the DCCT for type 1 and the UKPDS for type 2.
Mm.
Both trials prove that keeping blood sugar as close to normal as possible dramatically reduced microvascular complications.
Okay, but how does high blood sugar actually break a blood vessel in the eyes or the kidneys?
It comes down to a process called glycation. When glucose levels are chronically high, the excess sugar molecules literally stick to the proteins and lipids that make up the walls of your blood vessels.
Wait, they just stick to them?
Yeah, this creates what are called advanced glycation end products, or AGEs.
That sounds like rust building up inside a pipe.
It functions very much like that. These AGEs stiffen the vessel walls, promotes systemic inflammation, and cause the tiny capillaries in the retina of the eye, the filtering units of the kidneys, and the linings of the nerves to physically thicken and leak. The DCCT and UKPDS trials prove that the hyperglycemia itself is what drives this structural damage.
Okay, so we've established this very logical, neat two-bucket model. Type 1 is the autoimmune destruction. Type 2 is the fat-induced insulin resistance.
Right.
But here's where we get to the cutting edge, because nature hates neat boxes, and modern science is actively taking a sledgehammer to this binary.
Oh, yeah. The two-bucket model is now openly debated inside endocrinology. The major turning point was a 2018 Swedish study published by Alquist and colleagues in the Lancet Diabetes and Endocrinology.
They didn't just look at a few basic labs, did they?
No, they applied complex cluster analysis to massive amounts of metabolic and genetic data from nearly 9,000 newly diagnosed diabetes patients.
And they didn't find two groups. They found 5 distinct clusters of the disease.
5 unique metabolic profiles. They identified a severe autoimmune cluster, which maps to our classic type 1, but then they broke the type 2 bucket into 4 separate diseases.
Wow, 4.
Yeah. They found a severe insulin-deficient cluster where patients look like they have type 2 but produce very little insulin and have a massive risk of retinopathy. They found a severe insulin-resistant cluster where patients produce plenty of insulin but have an incredibly high risk of kidney disease. And finally, they identified a mild obesity-related cluster and a mild age-related cluster.
The implication there is staggering. It means treating every quote-unquote type 2 patient the same is physiologically backward. A severe insulin-deficient patient needs a completely different pharmaceutical strategy than a severe insulin-resistant one.
Absolutely. The textbook binary is largely a simplification we've kept around for teaching and medical billing convenience. We can actually see this blurring of the lines in clinical practice right now with something called LADA.
LABA stands for latent autoimmune diabetes in adults. Some clinicians informally refer to it as type 1.5, right?
Yes. These patients test positive for the exact same autoantibodies as type 1, especially GAD65.
Yeah.
The autoimmune fire is burning, but it's burning in slow motion.
And because they are adults and they don't immediately go into DKA, they get misdiagnosed as having type 2.
This is a critical failure mode that nurses and clinicians must watch for. A lean adult comes in with elevated blood sugar. The clinician assumes it's type 2 based on age, puts them on an oral medication like metformin, and sends them home.
But metformin primarily reduces glucose production in the liver. It does absolutely nothing to stop the immune system from destroying the beta cells.
Right. Eventually, the destruction completes, and the patient absolutely requires insulin. Misdiagnosing LEA delays necessary therapy and causes immense metabolic stress.
That actually touches on one of the biggest misconceptions we need to clear up. The stereotype that type 2 diabetes only happens to overweight individuals.
Oh, that is a huge myth.
Lean people absolutely develop type 2 diabetes based on their specific genetic architecture for fat storage. If your body has a very low capacity to safely store fat in subcutaneous tissue, even a small amount of weight gain can spill over as ectopic fat into the liver and trigger the Randle cycle.
The epidemiology forces us to confront these stereotypes constantly. We saw this historically when pediatric type 2 diabetes became so common that the medical community had to retire the old name adult-onset diabetes.
Because kids were getting it.
Exactly. And we must also confront the myth that type 1 is caused by a poor diet. Type 1 has zero to do with sugar consumption. It is an autoimmune genetic roll of the dice, and the stigma around it causes needless guilt for families.
Which brings up a fascinating current debate in the medical community, the concept of reversing type 2 diabetes. We hear this a lot with the rise of bariatric surgery and extreme low-calorie diets, like those studied in the UK's DIRECT trial.
Yes, the DIRECT trial was groundbreaking.
They showed that intensive weight loss can effectively clear out that ectopic fat infiltrating the liver and pancreas, restoring normal glucose control in a substantial fraction of patients.
It is a phenomenal therapeutic advancement, demonstrating just how mechanically driven insulin resistance is. But the ADA strongly prefers the term remission over cure or reversal.
Because the genetic susceptibility to the Randle cycle hasn't gone anywhere.
Precisely. The genetic architecture remains. The beta cell capacity and the underlying insulin resistance will rapidly re-deteriorate if the ectopic fat returns, or simply as a consequence of aging. Remission acknowledges that the environmental trigger has been removed, but the underlying biology requires lifelong vigilance.
So what does this all mean for you listening? Why did we just spend 20 minutes dissecting the Randle cycle, autoantibodies, and identical twin studies?
Because understanding the mechanism is the absolute foundation of clinical relevance. If you are a nurse and you treat a type 1 patient's DKA the way you would manage a type 2 patient's HHS, or if you assume a 35-year-old lean adult can't possibly have LADA, that misunderstanding can be fatal.
Furthermore, understanding these pathways is the only way to make sense of the modern pharmaceutical revolution we are seeing. Take the blockbuster GLP-1 receptor agonists, like semaglutide.
Right. They work by mimicking incretin hormones.
Yeah, which naturally amplify the pancreas's ability to print those insulin badges in response to food. Or the SGLT2 inhibitors, which bypass the insulin system entirely and just force the kidneys to dump the excess glucose cargo directly into the urine. You cannot understand the treatments without understanding the biological machinery they're acting upon.
The pathophysiology underpins every treatment algorithm, every emergency response protocol, and how you educate your patients to take control of their own health.
I want to leave you with a final thought to mull over. Back in 1997, the medical community redefined this disease overnight. They dropped a diagnostic threshold from 140 down to 126 milligrams per deciliter, and they retired the confusing IDDM and NIDDM labels.
It was a massive shift.
Given the 2018 discovery of the 5 distinct genetic and metabolic clusters we discussed today, how long will it be before the labels type 1 and type 2 themselves become historical relics?
It's a great question.
We are on the verge of completely changing how we diagnose and treat this 3,000-year-old disease tomorrow. The next time you look at an A1C number, remember, it is just a number. It's the biological mechanism behind it that tells the true story.
Imagine for a second being an asthma patient back in the 1970s. You feel that terrifying tightness in your chest, right? The struggle to just pull air in.
Oh, it's an incredibly scary feeling.
Right. So you grab your trusted rescue inhaler, you take a puff, and within minutes, your airways open up. You feel cured.
Yeah, you feel like the crisis is over.
Exactly. But what you don't realize, and what even your doctor doesn't realize at the time, is that the very medication making you feel better is, it's quietly masking a fatal condition that's just building up inside your lungs.
It is a genuinely harrowing chapter in medical history because, when we treat only the symptoms we can easily observe while just completely ignoring the underlying invisible mechanisms, well, the consequences for patients can be catastrophic.
Yeah, catastrophic is the right word.
Okay.
So today we are taking a deep dive into the true mechanics of asthma. We are pulling from clinical nursing texts, medical history, and the latest pathophysiological research to figure this out.
It's a lot of ground to cover, but it's so important.
It really is. Whether you are prepping for a clinical exam, maybe trying to understand your own diagnosis, or you're just intensely curious about the human body, we are going to completely flip the script on what you think you know about bronchospasm, acute management, and, that famous blue rescue inhaler.
Because the story of asthma, it isn't just a straightforward medical timeline. It's really a story of how a fundamental misunderstanding of human biology shaped treatment for over a century, and how finally unlearning that misconception completely rewrote modern medicine.
Yeah, the unlearning part is wild. Our mission today is to uncover how a 19th century misunderstanding caused a modern medical crisis, and to decode what is truly happening on a cellular level inside the lungs during an acute attack.
I'm ready when you are.
Okay, let's unpack this. To understand the modern nursing approach to asthma, we have to look at how incredibly wrong we were for most of medical history.
Yeah.
Like, where does our understanding of this condition even begin?
Well, it goes back remarkably far, actually. The word asthma itself is ancient. It comes from the Greek word azein, which translates roughly to panting or, breathing with an open mouth.
Panting, that makes sense, yeah.
Right. You see it show up in the medical texts of Hippocrates around 450 BC, But there is a critical distinction in how they viewed it back then.
Oh, what?
Hippocrates used the term strictly to describe a symptom. He was describing the state of being breathless, not a distinct standalone disease.
Oh, I see. So it was just a clinical observation, sort of like a physician today is saying a patient has a fever or a cough. It tells you what is happening, but it doesn't really tell you why it's happening.
Precisely, yeah. The shift toward recognizing it as a specific mechanical condition that started later. In the 2nd century AD, there was a Greek physician named Aretaeus of Cappadocia,
Okay.
and he provided one of the first truly detailed clinical descriptions of an attack. He noticed a very specific, terrifying hallmark of asthma. The primary difficulty for the patient wasn't actually getting air in, the struggle was breathing out.
Wow. Which is such a counterintuitive detail if you aren't living it, right? Or if you aren't
Yeah,
treating
I
it
know.
clinically. You think of suffocating as not being able to draw breath into your lungs, but asthma actually traps the exhausted air inside.
Yeah, it's air trapping. It's horrible.
And just reading through the source material, it's fascinating how physicians were picking up on environmental clues centuries before they even had a word for allergen. Like there's that incredible case study from the 12th century involving Moses Maimonides.
Oh, yes. Maimonides was treating a patient who was widely believed to be the son of Sultan Saladin. He wrote an entire medical treatise on asthma specifically for this young man.
Just for him. Wow.
Yeah, and his recommendations included dietary changes, relocating to find clean air, and avoiding damp climates. So he had an intuitive, practical grasp of environmental triggers long before the concept of the immune system was even established.
That's brilliant for the 12th century. And then if you jump forward to like 1698, we get Sir John Floyer, an English physician who actually suffered from asthma himself.
Yes, the self-observation era.
Right. He kept these meticulous diaries of his own attacks and realized they followed a diurnal pattern, meaning his symptoms were consistently worse at night. So he was essentially performing early trigger identification on himself. But all of this observational progress hits a massive roadblock in 1860, doesn't it? This is the turning point that set us on the wrong path for over a century.
It really is. So in 1860, a physician named Henry Hyde Salter published a highly influential book defining asthma fundamentally as a disease of bronchial muscular spasm.
Just the muscles.
Right. He proposed this idea of nervous bronchoconstriction. And, I mean, to be fair to him, based on the tools he had at the time, it made sense. The airways were constricting, so the muscles wrapping around them must be the problem.
Sure, you see a pipe squeezing shut, you blame the clamp.
Exactly. And for over 100 years, that became the gospel truth in medicine. Asthma was viewed operationally as just a muscle problem. The airway muscles were just twitchy and irritable.
And naturally, if you believe the root cause of a disease is just a muscle spasm, well, your entire treatment protocol is going to be focused on forcing that muscle to relax.
That was the logic, yeah. Bronchodilators, which are medications designed specifically to relax smooth muscle, they were considered both the diagnostic tool and the cure. That muscle-centric model completely dominated the field until the late 1980s and early 1990s.
Which is when researchers like Stephen Holgate and Peter Barnes in the UK started looking at actual bronchial biopsies, right?
Yes, and what they found under the microscope completely shattered that 1860 model.
What did they see?
Well, they looked at patients who had very mild asthma, patients who were perfectly well controlled and had zero symptoms at the exact time of the biopsy. But when they looked at the tissue, their airways showed persistent, active eosinophilic inflammation and thickening of the airway wall.
Wow. So even when they felt fine, their lungs were inflamed.
Exactly. It was a massive paradigm shift. It forced the medical community to basically reclassify asthma from the ground up. The underlying pathology wasn't a muscle disease at all. It was fundamentally a chronic inflammatory disease. And the bronchospasm, that twitchy muscle, was just a downstream symptom of that persistent inflammation.
I have to admit, I was so surprised reading this. I mean, for over a century, the medical consensus was essentially just twitchy muscles. So
Yeah.
we were basically treating a chronic smoldering fire in the lungs as if it was just a faulty smoke detector going off.
That is the perfect analogy, and that exact redefinition from a muscle problem to an inflammatory disease where the bronchospasm is just the alarm bell ringing completely revolutionized modern acute management.
Changes everything about how you treat it.
It really does. It's the reason why the Global Initiative for Asthma, or GINO, rewrote global treatment algorithms in 1993, firmly shifting the primary focus to inhaled corticosteroids as the necessary daily controller therapy to, actually put out out the fire.
So if asthma is actually this smoldering inflammatory fire masquerading as a muscle problem, we need to break down exactly what happens in the airway to cause an attack. The nursing texts describe this as a mismatch between airway tone and what the airway should be doing. Let's look at the actual physiological timeline here.
Let's do that. So, in a healthy person, the smooth muscle wrapping around the bronchi, which are the tubes carrying air into your lungs, maintains a baseline tone.
A normal level of tension.
Right. If you inhale a mild irritant, that muscle might constrict modestly to protect the deeper lungs, and then it just relaxes. But in an asthmatic airway, you have a dysfunctional cascade that happens in distinct overlapping layers. The first layer is the immediate reaction, bronchospasm.
The fast component.
Yes, the fast component.
Yeah.
The airway smooth muscle contracts aggressively and excessively in response to a trigger. That could be cold air, pollen, exercise, you name it. It physically narrows the airway lumen, which is the central space the air flows through. This is the fast, reversible component of an attack.
And if you were holding a little blue rescue inhaler right now, this is exactly what it is designed to fix. When you take a short-acting beta-2 agonist like albuterol, it goes to work in minutes. But I want to pause here because the mechanism is fascinating.
Oh, it really is.
The sources say it binds to beta-2 adrenergic receptors on the smooth muscle, which raises intracellular cyclic AMP or CAMP. Can we break that down? What is CAMP actually doing in there?
Sure. Think of CAMP as an internal cellular messenger. When the albuterol molecule docks onto the receptor on the outside of the muscle cell, it triggers the production of CAMP inside the cell.
Okay, so it sends a signal inward.
Right. And that CAMP messenger basically runs through the cell shouting, "Relax, stand down." It chemically interrupts the contraction process, forcing the muscle to loosen its grip on the airway.
The pipe is unclogged, and the patient can breathe again. But here's where it gets really interesting. That muscle spasm is just the outer layer, right? The second layer of this condition is the inflammation itself.
Exactly. This is the slow, silent component. Let's look at the most common type, the allergic phenotype of asthma, which is often called type 2 high. When you are exposed to an allergen, your immune system overreacts. It activates specific immune cells called T helper 2 cells.
Okay, the T cells wake up.
Yeah. And these cells sound a biochemical alarm by releasing a flood of messenger proteins called cytokines, specifically interleukin-4, interleukin-5, and interleukin-13.
Wait, interleukins are those the actual signals calling for backup?
Exactly. They're basically chemical text messages sent to the rest of the immune system. And the specific backup they call in are eosinophils.
Eosinophils, okay?
Yeah, eosinophils are a type of white blood cell designed to fight off massive threats like parasites. They are packed with toxic granules. But in asthma, they arrive in the airway and release those toxins unnecessarily, causing immense collateral damage to your own lung tissue.
Man, so the body is essentially carpet bombing its own airways just to fight off pollen. And the sources note these cytokines also stimulate B cells to produce IgE antibodies, which prime the body to overreact even faster next time.
Yes, it creates a vicious cycle of sensitivity.
Plus, they send the mucus glands into overdrive, creating thick, sticky mucus that physically plugs up the smaller airways.
And you cannot undo that complex immune cascade in 3 minutes with a puff of albuterol. You just can't. You need an entirely different class of medication, inhaled corticosteroids, taken every single day as a controller to penetrate the tissue and tell those T cells and eosinophils to stand down. What's fascinating here is the stark contrast in speed and feedback.
How so?
Well, you have a patient experiencing instant life-saving relief from the rescue inhaler, right? While the controller medication operates invisibly on a cellular level over days and weeks with absolutely no immediate sensory payoff.
Right, you don't feel a steroid working instantly.
Yeah.
That disconnect between how a medication feels and what the disease is actually doing is crucial, especially because it leads right into the third layer of this condition, which is airway remodeling.
The permanent consequence.
Yeah. If a patient just uses the fast rescue inhaler to feel better today and ignores the slow inflammation, years of that unchecked immune carpet bombing will permanently damage the architecture of the lung.
It leads to severe structural changes. The smooth muscle we talked about hypertrophies.
Which means it bulks up, right? Like a bodybuilder.
Yes, exactly.
Yeah.
The muscle cells literally enlarge and multiply from the constant working and spasming, making the airway permanently thicker and narrower. Additionally, the basement membrane, which is the foundational layer of connective tissue that the airway lining sits on, becomes thick and stiff. Blood vessels in the airway walls proliferate and become engorged.
So the airflow obstruction slowly becomes less and less reversible over time. Using that daily controller inhaler isn't just about reducing symptoms this week. It is about preventing permanent architectural scarring of your lungs over a lifetime.
And if we don't effectively communicate the difference between the fast spasms and the slow inflammation to patients, the results can be fatal.
Which transitions us to the most sobering part of our deep dive. We have concrete historical examples of what happens when the medical field gets this balance wrong. Let's talk about the phenobarbital story in New Zealand in the 1970s and 80s.
It remains a deeply tragic public health lesson. During that period, an epidemiologist named Neil Pearce and his colleagues began documenting a sharp, highly alarming spike in asthma-related deaths across New Zealand.
A sudden spike, out of nowhere.
Pretty much. And after rigorous investigation, they traced the mortality spike back to the introduction and heavy marketing of a specific drug called phenobarbital,
Which was a very potent, short-acting rescue inhaler, a powerful bronchodilator.
a massively powerful one. Patients and physicians were using this bronchodilator as their primary and often sole treatment. The medication was so remarkably good at forcing the airway muscles to relax that patients felt completely fine.
They thought they were cured.
Yeah, they felt their asthma was controlled. But the underlying eosinophilic inflammation was completely unmedicated. It was quietly worsening every single day. They were masking the disease, attack after attack, until the inflammation became so severe and the mucus plugging so dense that the inhaler could no longer force the airway open, resulting in fatal attacks.
It's horrifying. They were using a chemical crowbar to hold the door open while the house burned down. And when phenobarbital was heavily restricted, the death rate plummeted back down, right?
Almost immediately, yes.
But what's truly wild is that the exact same phenomenon had already happened in the United Kingdom in the 1960s with a different high-dose beta agonist called isoprotronol.
Exactly. The medical field simply didn't institutionalize the lesson the first time around.
Imagine the psychological terror of that for a patient. You reach for the very medication designed to save you, the one that has always worked in minutes, only to find out it's actively masking a fatal condition. How did the broader medical community miss the inflammation piece for so long when people were actively dying?
It ultimately comes down to a behavioral trap created by human nature and pharmacology. Because the rescue inhaler feels like a cure, it provides this undeniable instant relief from a terrifying sensation of suffocation. It creates an incredibly powerful behavioral feedback loop.
Cause and effect.
Yeah.
I take this, I feel better.
Right. Patients naturally over-relied on the bronchodilator because they could physically feel it working. Conversely, they ignored the inhaled corticosteroids because taking them felt like breathing regular air. The medical community missed it because for a long time they were looking at symptom relief, the relaxed muscle, as the ultimate endpoint of treatment, rather than disease control.
And remarkably, we had to learn this lesson again as recently as 2003 with the SMART trial, the salmeterol multi-center asthma research trial. They were studying salmeterol, which is a long-acting beta agonist, or LAB.
Right.
It works like albuterol, but it keeps the muscle relaxed for 12 hours. But the trial revealed a real statistically significant increase in asthma-related deaths and life-threatening experiences when patients took it without a background corticosteroid.
They actually had to halt the trial early because the safety signal was so dangerously clear. It forced the FDA to issue a strict boxed warning, mandating that LABAs can never be prescribed as a monotherapy for asthma. They must always, without exception, be paired with an inhaled corticosteroid to treat the inflammation simultaneously.
So we've explored the internal mechanics of the disease, and we know how dangerous mismanagement can be. Let's look outside the body for a moment. What actually kicks off this inflammatory cascade in the real world? Because environmental triggers can be terrifyingly unpredictable. The sources highlight the thunderstorm asthma event in Melbourne, Australia in November 2016.
That event is a staggering demonstration of how the environment interacts with human physiology. It was peak grass pollen season. A severe thunderstorm rolled into Melbourne, bringing massive updrafts, gusty winds, a sudden plunge in temperature, and a dramatic increase in atmospheric moisture.
And that moisture is the key, right? Because normally, intact ryegrass pollen grains are relatively large. If you inhale them, they just get trapped in the mucosal lining of your nose, which causes standard hay fever. But how do they end up deep in people's lungs?
It was caused by a fascinating physical process called osmotic shock.
Osmotic shock.
Yeah, when that sudden storm hit, the intense humidity caused those large pollen grains to rapidly absorb water. They swelled up until they literally burst open, shattering into thousands of microscopic allergenic fragments.
Oh, wow. And then the storm's downdrafts swept those microparticles back down to street level. Because they were now so microscopically small, they completely bypassed the body's upper airway defense mechanisms. They penetrated deep into the lower airways of almost anyone who was outside.
It was immediate. Within a matter of hours, emergency departments across the entire city of Melbourne were completely overwhelmed.
Thousands of people were suddenly in severe respiratory distress. And this is the most alarming part. Many of these people had absolutely no prior asthma diagnosis.
Exactly. They had no idea.
They thought they only suffered from seasonal hay fever. A routine thunderstorm triggered a mass casualty event, and multiple people tragically lost their lives.
If we connect this to the bigger picture, the Melbourne event isn't just an isolated freak occurrence, it is a profound warning about climate change. The data shows we are seeing longer and vastly more intense pollen seasons. We are seeing altered, more volatile storm patterns capable of creating these exact thunderstorm asthma events, and we are seeing exponentially more frequent wildfire smoke events.
And it is crucial to note from the sources that this environmental burden isn't shared equally. Urban, lower income, and minority populations bear a disproportionately higher rate of severe asthma and hospitalization.
For sure.
It's intrinsically tied to higher baseline air pollution, poor housing conditions that harbor mold and pests, and deeply unequal access to those vital daily controller medications.
It is a profound environmental justice issue. The environment physically shapes the prevalence of the disease. We also see this broad environmental concept in the ongoing medical debate around the hygiene hypothesis, which was first proposed by epidemiologist David Strachan back in 1989.
Right, his famous BMJ paper.
Yeah.
He noticed a fascinating correlation, didn't he? Children who grew up with a lot of older siblings generally had much lower rates of hay fever and allergic asthma.
His initial theory was that smaller families and increasingly hygienic, sanitized modern environments severely reduced childhood exposure to everyday infections. Without those early microbial challenges, the developing immune system remains undertrained and bored, essentially.
Bored immune cells.
Yeah, so it defaults to a type 2 skewed allergic response, attacking harmless things like pollen or dust mites just for something to do.
Though the modern scientific nuance has shifted a bit, right? It's less about needing to roll around in dirt to catch infections and more about the microbiome. The old friends framing the idea that our immune systems evolved alongside diverse, non-pathogenic microbes, and we need exposure to them early in life to properly calibrate our immune responses.
Exactly. While the exact mechanisms are still heavily researched and debated, it remains a crucial framework for understanding why allergic diseases have skyrocketed so sharply in industrialized nations over the last century.
Okay, let's zoom back into the clinical setting. Because if you are a nursing student learning this, a practitioner, or just someone managing this disease at home, there are some incredibly dangerous myths we need to clear up based on our sources.
Oh, absolutely.
Let's start with misconception number 1, the silent chest. Imagine you're observing a patient having a severe asthma attack. They're wheezing loudly, struggling to breathe, and then suddenly the wheezing stops. Their chest is completely quiet.
And basic human instinct says, quiet is good. The wheezing stopped, so the medication must be working, and they are getting better. In reality, a silent chest during an acute attack is a catastrophic medical emergency.
Why? What is actually happening in the airway?
It means the airflow obstruction has become so profound, the airway is so incredibly tight and plugged with mucus that there isn't even enough air moving back and forth to generate the sound of a wheeze. The silence doesn't mean the airway is open, it means the airway is entirely closed.
It's chilling. A lack of noise literally means a lack of air. Misconception 2, the idea that kids fully outgrow asthma.
It is true that many children enter a state of clinical remission by adolescence and they stop experiencing any day-to-day symptoms. But longitudinal studies show that subclinical hyperresponsiveness, that underlying invisible immune sensitivity in the airway tissue, can quietly persist into adulthood.
Just waiting.
Exactly. And it can roar back to life decades later, often triggered by a new environmental exposure or a severe respiratory viral infection.
Which brings us to the cutting edge of how we treat this today. We've talked a lot about the allergic immune response, but asthma is no longer considered one disease. So what does this all mean for the future of treatment?
It means we have to treat asthma as an umbrella term. In modern medicine, we differentiate between what a disease looks like on the outside, its phenotype, like wheezing and coughing, and the actual biological mechanism causing it on the inside, which is the endotype. We now know there are multiple distinct endotypes hiding under the asthma umbrella.
Right, so you have the allergic type 2 high asthma we've discussed, which is driven by eosinophils. But the sources also detail type 2 low asthma. This is driven by an entirely different white blood cell called a neutrophil, which is typically a general infection fighter.
Right.
And importantly, neutrophilic asthma responds very poorly to standard inhaled corticosteroids.
And this realization that we are dealing with different cellular drivers led to the development of biologic drugs. Instead of just throwing a general blanket anti-inflammatory steroid at the lungs, we can use monoclonal antibodies. These are highly specific, lab-engineered proteins.
How do they work compared to a steroid?
Rather than reducing overall inflammation, biologics act like molecular sponges or interceptors. Take a drug like omalizumab, which specifically hunts down and neutralizes IgE antibodies before they can trigger an allergic response.
Oh, wow.
Or drugs like mepolizumab, benralizumab, and dupilumab. They specifically target those cytokine text messages we talked about earlier, interleukin-5 and interleukin-4 and 13. They intercept the message before the eosinophils even get the call to attack.
This raises the bar for how precise medicine can be. We are stopping the cellular domino effect before the first piece even falls.
This raises an important question for the future of respiratory medicine as well. If asthma is an umbrella, we have to be incredibly precise in how we diagnose it compared to other conditions. For instance, comparing asthma to COPD, chronic obstructive pulmonary disease.
Right, because they both cause severe airflow obstruction.
They do. But asthma is classically defined by its reversibility, whereas COPD involves a largely fixed, permanent obstruction and alveolar destruction, usually resulting from long-term smoking.
Yet, while they are different diseases, the treatments sometimes overlap in fascinating ways. Speaking of unexpected overlaps, I have to mention the COVID-19 connection from the pathophysiological research.
Oh, the StudyGuide study.
Yeah. During the height of the pandemic, researchers ran the StudyGuide study in Oxford. They found that inhaled budesonide, which is a standard everyday asthma controller medication, actually reduced the likelihood of patients needing urgent care for COVID-19 if it was administered early in the infection.
It perfectly highlights how deeply interconnected our immune pathways are. A century-old asthma drug class crossing over to suppress the inflammatory cascade of a novel virus. It shows that when you understand the underlying mechanism of inflammation, you can find surprising benefits across entirely different diseases.
So to pull all of this together for you listening, we have journeyed from ancient Greek physicians observing patients panting in the Mediterranean through the completely avoidable tragedy of the phenotyral crisis in New Zealand to the microscopic ryegrass pollen shattering from osmotic shock in a Melbourne thunderstorm. And the undeniable life-saving through line of all this research is this asthma is fundamentally a chronic inflammatory disease, not just a simple muscle spasm.
And understanding that vital distinction isn't just academic trivia for a textbook.
No, absolutely not. Whether you are prepping for a nursing exam, managing your own inhaler at home, or you are just deeply curious about human physiology, understanding the why behind the rescue inhaler versus the controller medication could literally save a life, especially if it helps you recognize the terrifying reality of the silent chest.
It truly is a triumph of modern medicine that we've decoded these underlying cellular pathways, but it leaves us with a fascinating, slightly unsettling thought to mull over.
Let's hear it.
If asthma, one of the most common, seemingly straightforward diseases in human history, turned out to be an umbrella term for several entirely different immune dysfunctions, just masquerading behind a shared symptom, how many other common diseases that we treat as a single illness today are actually just shared symptoms hiding completely different conditions?
It makes you wonder how many other simple plumbing issues in medicine are actually complex, smoldering fires, just waiting for us to finally notice the smoke. Imagine for a second that you are, well, in absolute peak physical condition.
Right, like you're a professional athlete at the top of your game.
Yeah, exactly. Maybe even a gold medalist. And you undergo this fairly routine foot surgery, and the operation goes perfectly. You go home to rest. But then, days later, you find yourself struggling to breathe, literally fighting for your life in an emergency room.
And it's not because of an infection or anything like that.
Exactly. No infection. You didn't tear a muscle.
Oh,
You were being taken down by something completely invisible. It's this microscopic threat that formed entirely because you did exactly what you were told to do.
Which is to stop moving.
Right. You stop moving.
It's honestly one of the most counterintuitive paradoxes of the human body. I mean, we are conditioned from childhood to believe that resting is the ultimate form of healing.
Right. You get hurt, you go to bed.
Exactly. But in the context of human circulation, absolute rest can actually be the very trigger for a catastrophic medical event.
And that is the exact paradox we are diving into for you today. Welcome to the Deep Dive. We have this fascinating stack of sources in front of us today. We've got nursing protocols, some wild historical medical cases, and modern clinical trial data.
It's a really comprehensive pile.
It is. And our mission today is to explore this concept, the clot that forms when you stop moving. We are talking about deep vein thrombosis, or DVT. So, okay, let's unpack this.
Let's do it.
Looking at these sources, they draw a very hard line between different types of veins. What exactly is a DVT, and why is it so much more dangerous than just getting a bruise or a surface-level clot?
Well, the distinction is purely anatomical, but it really makes all the difference in the world. A deep vein thrombosis is a blood clot, or a thrombus, that forms inside one of the body's deep veins.
So, like where exactly?
Typically, these are buried deep inside the muscle of your calf, your thigh, or your pelvis. So if you think of the veins just under your skin as small, winding side streets.
Okay, side streets.
Right. If a clot forms there, yeah, it's painful, but it's relatively contained. The deep veins, on the other hand, are the massive high-speed return highways.
Oh, wow.
Yeah, they're responsible for channeling huge volumes of oxygen-depleted blood directly back to the right side of your heart and then immediately into your lungs to get reoxygenated.
Which means if a clot forms on that high-speed highway, there is no detour.
None at all.
If a piece of that clot breaks off, like it embolizes, right? It has a straight, unobstructed shot right into the heart and then into the pulmonary arteries.
Exactly. And when it lodges in the lungs, it completely blocks blood from picking up oxygen.
Right.
That is what we call a pulmonary embolism, or PE.
And that can be instantly fatal.
It can. In modern clinical practice, doctors actually don't even view DVT and PE as separate diseases anymore.
Really?
Yeah, they group them together under the umbrella term venous thromboembolism, or VTE, because honestly, they're just two stages of the exact same disease process. The clot forms in the leg, and it basically finishes its destructive journey in the lung.
Wow. So the entire goal of modern medicine, and really the main through line of all the nursing protocols in our sources today, is early recognition and prevention.
Prevention is everything here.
It's about understanding that something as basic as, bending your knees and walking is literally a matter of life and death. But to figure out how to stop these clots, we first need to understand the blueprint of how they form.
Right.
And reading through these historical documents, I was genuinely stunned to see that the prevailing theory on this isn't from modern times at all. It's from the 19th century.
Yeah, it's pretty wild. Despite all our advanced MRIs and, genetic sequencing, the foundational framework for understanding blood clots was actually established way back in 1856.
1856.
It's incredible. By a German physician and pathologist named Rudolf Virchow. He basically proposed that for a clot to form inside a blood vessel, one of three specific conditions had to be met.
And this is Virchow's triad.
Exactly. We still call it Virchow's triad today. It is literally the first thing taught in every single medical and nursing school when covering this topic.
So let's break those three conditions down because they really dictate everything else we are going to talk about today.
Okay, so the first pillar of the triad is stasis.
Which means?
This is simply blood flow slowing down to a crawl. The second pillar is endothelial injury, which means physical damage to the smooth, delicate inner lining of the vein itself.
Okay, stasis and injury.
Right. And the third is hypercoagulability. That's a systemic state where the blood's chemistry is altered. So it makes the blood fundamentally primed and eager to clot even when there is no physical bleeding to stop.
Okay, I want to linger on that first pillar for a second, stasis, because it really highlights the mechanical engineering of our bodies.
Oh, absolutely.
If you think about the blood in your legs, it has a massive problem to overcome, which is gravity. It has to travel all the way from your ankle back up to your chest. And your heart alone just isn't strong enough to suck that blood upward.
No, it's not. So your body relies on your leg muscles, specifically the calf muscle pump. The soleus muscle in the calf is actually often called the second heart for exactly this reason.
The second heart. I love that. It's basically a biological plumbing system. Every time you take a step, that calf muscle contracts and physically squeezes the deep veins, just shooting the blood upward. And then these little one-way valves inside the vein snap shut so the blood doesn't fall back down. But when that pump is turned off, like when you are immobilized in a hospital bed or sitting at a desk for 12 hours, the blood just pools.
It just sits there.
Right. If a plumbing pipe has a fast-flowing river of water, it stays clean. But if the water stops waiting, All the heavy sediment, the debris, the clotting factors, they all start to settle against the walls of the pipe.
And that sediment settling triggers a microscopic chain reaction.
Yeah.
And that cascade is dramatically accelerated if you introduce the second pillar, which was endothelial injury.
So physical damage to the pipe itself.
Exactly. If you undergo surgery like a knee replacement, or if you suffer trauma in a car accident, the lining of your vein is damaged. When that lining breaks, it exposes a protein underneath called tissue factor.
Tissue factor.
Yeah, and tissue factor is basically a biochemical alarm siren. It screams to the rest of the body, hey, we're bleeding, send the clotting crew right now.
Wow.
So even if the bleeding is purely internal, a clot will rapidly build at that exact site of injury.
So, I mean, if your pipes are flowing and the pipes aren't physically damaged, you should be completely safe from a clot, right?
Well, you'd think so.
Right, but that brings up the third part of the triad, hypercoagulability. Because what if the fluid running through the pipes is genetically primed to basically turn into sludge?
Exactly. Sometimes the blood itself is the core problem. Our sources highlight a condition called Factor V Leiden. It was identified in the mid-90s, and it's a genetic mutation that essentially breaks the off switch for blood clotting.
The off switch.
Yeah, so people with this mutation create clots much faster than their bodies can dissolve them. But the thing is, hypercoagulability doesn't have to be genetic. You can acquire it.
How does that happen?
Things like active cancer, systemic inflammation, or severe obesity can all basically dump chemicals into your bloodstream that lower the threshold for clotting.
And looking at this 165-year-old triad, it completely destroys the modern stereotype we have about who actually gets a DVT.
Oh, completely.
I think the average person assumes this is a disease strictly for the elderly or maybe someone confined to a nursing home. But Virchow's triad proves that age is entirely irrelevant if those conditions are met.
The triad does not care how young you are. It doesn't care how fast you can run a marathon. If the scales tip, a clot forms, period.
The story of David Bloom in our sources is just a heartbreaking example of this. He was this incredibly prominent, dynamic NBC News correspondent. And in 2003, during the invasion of Iraq, he was embedded with U.S. forces.
Right.
He was only 39 years old. But he spent days folded up with his knees to his chest inside this cramped Bradley fighting vehicle just bouncing across the desert.
He had almost no ability to extend his legs or activate that calf muscle pump we talked about. The stasis was absolute.
The pump was turned off, the sediment settled, and a massive DVT formed. And it eventually embolized into a fatal pulmonary embolism. I mean, he wasn't elderly, he wasn't sick. It was pure stasis-driven thrombosis caused entirely by his environment.
And we see this phenomenon regularly at the extreme opposite end of the health spectrum, too, like in elite professional athletes.
Right, going back to the surgery example.
Yeah, the tennis legend Serena Williams developed a life-threatening pulmonary embolism following foot surgery in 2011. And she was arguably in the top fraction of a percent of human physical fitness.
Truly peak condition.
But the physical trauma of the surgery created endothelial injury, and the prescribed recovery period created stasis. So 2 pillars of the triad were met, and her incredible fitness just couldn't stop the clot.
Chris Bosh is another prime example from the sources. He was an NBA All-Star, constantly moving, but his career was tragically cut short by recurring blood clots.
Yeah, he had an underlying hypercoagulable state.
So you combine that with the constant microscopic physical trauma of professional basketball and the endless hours sitting on airplanes, and boom, you trigger the triad.
Exactly. And if we connect this to the bigger picture, the realization that prolonged stillness is deadly forces us to look back at medical history with a lot of horror.
Oh, totally.
Because for a very long time, the medical establishment was prescribing the exact thing that was killing people.
The era of strict bed rest. Reading these older protocols, it is wild how universal it was.
It was the standard for everything.
Right. For much of the 20th century, if you had a baby, you were on strict bed rest. Heart attack, weeks of bed rest, surgery, do not move a muscle.
The logic was that a recovering body needed to conserve every single ounce of energy to heal tissue, and moving might, rip open surgical stitches.
It was incredibly intuitive logic at the time.
It was. But the outcomes data eventually revealed an absolute disaster. Doctors were noticing horrifying rates of sudden death in patients who seemed to be recovering perfectly from their initial surgeries.
And they didn't know why.
Not at first. It took decades of autopsies and outcome tracking to realize that the bed rest was allowing massive clots to form in the deep veins. Orthopedic surgeons were actually some of the very first to sound the alarm on this, particularly as joint replacements became more common in the mid-20th century.
Because replacing a hip or a knee is basically a worst-case scenario for the triad,
Oh,
right?
yeah.
You have massive bone and tissue trauma causing endothelial injury, plus the patient can't walk.
Precisely. The DVT rates in early orthopedic surgeries were astronomical, and this realization forced one of the most profound paradigm shifts in modern nursing and medicine.
Right.
Immobility went from being a prescribed treatment to a recognized pathogen. Today, if you wake up from a major surgery, a nurse is likely going to have you standing up and shuffling down the hallway within hours. Early mobilization is now the ultimate protective standard.
But wait, let me push back on that for a second.
Sure.
If getting up and moving is the cure, if activating the calf muscle pump sweeps the sediment away, why do the nursing protocols in our sources still mandate heavy blood thinners for patients in the hospital?
That's a great point.
I mean, if I am walking the halls, why are they injecting me with anticoagulants? Doesn't the walking basically cancel out the need for the drugs?
It raises an important question, but the flaw in that logic goes right back to Virchow's triad. You cannot view the triad as a single problem with a single solution.
Ah, okay.
Walking down the hallway absolutely solves the stasis problem. But what if you just had major abdominal surgery? You still have immense endothelial injury that is actively calling for clotting factors. Or what if you are hospitalized for cancer treatment? Your blood is still hypercoagulable.
So the movement only fixes 1/3 of the blueprint.
Yes, exactly. Walking cannot fix a chemical imbalance or a torn vein lining, and that is why mechanical prophylaxis like walking and chemical prophylaxis like blood thinners are not substitutes for one another.
They work together.
They do. Medications like heparin or the newer direct oral anticoagulants work synergistically with movement. The movement keeps the blood flowing, and the medication alters the blood chemistry to raise the threshold for clotting, preventing that tissue injury from triggering a massive response.
Okay, so what does this all mean for things like compression socks? Because for years, the conventional wisdom was just to put tight stockings on immobilized patients to keep the pressure up and prevent stasis.
Right.
It seems like a perfectly logical physical solution, right?
It does seem logical, and for decades, graduated compression stockings were used as this blanket preventive measure for almost everyone in a hospital bed. But the medical community eventually learned that you cannot just slap a mechanical Band-Aid on a complex system without testing it rigorously.
And that's where the Seal Oates trial comes in.
Exactly. The UK CLOTS trial in the 2000s completely upended this assumption.
So what did the trial actually test?
They looked specifically at stroke patients. Now, stroke patients are highly vulnerable to DVT because they often suffer from paralysis and simply cannot move their legs.
So ultimate stasis.
Right. The researchers assumed thigh-length compression stockings would artificially squeeze the veins and prevent clots, but the data showed the exact opposite of what they hoped.
Wait, really?
Yeah. Not only did the stockings fail entirely to reduce DVT rates in these stroke patients, but they also actively caused harm. The constant tight pressure on fragile skin led to terrible ulcers, skin breakdown, and even restricted arterial blood flow.
Oh man, that is a massive backfire. Trying to passively squeeze the leg ended up causing a whole new set of injuries.
It forced a total reevaluation. It taught clinicians that you just cannot apply a universal passive fix to every single patient. Prevention requires an active, tailored approach based on individual risk factors, not just handing out tight socks.
And the urgency of getting that prevention right is magnified by how sneaky these clots actually are. Because even with early walking and even with blood thinners, a clot can still form.
They absolutely can.
And the most terrifying detail in these sources isn't just that they form, but that they often form in complete silence. There is this huge misconception that a DVT will always present as this massive, red, swollen, throbbing leg.
And that expectation is incredibly dangerous. While a classic DVT certainly can cause swelling and pain, a huge percentage of them are completely asymptomatic.
Just zero symptoms.
Zero. Or the symptoms are so mild, just a vague ache or a feeling of heaviness, that a patient will completely dismiss it as a muscle cramp or a pulled hamstring.
Wow.
Very frequently, the absolute first sign that someone has a DVT is when a piece of it breaks off, travels to the lungs, and they suddenly collapse with crushing chest pain and shortness of breath.
The silent nature of the disease is just deeply unsettling. But historically, that silence has also served as a very dark warning sign for other hidden diseases. There was a story in our sources about Armand Trousseau, a French physician in 1865.
Trousseau is a fascinating figure. He was a brilliant diagnostician studying thrombophlebitis, which is basically inflammation and clotting in the veins. And during his practice, he noticed a very strange pattern in a subset of his patients.
What did he see?
They would develop unexplained blood clots that would appear in one leg, resolve, and then spontaneously appear in an arm or the other leg.
Okay, so just popping up everywhere.
Right. These migrating, recurring clots were happening without any obvious stasis or injury.
So he realized he was looking at severe hypercoagulability.
Yes, and he made a groundbreaking connection. He discovered that this specific pattern of migrating clots was often the very first visible symptom of an occult or hidden visceral cancer, most notably stomach or pancreatic cancer.
Because the tumor is changing the blood.
Exactly. The tumor itself was secreting chemicals that threw the clotting cascade into absolute overdrive. Today, this phenomenon is still taught in medical schools as Trousseau's sign of malignancy.
But the truly chilling part of the story is how his research ended.
It is incredibly tragic, honestly. Just 2 years after publishing his findings in 1867, Trousseau felt a strange ache in his own body. He observed his own veins and saw the very pattern of migrating blood clots he had just documented.
Oh my God.
Yeah, because he wrote the paper on it, he knew instantly what it meant. He used his own physical symptom to diagnose himself with advanced pancreatic cancer, and he succumbed to the disease just months later.
The clots were the smoke and the hidden cancer was the fire. It is an amazing testament to the power of clinical observation. But obviously, how we look for that smoke has evolved a lot, because back in the 1940s, a doctor trying to figure out if you had a clot would basically just physically squeeze your leg.
You were talking about Hohmann's sign.
Right. The old bedside test where the doctor forcibly flexes your foot upward toward your shin to see if it causes deep pain in your calf.
Yeah, it was the gold standard physical exam for decades. But modern medicine completely abandoned it, and for very good reason. First of all, it is essentially useless from a diagnostic standpoint.
Because almost anything can make your calf hurt when you stretch it like that, right?
Yeah.
Like a cramped muscle or a ruptured cyst.
Exactly. The sensitivity and specificity are terrible. But more importantly, performing Hohmann's sign is actively dangerous.
How so?
Think about the mechanics. You have a fresh, gelatinous blood clot precariously clinging to the wall of a vein. Then a doctor comes along and aggressively stretches and squeezes the muscle surrounding that vein.
Oh, no.
Yeah, the physical manipulation can actually dislodge the clot right then and there, causing the exact pulmonary embolism the doctor is trying to diagnose.
It's literally squeezing a live bomb to see if it's ticking. So Hohmann's sign is out. Today, clinicians use a much more sophisticated algorithm. Our sources highlight this three-step pathway. First, instead of guessing, they use the Wells score, which is basically a strict mathematical checklist.
Right.
It assigns points for things like recent surgery, swelling, or cancer history to determine the mathematical probability that a clot is present. Then, they use a D-dimer blood test.
The D-dimer is fascinating. When a clot forms, your body immediately starts trying to break it down. As the clot degrades, it sheds these microscopic protein fragments into the bloodstream.
And the test looks for that.
Exactly. The D-dimer test detects that specific biochemical wreckage. So if the D-dimer is completely negative, you can be fairly certain there is no active clotting going on.
But if it is positive, you move to the ultimate tool, which is the compression ultrasound. It uses sound waves to actually visualize the blood flowing through the deep veins in real time. And here's where it gets really interesting, because this advanced ultrasound technology actually sparked a massive ongoing debate in the medical community.
It absolutely did.
Yeah.
Before ultrasound, a clinical DVT was just a DVT, and it was treated aggressively. But ultrasounds became so sensitive that doctors could suddenly pinpoint exactly where the clot was located.
Right.
This created a new anatomical distinction. They asked, was the clot proximal, meaning high up in the large veins of the thigh or pelvis? Or was it distal, meaning it was tiny and isolated solely in the deep veins of the calf?
And that matters, because a clot in the calf has a much longer, more difficult journey to get to the lungs than a clot in the thigh, right?
Precisely. The data eventually showed that distal calf clots have a remarkably low rate of embolizing. In fact, the body's natural enzymes often just dissolve them over time without any medical intervention whatsoever.
Wow.
And this realization caused a massive fracture in standard protocols. Historically, the moment a clot was found anywhere, the patient was put on powerful blood thinners for months, but blood thinners carry a significant risk of severe internal bleeding.
So doctors started asking, like, are we risking a brain bleed to treat a tiny calf clot that might never cause a problem.
Exactly. This led to a controversial new approach called watchful waiting for isolated distal clots.
Watchful waiting.
Right. Instead of prescribing dangerous anticoagulants, some clinicians now opt to simply perform serial ultrasounds every few days. They just watch the clot. If it doesn't grow or move upward toward the thigh, they never medicate it.
That's a huge shift.
It was considered medical heresy 20 years ago, and professional hematology guidelines are honestly still actively debating exactly when to treat and when to watch.
It shows just how incredibly nuanced our understanding of blood clotting is becoming. And that nuance isn't just for hospital wards. It applies to all of us living our daily lives. Because the triggers for Virchow's triad are hiding in our everyday routines. For example, economy class syndrome.
Yes, the World Health Organization actually launched a massive study called the RIGHT Project to investigate that specific phenomenon.
And the data they found is just stark. I mean, if you were listening to this deep dive right now while sitting on a flight that is longer than 4 hours, your risk of developing a venous thromboembolism has roughly doubled compared to when you were just waiting in the terminal.
Because your calf pump is off.
Exactly. The pump is off, and the dry cabin air is dehydrating you, making your blood slightly thicker. So it is pure stasis combined with mild hypercoagulability.
And everyday life events affect that hypercoagulability too. Taking estrogen-based birth control pills, undergoing hormone replacement therapy, or simply being pregnant prompts the liver to produce more clotting factors.
Which is natural, right?
It is. It's the body's evolutionary way of preparing for the bleeding of childbirth, but it dramatically increases the risk of a DVT.
And then there are massive, unpredictable global events that throw the entire clotting cascade into chaos. The COVID-19 pandemic is heavily featured in these clinical notes.
The vascular impact of COVID-19 was a terrifying surprise to the medical community in 2020. Clinicians were seeing patients whose lungs were full of microclots and whose legs were developing massive DVTs, even when those patients were already on high doses of preventive blood thinners.
Wait, how is a respiratory virus causing blood clots in the legs?
It comes back to endothelial injury and inflammation. COVID-19 triggered what we call a cytokine storm, a massive uncontrolled inflammatory response by the immune system. The virus and the inflammation aggressively attacked the inner lining of the blood vessels throughout the entire body. So the body misinterpreted this massive systemic inflammation as widespread physical trauma.
Oh, wow. So it thought it was bleeding everywhere.
Exactly. It essentially panicked, thinking it was bleeding out, and dumped massive amounts of clotting factors into the blood. It created a hypercoagulable state so aggressive that standard drugs just couldn't stop it.
That is terrifying. But medical research also delivers incredible, positive surprises regarding how our vascular system works. The Jupiter trial from 2009 is a perfect example of this.
Oh, the Jupiter trial is one of my favorite anomalies in modern medical research.
Tell us about it.
It was a massive multinational study looking at a drug called rosuvastatin. Statins are widely known and prescribed exclusively to lower bad cholesterol. The goal was to see if the statin prevented arterial plaques from bursting and causing heart attacks.
But they accidentally discovered a massive benefit for the venous system.
Yeah. They did. When they analyzed the data, they found that the patients taking the statin had a dramatic, statistically significant reduction in venous thromboembolism.
Which makes no sense.
It confused everyone at first because cholesterol plaques do not form in veins, they only form in arteries. So how is a cholesterol drug preventing DVTs?
Right, what was the actual mechanism there?
It turns out statins don't just lower cholesterol, they're also powerful anti-inflammatory agents. They soothe the endothelium, the inner lining of the blood vessels.
Okay.
By reducing systemic inflammation, the statin essentially calmed the vein walls down, preventing them from sending out those chemical distress signals that trigger a clot. It was a total accident of research that proved how interconnected our cardiovascular systems really are.
It is incredible how a drug built for one side of the circulatory system ended up protecting the other just by calming the environment.
Yeah.
So as we pull all these threads together, the core takeaways from this massive stack of research are incredibly clear.
Very clear.
First, Virchow's triad stasis, endothelial injury, and hypercoagulability is the ultimate blueprint. Every risk factor you will ever face traces back to one of those three pillars. Second, bed rest is no longer the cure. It is a profound risk. Early, active movement is the gold standard of prevention.
Movement is medicine.
Exactly. And finally, you cannot wait for obvious pain to warn you because a clot can be utterly silent until the exact moment it threatens your life.
And as you think about the silent, lingering nature of this disease, I want to leave you with a final concept to ponder that illustrates the true long-term stakes of a deep vein thrombosis.
Okay.
It is a condition called post-thrombotic syndrome. We focus so heavily on the immediate life or death threat of the clot breaking off and traveling to the lungs. But what happens to the leg itself after the crisis is over?
That's a good question.
Even if you were diagnosed early, even if you are given the right blood thinners, and even if the clot completely dissolves, the physical trauma of that clot sitting in your vein can permanently destroy those tiny, delicate one-way valves we talked about earlier.
Oh, no.
And when those valves are ruined, they never grow back. The blood can no longer fight gravity efficiently. It constantly falls backward and pools in your lower leg.
Wow.
For the rest of your life, you can be left with chronic, heavy swelling, persistent pain, and irreversible skin discoloration. It is the permanent structural footprint that a clot leaves behind long after it is gone. And it is the ultimate reminder that the true goal of medicine isn't just to survive a blood clot. The goal is to never let it form in the first place.
You know, usually when we talk about medical diagnosis, there's this expectation of precision.
Right, like a clear-cut answer.
Exactly. I mean, you break your arm, the x-ray shows a jagged white line, and the clinical path is just binary. It's broken or it's not broken.
Yeah, there's no real debate there.
But you step into an obstetric emergency, and that x-ray machine is, well, it's essentially useless. You're suddenly operating in these diagnostic muddy waters, where the clinical picture is just shifting by the second.
It's incredibly volatile.
Yeah, and the stakes literally could not be higher, especially considering that roughly a quarter of all maternal deaths globally are tied to one very specific complication, postpartum hemorrhage, or, PPH.
It is arguably the most urgent diagnostic puzzle in modern obstetrics. And what makes it so critical for us to analyze in this deep dive is that mastering PPH, it goes way beyond just memorizing vascular anatomy.
Right, it's bigger than that.
Oh, absolutely. We are really looking at a masterclass in how clinical systems and definitions and simple cognitive checklists can actually intercept human error in the middle of a totally chaotic high adrenaline crisis.
Okay, let's unpack this, because our mission today for you, the listener, is to really demystify how modern medicine tackles this ancient threat. We're going to explore the actual physiological causes of why a patient hemorrhages after birth, and we'll decode this framework known as the 4 T's.
Which is a brilliant life-saving checklist.
Totally. But we also need to examine the controversies in the sources, like the fierce debates over how to even measure blood loss in real time, and why this entire standard of care is actively evolving right now.
Yeah, and to really grasp that evolution, you have to look at how the target itself has moved over time. Because before a clinical team can, fix a hemorrhage, the system has to agree on what actually qualifies as one.
Which sounds like it should be obvious, but it's really not.
No, not at all. For decades, the traditional baseline, which the World Health Organization still references, by the way, defined PPH strictly by volume.
Okay, so just a strict number.
Right. It was 500 milliliters for a vaginal delivery and 1,000 milliliters for a C-section, all within 24 hours.
Which, I mean, on the surface, that feels like that clean binary x-ray we mentioned. But the sources highlight a pretty major pivot that happened in 2017.
Yes, a massive shift.
Right, because the American College of Obstetricians and Gynecologists, ACOG, they basically threw out those separate thresholds. They bumped the vaginal baseline up to 1,000 milliliters, regardless of how the baby was delivered. And more importantly, they layered on this clinical criterion.
If we connect this to the bigger picture, the problem with a fixed numeric threshold is that it completely ignores the actual physiological reality of the specific patient in the bed.
Right, because everybody's different.
Exactly. By requiring either 1,000 milliliters of loss or blood loss accompanied by signs of hypovolemia like a rapid heart rate or low blood pressure, ACOG shifted the focus from just the fluid volume to the patient's actual hemodynamics.
Okay, I think I get it. So a small-framed woman, for example, she might have a severely constricted vascular space if she has preeclampsia, right?
Precisely. She might start crashing at just 700 milliliters.
But then another patient who maybe has robust pregnancy-induced hypervolemia, like she has extra blood volume just from being pregnant, she could potentially lose 1,200 milliliters and still have perfectly stable vital signs.
Spot on. So a medical field that's usually defined by extreme precision realized that a static number just wasn't capturing the real clinical danger.
But looking at the measurement history in these sources, the actual methodology for tracking that blood volume is just staggering to me.
It's definitely a contentious topic.
Wait, so for decades, doctors and nurses were just visually eyeballing how much blood was lost on pads and sheets? just looking at it and guessing.
Yeah. Visual estimation was the undisputed standard of care for generations. And it was fundamentally flawed.
I mean, it's like trying to guess the weight of a packed suitcase just by looking at it from across the room. The human eye might process the dimensions, but you cannot possibly account for the density.
That is a perfect analogy. And when you factor in that you're dealing with blood mixing with amniotic fluid and soaking into heavy hospital fabrics, visual estimation isn't just difficult, it's basically mathematically impossible.
And the data backs that up, right?
Entirely. Multiple systematic reviews show that visual estimation underestimates true blood loss by a third to a half.
Oh, wow. A half.
Yeah, and the psychological component is what makes it so terrifying. Paradoxically, the larger the hemorrhage, the worse the human brain is at estimating it.
Wait, really? So when it's worse, we are worse at seeing how bad it is?
Exactly. When a patient is losing massive, catastrophic volumes of blood, the clinical team's visual estimate becomes increasingly conservative. The human brain just sort of goes into denial.
That cognitive blind spot that just totally explains the massive push in the last decade toward QBL, quantitative blood loss, meaning they literally have to weigh the suitcase now.
Right, you have to put the blood-soaked materials on a scale. QBL requires the team to weigh the lap pads, the under-buttocks drapes, subtract the known dry weights of those textiles, and then meticulously measure the fluid in suction canisters.
Which ACOG and AATHON now demand as standard practice, but implementing that on the hospital floor must have been incredibly disruptive.
Oh, it caused a massive uproar.
I can imagine. I mean, stopping to calibrate a scale and weigh bloody gauze while a patient is crashing. It feels totally counterintuitive to the urgency of an emergency.
It really was met with tremendous resistance. It's a hugely disruptive workflow when every single second counts. But the patient safety movement pushed it through because the alternative, just relying on a flawed visual estimate, was leading to delayed recognition.
And delayed recognition costs lives.
Exactly. That's exactly what drives the mortality rate.
So if visual estimates were just systematically failing for decades, it completely contextualizes why the medical field had to restructure its entire behavioral response.
Which brings us to the real core of this deep dive, the 4 Ts.
Yeah, and the architecture of the 4 Ts is fascinating, mostly because it was born out of a very dark reality.
What do you mean?
Well, in the late 90s and 2000s, state-level maternal mortality review committees, particularly the California Maternal Quality Care Collaborative, the CMQCC, they began aggressively auditing these deaths.
Okay.
And the hard data they published revealed that a significant portion of hemorrhage deaths were not caused by untreatable exotic diseases. They were preventable.
Preventable. So why were they dying?
Patients were dying because the clinical response was disorganized, people were panicking, or they were waiting for an attending physician to arrive to sort of divine the source of the bleeding.
So they essentially took the ABCs of trauma resuscitation, airway, breathing, circulation, and they just built a trauma bay checklist for obstetrics. That is the exact mechanism of action, yes. Through programs like the ASO course and those early CMQCC toolkits around 2009 and 2010, the 4 Ts were formalized.
Because it bypasses the cognitive overload.
Exactly. During a crash, clinicians can freeze or develop tunnel vision. The 4 Ts turns this open-ended panicked mystery of why is she still bleeding into a lightning-fast differential diagnosis.
Let's break down the physiology behind that differential then, starting with the overwhelming majority of cases. The first T is tone, specifically uteroadenectomy.
Right, which accounts for roughly 70 to 80% of all PPH cases.
With a failure rate that high, why isn't the standard of care to just intervene surgically right away, instead of relying on a bedside checklist?
Because the natural physiological mechanism of childbirth is incredibly robust when it works, and invasive surgery carries severe morbidity risks.
Okay, fair enough.
To understand adeny, we have to look at how the body naturally stops bleeding after the placenta detaches. Most people assume it's about clotting, but it's not driven by the coagulation cascade. It is entirely mechanical.
The spiral arteries.
Yes. The uterine muscle, the myometrium, is this dense, interlacing network of fibers. When the placenta separates, those torn spiral arteries are just exposed and bleeding. The only way to stop that high-pressure flow is for the uterus to contract violently, clamping down like a fist to physically strangulate those blood vessels.
So if the muscle stays soft or boggy, those arteries just bleed freely into the cavity.
Exactly.
Here's where it gets really interesting. The sources mention that carrying twins or having excess amniotic fluid polyhydramnios are major risk factors for this.
Right, because of the physical stretch.
Yeah, if you think about the interlacing fibers of the uterus, like a rubber band or maybe a woven Chinese finger trap,
Okay.
normally the harder it pulls together, the tighter it grips the vessels.
Right.
But if that trap is distended way beyond its structural limit by twins, the muscle fibers stretch out. They get fatigued and they lose their snapback force.
That is an excellent way to visualize the structural failure. Prolonged labor induces a very similar kind of muscle fatigue. And that mechanical failure is what we call tone.
Okay, so let's create a clinical dilemma for you. The nurse pushes on the patient's abdomen. The uterus is clamped down tight as a rock. The tone is perfect, but the blood is still pooling. The mechanical fix worked, but the patient is still bleeding out.
That immediately forces the clinician to move down the checklist and look for the second T trauma.
Which accounts for about 20% of cases.
Yes. When tone is resolved, the bleeding is almost certainly a structural injury somewhere along the birth canal. We are looking for lacerations, concealed hematomas, or, in catastrophic cases, uterine immersion.
That's where the uterus actually turns inside out, right? Often from excessive pulling on the umbilical cord before the placenta has fully detached.
Exactly. It's often an iatrogenic injury, meaning it's caused by the clinical management itself.
This specific T trauma was actually central to Serena Williams' highly publicized postpartum crisis back in 2017.
Oh, yes. That case was a major cultural touchstone.
Yeah, she had a hematoma at her C-section site, combined with a pulmonary embolism. Well, it wasn't textbook atony. It falls squarely into trauma. And it catalyzed this huge national conversation about maternal morbidity and specifically racial disparities in having your symptoms actually believed by medical staff.
Her experience forced a really critical structural review within health systems. It highlighted that even with all these checklists in place, the speed at which a patient's self-reported symptoms are evaluated is still a variable that hospitals have to rigorously monitor.
But going back to the bedside assessment of trauma and tone, there's a massive misconception here. I want to ask you about this. If a nurse feels the patient's stomach and the uterus is firm, they are safe, right?
Absolutely not, and that assumption has tragically cost lives.
Wait, really?
Yes, a firm fundus is not a free pass. You could have a patient with a perfectly contracted, rock-hard uterus, but if they have a severe undiagnosed cervical laceration, which is trauma, they will continue to hemorrhage briskly. Yeah, the firm uterus only clears the very first box on the checklist. The clinician is still obligated to visually inspect the entire anatomical tract.
Which brings us to the third scenario. The uterus is firm, the clinician does the visual inspection, and there are no lacerations, no structural trauma at all. But they are still leaking blood. What else could possibly be leaking?
That points directly to the third T tissue.
Retained placenta.
Yes, retained placental fragments or blood clots, which make up about 10% of these emergencies.
But if even a tiny fragment, like a millimeter of the placenta, is left behind, how does that cause a massive hemorrhage?
Because it disrupts that Chinese finger trap mechanism you mentioned earlier.
Okay, how so?
The uterus cannot contract uniformly if there is a foreign mass occupying space inside it. The muscle fibers around that retained tissue stay stretched out, which leaves a localized area of spiral arteries completely uncompressed and bleeding.
Got it. And the most aggressive pathology in this category from the sources is the placenta accreta spectrum, right?
Yes, where the placenta essentially invades the uterine wall.
And this was my biggest aha moment from the reading. The data is chilling. The massive rise in placenta accreta tracks almost exactly with the rising global C-section rate.
The pathophysiology behind that link is entirely rooted in how scar tissue alters the uterus.
Right, because a prior C-section leaves a physical scar on the uterine wall. And when the patient gets pregnant again, the new placenta often implants over that compromised scar tissue.
Exactly. And in an attempt to find adequate blood supply, the placental cells dig deeper. They invade the muscle wall because the normal physiological barrier was structurally damaged by the previous surgery.
So a surgery that was designed to make childbirth safer today is essentially planting the seed for a severe hemorrhage risk years down the line.
It's a downstream cascade of interventions,
Yeah,
yes.
that is just wild to think about. Okay, so that leaves the final, and I think most complex, T thrombin.
Thrombin is very rare, about 1% of cases, but it is disproportionately lethal. This is coagulopathy.
So the plumbing is fine, the structure is fine, the cavity is clear, but the blood simply won't clot.
Right. Conditions like severe preeclampsia or an amniotic fluid embolism can trigger DIC, disseminated intravascular coagulation. The body forms microclots everywhere, which rapidly consumes the entire reserve of clotting factors.
What's fascinating here is that thrombin is the only category where mechanical fixes are completely useless, right?
Exactly. You cannot massage a clotting disorder. If you put in a uterine balloon, it won't help. You must replace the blood products via a massive transfusion protocol. You have to rebuild their capacity to clot.
Okay, so knowing the 4Ts tells clinicians why it's happening, but how do they proactively stop it? This brings us to the fierce debates over intervention, like active versus expectant management.
Right. Intuition suggests that for a low-risk patient, you just practice expectant management, let nature take its course, and withhold drugs.
But the sources say that's totally wrong now.
It is. Large trials prove that a massive portion of atony cases happen to women with absolutely zero identifiable risk factors.
So you can't predict it.
You can't, which is why active management is the standard. Giving a uterotonic drug like oxytocin to every single woman immediately after birth. It chemically forces the uterus to contract.
And when that fails, we look at the woman trial from 2017, tested on 20,000 women across 21 countries. It proved that tranexamic acid, or TXA, drastically reduced bleeding deaths.
Yes. It's a cheap, decades-old generic drug that stops the body from breaking down its own early clots.
But there's a dramatic catch here. TXA only works if given within 3 hours of delivery, right?
Timing is literally everything. If given after 3 hours, the patient's coagulopathy has shifted phases, and TXA offers absolutely no survival benefit. In fact, it could cause dangerous blood clots.
Wow. Okay, as we wrap up this deep dive, I want to address you, the listener, directly. Because there is one last dangerous misconception about timelines that you need to know. A lot of people assume the danger window closes when the mother leaves the delivery room.
Oh, that is a huge mistake. We have to talk about secondary PPH.
Right, the 12-week danger zone.
Exactly. A patient could be home weeks into recovery and suddenly experience a massive hemorrhage, often from a tiny retained placental fragment that causes an infection. It can strike completely out of nowhere.
So what does this all mean? When you look at everything, the 4Ts essentially compress a life-or-death mystery into a seconds-long bedside checklist. It empowers nurses and midwives to act instantly without waiting for a specialist.
It's the ultimate example of clinical systems overcoming human error.
It really is. But I want to leave you with a final thought to mull over. Since rising C-section rates globally are quietly driving up the rates of placenta accreta, are we currently manufacturing a future epidemiological crisis? In our modern quest to medically manage childbirth for immediate safety today, are we unknowingly engineering the very hemorrhage crises that the next generation of nurses and doctors will have to fight? Definitely something to think about. Imagine someone looking you right in the eye and telling you that a highly specific disease is just 100% fatal, like instantly fatal.
Right. No treatments, no interventions, just, no hope at all.
Exactly. And then, I don't know, decades later, you find out that the entire medical establishment was just, well, looking at it completely wrong for centuries.
Yeah, I mean, it sounds like this absolute failure of science, right? But that is actually the genuine history of one of the most common medical emergencies in the world. We were just fundamentally blind to it.
So today on the deep dive, we are looking at myocardial infarction, but specifically through a specialized clinical and nursing lens. We're taking our stack of sources, so, the pathology studies, the historical archives, the modern clinical guidelines, to really decode what an MI actually is at the cellular level.
Right. We really want to understand the biological mechanisms behind that famous phrase, time is muscle. And of course, dive into the whole high-sensitivity troponin debate and explore the immediate emergency care protocols that, nurses and doctors use every day.
Okay, let's unpack this. Because for a clinical audience, we already know the basic anatomy. But the actual etymology of the word infarction, it actually carries this very specific, physical pathology that sets the stage for everything else, right?
It does, yeah. It's a beautifully grim Latin root, actually. Infarction comes from the word infarcere, which literally means to stuff.
To stuff,
Yeah,
like stuffing a turkey.
Basically, yeah, because when early pathologists opened up the chest on autopsy tables, they weren't just seeing, generalized wear and tear on the heart. They were seeing this very distinct, literally stuffed, wedge-shaped mass of dead, hardened tissue right in the ventricular wall.
Oh, wow. So it's something you could visibly, physically see.
Exactly. It's a highly physical endpoint. And it's really important to distinguish it from angina. With angina, reduced blood flow causes temporary ischemia, which is basically cellular oxygen starvation, but without permanent damage.
Right, they bounce back.
Yeah, exactly. But in infarction, that means the cells have undergone completely irreversible necrosis. They are dead.
And, well, because heart cells don't regenerate in any meaningful way, that dead zone just gets permanently replaced by non-contractile scar tissue, right? Like the heart's mechanical efficiency is just altered forever.
Right. It never fully recovers its original state.
But to understand how we manage an MI today, we have to figure out how doctors even realized this was, a survivable, treatable condition in a living person. Because for centuries, if you had sudden, crushing chest pain and died, what was the official diagnosis even called?
Historically, physicians just blamed it on apoplexy.
Apoplexy. That sounds so old-timey.
It really is. It was basically this medical catch-all term for suddenly dropping dead from some kind of cardiovascular or neurological collapse. They just didn't know. Later on, they started using the term angina pectoris, which was actually coined by William Heberden way back in 1768.
Okay, 1768. But he was just describing the pain, right?
Right.
Not the actual cause.
Exactly. Heberden was only describing the sensation. The prevailing medical dogma at the time was that if a coronary artery suddenly clotted off, the patient just died instantly. Full stop.
Which means, I guess, there was zero incentive to try and diagnose it in a clinic. Like, if coronary occlusion is completely synonymous with sudden death, you're only ever going to see it on an autopsy table.
That was the deadlock. You can't treat what you think is instantly fatal. But there is a massive historical twist here. The person who first broke that deadlock and actually diagnosed a coronary thrombosis in a living patient was Adam Hammer. He was an Austrian-American physician working in St. Louis.
Wait, really? When was this?
He made the clinical connection right at the bedside in 1878.
1878. But wait, I'm looking at our sources, and the physician who gets all the textbook credit is James B. Herrick. And he published his landmark paper in the Journal of the American Medical Association in 1912. That's like more than 30 years later.
Right, so here's the crazy part. Hammer published his 1878 report in German, and because of that language barrier, the English-speaking medical establishment just completely ignored it.
You kidding?
No, his discovery basically just vanished into the archives.
So this is like discovering the blueprint to save a burning house, but the fire department just ignores it because it wasn't written in English. That is infuriating. It just goes to show you how scientific firsts are usually about who had the social capital to get believed, not who actually made the discovery first.
What's fascinating here is that Herrick undeniably did the much harder sociological work. I mean, his 1912 paper, it was called Clinical Features of Sudden Obstruction of the Coronary Arteries. He actively argued that coronary occlusion was survivable.
He had to really fight for it.
Oh, absolutely. He correlated the clinical presentations of living patients with later autopsy findings to prove that the initial clot didn't kill you instantly. The damaged, healing heart muscle produced a clinical syndrome you could actually recognize.
Right, but I'm guessing the doctors of 1912 didn't just accept that immediately.
Oh, not at all. Being right wasn't enough. Herrick spent years just relentlessly arguing with a highly skeptical medical community to reframe MI from an autopsy curiosity to a living, actionable disease process.
And Herrick proving that patients survive the initial clot. Well, it forces us to ask a pretty terrifying biological question. If they aren't dying instantly, what is the heart muscle actually doing during those first few hours after the blood stops flowing?
Well, the biological clock starts ticking the very second that fatty plaque ruptures and the thrombus, or clot, stops downstream blood flow. The heart muscle cells, the cardiomyocytes, are just uniquely vulnerable.
Because they need so much oxygen, right?
Exactly. They have virtually zero capacity for anaerobic metabolism, especially compared to your skeletal muscles. Since your heart never gets to rest, its cells are just packed with mitochondria that demand constant, uninterrupted oxygen for aerobic metabolism.
So when you cut that oxygen off, they don't just switch to a backup power system. They immediately start to suffocate. And our sources detail this concept called the wavefront phenomena, which was discovered by cardiac pathologist Robert Jennings in the 1970s.
Yes, Jennings's canine studies were groundbreaking for this.
Right, so when the artery blocks, the tissue doesn't die all at once. The cell death actually starts in the innermost layer of the heart muscle, the subendocardium, at roughly the 20-minute mark.
And the mechanics of why it starts there are fascinating. That innermost layer It's under the highest physical pressure from the blood inside the ventricle, and it is the furthest away from the epicardial coronary arteries, which sit on the outside of the heart.
So it's basically the hardest zone to supply with blood, even on a good day.
Exactly. Once an occlusion happens, that inner layer collapses first. From there, the tissue death spreads outward through the muscle wall toward the exterior. It literally moves like a wave.
It makes me think of a slow-moving flood in a house. Like if you can stop the water when it's just in the basement, the foundation takes some damage, sure, but the house stays standing. But if you just sit on your hands for 3 to 6 hours, that flood reaches the roof, and the entire house is ruined.
That captures the clinical reality perfectly. By 3 to 6 hours of total blockage, that wave of necrosis extends through the entire thickness of the muscle wall. And that results in what we call a transmural infarction.
A full-thickness dead zone, and this is the biological foundation for that phrase, time is muscle. Every single minute dictates how far that wave of death travels. And to really prove how critical those minutes are, we have the ISIS-2 trial from 1988, right?
Oh, the ISIS-2 trial is a cornerstone of modern cardiology.
They took over 17,000 patients and found that simply giving a patient aspirin within 24 hours of a suspected MI reduced 5-week vascular mortality by 23%, just from aspirin.
Right, and then adding streptokinase, which was an early clot-dissolving drug, to that aspirin reduced mortality by roughly 42% compared to the placebo. I mean, it definitively proved that acting fast to intervene in that wavefront literally saves heart muscle.
And I really want to emphasize why saving that specific muscle is so vital to you listening, because it goes back to something we mentioned earlier, regeneration. If you damage your liver or scrape your skin, the cells divide and they heal. But you don't get new cardiomyocytes, do you?
No, you really don't. And Olaf Bergman's 2009 carbon-14 dating study quantified this beautifully. He proved that even in healthy young arts, only about 1% of muscle cells are replaced per year.
Wait, 1% a year? That is practically nothing.
It is nothing, and that minuscule replacement rate plummets even further as we age. So time is muscle isn't just a catchy slogan, it is a biological reality, because whatever you lose in those first few hours of the wavefront, you are losing for the rest of your life.
Which means the ultimate pressure is on the nurses and clinicians to diagnose the infarction as quickly as humanly possible. But if the cells are actively dying in a wave, how do we actually measure that cellular death in real time without, cutting the chest open?
We look for the leak.
The leak?
Yeah. As those cardiomyocytes suffocate and undergo necrosis, their cell membranes literally break down and rupture. All of their internal cellular machinery just spills into the surrounding tissue and eventually washes into the systemic bloodstream.
Ah, okay. And the primary piece of machinery they spill is cardiac troponin.
Exactly. Troponin is the protein complex that regulates the calcium-triggered interaction between actin and myosin filaments. It's basically the physical lock and key mechanism that allows the heart muscle to contract in the first place.
And you can detect that in the blood.
You can, because the specific troponin isotopes found in the heart are structurally distinct from the troponin in your skeletal muscles. So detecting them in the blood is a highly sensitive, highly specific indicator of cardiac cellular destruction.
So it's the ultimate biomarker. I know it totally replaced older enzymes like CKMB. But the kinetics of how it actually enters the blood are pretty tricky, aren't they?
They are. Troponin typically becomes detectable within 2 to 4 hours of the initial injury. It peaks around 12 to 48 hours, and it can linger in the blood for up to 14 days after a massive infarction.
And that time delay is exactly why serial nursing measurements are so critical. Because a single troponin draw tells you almost nothing useful in an acute setting, right?
Right. A single snapshot is useless. Clinicians are looking for the delta, the change over time. A troponin level that doubles in 2 hours tells a wildly different clinical story about an active, evolving injury than a stable, slightly elevated number does.
Troponin is so integral to modern cardiology that it actually forced the medical community to rewrite the rulebook entirely. The 2018 Fourth Universal Definition of Myocardial Infarction explicitly shifted to a biomarker-driven diagnostic framework.
Yeah, that was a huge shift.
It requires evidence of myocardial injury, meaning an elevated troponin paired with clinical evidence of acute ischemia, like new ECG changes or severe anginal symptoms.
The diagnosis is now entirely mechanistic. We aren't just relying on a patient's subjective description of pain anymore. We are physically measuring the chemical debris of their dying heart cells.
But this introduces a massive clinical debate in emergency medicine right now regarding high-sensitivity troponin assays. Because these next-generation tests, They can detect troponin concentrations at incredibly microscopic levels, sometimes 10 to 100 times lower than the older generation.
Which is great for speed. It allows doctors to rule out an MI in just 1 hour.
Right. But the catch is that they are so sensitive they pick up microscopic leaks that have absolutely nothing to do with a plaque rupture.
Exactly. Severe kidney failure, sepsis, pulmonary embolism, or even the intense physiological strain of running a marathon can cause a tiny amount of troponin to leak into the blood.
So troponin is basically a highly sensitive smoke detector. It's great that it can detect a smoldering fire in the walls before you even smell smoke. But if it's so sensitive that it goes off just because someone is, like, boiling water or blowing out a candle in the dining room, which is essentially what a marathon runner's benign troponin leak is, aren't we risking rushing healthy people to the operating room?
This raises an important question, and it really requires clearing up a massive misconception in the field. An elevated troponin confirms myocardial injury, not a myocardial infarction diagnosis. You cannot look at a positive troponin in a vacuum.
It has to be married to that clinical evidence of oxygen starvation we talked about earlier.
That's the key. And it's why the universal definition splits MIs into different classifications. Type 1 MI is your classic pathology. A plaque ruptures, a thrombus forms, the artery blocks. You have to rush that patient to the cath lab to physically thread a wire into the heart and open the vessel.
Right, ideally meeting that 90-minute door-to-balloon metric.
Exactly. But type 2 MI is a completely different biological mechanism.
Right, because there's no clot.
Exactly. A type 2 MI is a supply and demand mismatch without any acute plaque rupture. Picture a patient with profound anemia or septic shock or even a dangerously rapid tachycardic rhythm.
So their body suddenly demands vastly more oxygen than their previously narrowed but stable coronary arteries can deliver.
Precisely. The cardiomyocytes still starve. They still undergo necrosis. They still leak troponin into the blood.
So the lab results look completely identical, but the treatment protocol is the exact opposite. If you rush a type 2 patient to the cath lab, you aren't going to find a fresh clot to stent. You're just subjecting a highly unstable patient to surgical risks for literally no reason.
The intervention for a type 2 MI is to fix the underlying physiological trigger. You transfuse blood for the anemia, you give fluids and antibiotics for the sepsis, or you slow down the heart rate. The diagnostic framework has to be incredibly sharp here because the objective numbers can easily mislead you.
Which forces us to look at what happens when the patient's physical presentation also lies to the clinician. We have this culturally ingrained idea that a heart attack always involves a patient clutching their chest in agony, describing, an elephant sitting on their chest.
Oh, television loves that trope. But the reality is that silent or atypical presentations are dangerously common. We see this particularly in women, older adults, and individuals with long-standing diabetes.
Why diabetes specifically?
Well, for a diabetic patient, chronic hyperglycemia causes systemic neuropathy, and that nerve damage blunts the afferent pain fibers running from the heart up to the brain.
Oh, wow. So their nervous system just isn't transmitting the alarm bells at all. They might just present with profound fatigue or unexplained nausea or vague referred pain in their jaw or back.
Exactly. They can look relatively stable while that wavefront of cellular death is actively tearing through their ventricle.
That is terrifying. And then on the completely opposite end of the spectrum, you have the ultimate mimic, a condition that looks clinically identical to a massive heart attack but involves zero blocked arteries.
Yes, Takotsubo cardiomyopathy or broken heart syndrome. It was first formally described by a Japanese cardiologist named Hikaru Sato in 1990.
And the pathophysiology of this one is just wild. It's triggered by an acute, overwhelming surge of emotional or physical stress, like the sudden death of a spouse, a terrifying car accident, or a catastrophic natural disaster. It just floods the central nervous system with catecholamines, primarily adrenaline.
And that massive surge of stress hormones is directly toxic to the myocardium. It completely overwhelms the beta receptors, particularly at the apex, which is the bottom of the left ventricle, essentially paralyzing the muscle tissue.
So they show up looking like a classic heart attack.
Right. The patient presents with classic STEMI symptoms. They have crushing chest pain, massive ST elevation on their ECG, and a spike in their troponin levels.
But when you get them to the cath lab and shoot dye into their coronary arteries, the vessels are wide open. There's no plaque rupture.
Instead, the extreme stress has caused that paralyzed left ventricle to balloon outward. It takes on a highly distinct shape, with a narrow neck and a wide base.
Right, and Sato noticed it looked visually identical to a traditional Japanese octopus trap, which is known as a takotsubo.
Exactly. That extreme stress completely impaired the heart's mechanical ability to pump without a single blood clot being involved. It's a diagnostic minefield for clinicians.
So what does this all mean for the patient? I mean, let's say the diagnosis is straightforward for a second. It's a classic type 1 MI. You get them to the cath lab, you inflate the angioplasty balloon, and you clear the blockage. The blood is flowing again. I think most people, myself included, would assume the danger has passed and the patient is safe.
That is perhaps the most dangerous misconception in cardiology. The first few hours immediately after the arteries reopened actually carry the highest risk of sudden cardiac death.
Wait, I'm stuck here. If you just cleared the blockage and flooded the starving tissue with fresh oxygen, that should be the moment they are safest. Why is that the exact moment they are at the highest risk of dropping dead?
It comes down to a phenomenon called reperfusion injury and how it affects the heart's electrical wiring. See, while the artery was blocked, the starving cells switched to inefficient metabolic pathways, building up massive amounts of lactic acid and toxic waste products.
Okay, so there's a buildup of garbage in the cells.
Right. So when you suddenly restore blood flow, that rush of fresh oxygen hits all that damaged cellular machinery, generating a massive burst of oxygen-free radicals that actually cause further tissue damage.
So you're basically washing all of that concentrated acid, intracellular potassium, and toxic metabolic waste straight into the systemic circulation of the heart all at once.
Exactly. And that sudden chemical shift creates severe electrical irritability. The heart relies on incredibly precise ion gradients to coordinate its pumping. The tissue that died, bordering the tissue that was just rescued, becomes electrically chaotic.
And that leads to arrhythmias.
Yes. This reperfusion phase frequently triggers fatal arrhythmias, primarily ventricular fibrillation, where the heart just quivers uselessly instead of actually pumping blood.
So the doctors might have fixed the plumbing, but the electrical wiring is actively short-circuiting, which really highlights why the bedside nursing role is absolutely critical in the ICU, like continuous cardiac monitoring, managing the hemodynamic instability, and having a defibrillator instantly ready to shock the heart back into a normal rhythm. Those things are just as vital as the physical stent.
Absolutely. The intervention doesn't end in the cath lab. That continuous nursing vigilance is the literal barrier between a patient recovering and a patient suffering sudden cardiac death from a reperfusion arrhythmia.
To pull all of this complex pathology back to the big picture for you listening, cardiovascular disease is lethal, obviously, but the major takeaway from all of our sources is that it is uniquely actionable and largely preventable.
Oh, completely. Just look at the InterHeart study from 2004.
Right, the one led by Salim Yusuf across 52 countries. It completely reframed how we view MI risk.
The InterHeart findings were a total paradigm shift. They demonstrated that just 9 modifiable risk factors account for over 90% of the population. Attributable risk for a first myocardial infarction.
90%.
90%. We are talking about smoking, dyslipidemia, hypertension, diabetes, abdominal obesity, psychosocial stress, poor diet, lack of exercise, and alcohol consumption.
Which means 90% of the risk comes down to daily variables. It proved that a heart attack is not just this unavoidable genetic destiny for most people. It is heavily dictated by our environment and our choices. And it's incredible how public perception of this has evolved over time.
Oh, for sure.
Like when President Dwight Eisenhower had his massive heart attack in 1955, it was reported with such intense public candor that the U.S. stock market actually plummeted. But it also dragged the disease right out of the shadows. It proved to the public that MI wasn't just this sudden private death sentence. It was a survivable disease process that really required public health awareness.
And the entire trajectory we've discussed today, from Herrick proving the initial clot was survivable, to mapping the wavefront of cellular death, to detecting those microscopic troponin leaks, is really a story of medicine learning how to visualize the invisible damage happening inside the chest and then intervening faster and faster.
Which brings up a final, somewhat unsettling thought I want to leave you with, pulled straight from the Framingham Heart Study data in our sources. We've established today that an infarction leaves a permanent, non-contractile scar. And we've detailed how stealthy the symptoms can be, especially if neuropathy blunts the pain.
Right, the silent MIs.
Exactly. The Framingham data show that a highly significant fraction of myocardial infarctions are only ever discovered retrospectively. A patient goes in for a routine pre-op ECG years later, and the doctor sees the definitive electrical Q waves of an old scar. The actual event was entirely silent and completely unrecognized by the patient when it happened.
They never even knew.
So, think back to the beginning of this deep dive. When doctors missed the diagnosis for centuries because they assumed a heart attack only looked one specific way, if the physical symptoms can be that completely invisible and the resulting tissue death is that permanent, could you, or someone in your family, have already survived a silent wavefront of cellular death without ever taking a single aspirin? And how would you even know? When you hear the phrase water pill, there's this expectation of something, incredibly gentle, like it sounds like a cup of herbal tea or something.
Right, yeah, like a mild detox.
Exactly. You take a pill, you shed some extra water, you feel a bit lighter. But if you step into the actual world of renal pharmacology, that serene image just shatters instantly.
Oh, completely. It's not gentle at all.
Right. We aren't looking at some gentle sponge squeezing out fluid. We are looking at a microscopic, highly pressurized industrial assembly line inside the kidney.
Yeah, that's a great way to put it. An industrial assembly line.
And to really grasp how these ubiquitous medications operate, whether you're, prescribing them, administering them, or just studying them, we have to map out that assembly line. So our mission today in this deep dive into the source material is to follow these molecules down into the nephron.
Which is where all the action happens.
Exactly. To see how they manipulate our electrolytes, alter our hemodynamics, and occasionally create utter physiological chaos.
Because it is an industrial level of precision, really. And intervening in that process is never, well, it's never just about water. It's about chemical exchange.
Okay, let's unpack this.
Yeah.
Because the textbook definition of a diuretic that a lot of practitioners carry around is surprisingly slippery.
It is, yeah. It's highly misunderstood.
We call them water pills, but that implies a direct relationship with water excretion.
Mm-hmm.
We really need to distinguish between a true aquaretic and what the vast majority of these clinical drugs actually are, which are natriuretics.
That distinction is it's the absolute foundation of renal pharmacology. Strictly speaking, the clinical drugs we casually call diuretics, they don't target water at all.
And not even touch it, right?
No, not directly. They target sodium. They are natriuretics. Their primary mechanism is inhibiting the reabsorption of sodium natrium. So it just stays in the tubule and gets excreted.
Right.
The water loss that happens is entirely secondary. It's just following the sodium out of the body passively through an osmotic gradient.
So the water is just collateral damage to the sodium transport, essentially.
Exactly. Collateral damage is a perfect term for it.
If we wanted a true aquaretic-like, something that increases water excretion without touching sodium, we'd have to look at something like the Vaptan class, right, which blocks antidiuretic hormone directly at the V2 receptors.
Right, the Vaptans. Or, if you look historically, something as simple as ethanol, which just suppresses ADH release centrally.
Like having a few beers and suddenly needing the bathroom all night.
Exactly, yeah. Or you could use an osmotic diuretic like mannitol, which is freely filtered but not reabsorbed, so it physically drags water into the lumen via osmolarity.
Right, it just pulls the water with it.
But when we talk about modern first-line clinical management of hypertension or heart failure, we are focusing on molecules with highly specific transport targets in the nephron.
And tracing how we got those targeted molecules requires a look back. Because, this was not a story of brilliant scientists logically engineering the perfect drug from scratch.
Oh, not at all. It was incredibly messy.
The origins are wildly serendipitous.
Yeah, it was very much an era of clinical observation driving the science rather than, the other way around.
Take Alfred Vogel in 1919. He was this medical student in Vienna, and he was treating a patient with a severe case of syphilis.
Right.
Which was complicated by advanced heart failure and massive anasarca, whole body swelling.
Yeah.
Now, the standard syphilis protocol back then involved merbafen, which is a highly toxic organomercurial compound.
Essentially a mercury injection.
Literally a mercury injection. So Vogel administers the mercury, and the patient inexplicably produces a staggering volume of urine. And it completely resolves his heart failure edema.
Which is wild to think about today.
It's the pharmacological equivalent of trying to seal a leaky pipe with toxic industrial sludge and accidentally inventing a brilliant pressure release valve.
That is exactly what it was. And that single observation birthed a 30-year era of organ mercurial diuretics.
30 years of injecting mercury.
Yeah. They were the standard of care for heart failure for decades, despite requiring these painful intramuscular injections. And of course, carrying a severe risk of nephrotoxicity over time.
Because mercury accumulates.
Obviously. So the therapeutic index was terrifyingly narrow.
The next leap forward was another total accident. In the 1930s, clinicians were using this early antibacterial sulfa drug, sulfanilamide, and they noticed their patients were urinating constantly.
Right, and developing hyperchloremic metabolic acidosis.
Yeah, so by the 1950s, pharmacologists like Carl H. Bayer, they chased that side effect down. They kept tweaking the sulfonamide ring until they created acetazolamide.
Which is interesting because acetazolamide itself isn't even a powerful diuretic.
Right, but they just kept mutating that chemical structure, looking for different ways to block sodium. And that trial and error chemistry eventually gave us chlorothiazide in 1957.
What's fascinating here is the stark contrast between those early chaotic discoveries and the later development of the potassium-sparing diuretics. Well, by the late 1950s, the game had changed completely. Endocrinologists had just isolated and characterized the hormone aldosterone.
Oh, okay. So they actually knew what they were targeting.
Exactly. Instead of waiting for a happy accident, pharmaceutical chemists looked at aldosterone's molecular structure and deliberately designed a molecule to act as a competitive antagonist at the mineralocorticoid receptor.
So instead of stumbling in the dark, they finally had the lock, and they purposefully machined a key just to jam it.
Yes. And that gave us spironolactone in 1959.
Wow. A total paradigm shift from serendipity to, rational drug design.
Exactly.
So with that arsenal of molecules in hand, we can finally look at where they actually go to work on the nephron's assembly line.
Let's do it.
Because the nephron's primary job is reclaiming the massive amount of sodium we filter every single day. And the first checkpoint is the proximal convoluted tubule.
Which really handles the heavy lifting.
Yeah, it reclaims roughly 65% of filtered sodium. And this is where acetazolamide acts by inhibiting carbonic anhydrase. But clinically, if you block sodium here, the downstream segments just, they upregulate their own absorption to compensate.
Right. They see the extra sodium coming and just work harder. So the net diuresis is incredibly weak.
Which means if you actually want to clear meaningful volume from a fluid overloaded patient, you have to bypass that proximal compensation.
You have to target the actual engine of the kidney's concentrating ability, which is the thick ascending limb of the loop of Henle.
Okay, checkpoint 2. This is the territory of the loop diuretic, so furosemide, bumetanide, torsemide. This segment handles about 25% of the sodium load.
A massive amount.
Right. And just looking at the physiology, if you suddenly paralyze a checkpoint responsible for a full quarter of the body's sodium reclamation, the downstream segments can't possibly compensate for that. It must create absolute chaos in the tubules.
It does. It creates an overwhelming solute load, which is exactly why loop diuretics have the highest efficacy of any class.
The sledgehammers?
We consider them the sledgehammers of diuresis, yeah.
Yeah.
They act by reversibly binding to the chloride binding site of the NK2Cl cotransporter, or NKCC2.
So they don't just block sodium, they paralyze the transport of sodium, potassium, and 2 chloride ions all at once.
All at once. And the downstream consequences of paralyzing that specific transporter are just profound.
How does that cascade work?
Normally, as potassium is pumped into the tubule cell by NKCC2, it actually leaks back out into the lumen, and that back leak creates a positive electrical charge in the urine.
Okay, a positive charge.
Right, and that positive charge is critical because it repels other positively charged ions, specifically calcium and magnesium, forcing them out of the tubule, between the cells, and back into the blood.
Ah, I see. So the positive lumen potential is the actual driving force for saving calcium and magnesium.
Exactly. So when you give a patient furosemide and shut down NKCC2, you lose that potassium back leak.
You abolish the positive charge.
Yes, and suddenly the calcium and magnesium have no reason to leave the tubule.
They just, get flushed straight out into the urine.
They do. And that gives loop diuretics their distinct, dangerous electrolyte fingerprint. Profound hypokalemia, hypomagnesemia, and hypocalcemia.
Wow.
You are inducing massive volume contraction alongside severe electrolyte depletion.
And beyond the electrolytes, there is this structural danger to the loop class that, honestly, catches a lot of people off guard. They carry a well-documented risk of ototoxicity.
Right. Hearing loss.
A literal water pill that can cause permanent deafness. It sounds bizarre.
It sounds totally bizarre until you look at the histology. The stria vascularis in the inner ear, it relies on an isoform of that exact same NK2Cl cotransporter to maintain the endolymph fluid that actually allows us to hear.
So the furosemide crosses into the inner ear and blocks it there too.
Exactly. And the ototoxicity is highly dose and rate dependent, which dictates the strict nursing protocols for intravenous administration.
Like pushing it too fast.
Yeah, if you push IV furosemide faster than, say, 4 milligrams per minute, you drastically spike the risk of hearing loss.
And if the patient is simultaneously receiving aminoglycoside antibiotics, like gentamicin, which are independently vestibulotoxic and ototoxic,
Yeah.
you are essentially launching a two-front assault on the inner ear.
Yes. The synergistic damage there can be irreversible. You never push high-dose loops rapidly, especially in a septic patient on heavy antibiotics.
Okay, so if the loop of Hendel is the sledgehammer, checkpoint number 3 requires significantly more finesse.
Moving down the assembly line.
Right, moving down the assembly line, we hit the distal convoluted tubule. This is the domain of the thiazide diuretics, hydrochlorothiazide, chlorthalidone. They target the NCC, the sodium chloride cotransporter, managing about 5 to 8% of the filtered sodium.
Much less potent than loops, obviously, but with a highly unique pharmacokinetic profile.
And here's where it gets really interesting. Thiazides share the potassium and magnesium wasting properties of loops, but their effect on calcium is entirely paradoxical.
It is.
Instead of wasting calcium, thiazides actively hoard it. They increase calcium reabsorption back into the bloodstream.
Which is a fantastic example of compensatory cellular mechanics.
How does that actually happen?
Well, by blocking the NCC transporter on the lumen side, thiazides effectively starve the tubule cell of sodium. The intracellular sodium concentration just plummets.
So the cell panics.
It panics, yeah, and it activates a basolateral sodium-calcium exchanger on the blood side of the membrane. This exchanger works furiously to pull sodium out of the blood into the cell, and the price it pays is kicking calcium out of the cell and into the bloodstream.
Oh, wow. So it's essentially leveraging a backdoor mechanism to balance the sodium and accidentally hoarding calcium in the process.
Exactly. Which makes thiazides a brilliant prophylactic tool for nephrolithiasis.
Kidney stones.
Right. If you have a patient forming recurrent calcium oxalate kidney stones, throwing them on a thiazide strips the calcium out of the urine, cutting off the supply for the stones.
That's amazing. Just repurposing a side effect as a primary therapy.
It's very elegant.
Now, because thiazides only handle 5 to 8% of the sodium, there's this persistent assumption, especially I think among newer clinicians, that the stronger diuretic must be the superior choice for managing standard hypertension.
That's a very common misconception.
Right. Like, if someone has high blood pressure, why use a weak thiazide when you have a loop sledgehammer available?
And that assumption was systematically dismantled in 2002 by the ALHAT trial, the antihypertensive and lipid-lowering treatment to prevent heart attack trial.
This is a huge study, wasn't it?
Massive. It randomized over 33,000 patients. At the time, there was immense industry pressure claiming that newer, much more expensive calcium channel blockers and ACE inhibitors were vastly superior to old, cheap thiazides for hypertension.
So they tested chlorthalidone against the expensive new kids on the block.
They did. And chlorthalidone, a generic thiazide developed decades prior, was virtually unsurpassed in preventing fatal coronary heart disease and non-fatal myocardial infarction.
Wait, really?
Yeah, it actually outperformed the newer drugs in preventing heart failure.
That is a huge vindication for a cheap legacy drug.
And the physiology explains exactly why. Loop diuretics cause massive, rapid fluid shifts, but they have short half-lives.
So it's like a roller coaster.
Exactly. You get a spike in diuresis, followed by a period where the kidney actually aggressively retains sodium to compensate. But thiazides, like chlorthalidone, act slowly and constantly over 24 hours.
So it's just a smooth, steady curve.
Yes. They provide a gentle, steady reduction in plasma volume and eventually a reduction in peripheral vascular resistance. For uncomplicated hypertension, a gentle, continuous pressure reduction is always superior to erratic fluid shifts.
That makes perfect sense, and it perfectly sets up our final stop on the assembly line, the collecting duct, checkpoint 4.
At the end of the line.
This segment handles a paltry 2 to 3% of the sodium load via the ENSE channel. This is the territory of the potassium-sparing diuretics. Now, if this checkpoint handles such a negligible amount of sodium, it seems completely irrelevant for managing volume status. I mean, why do we even care about blocking 2%? It's a drop in the bucket.
If we connect this to the bigger picture, we have to look past the sodium itself and look at the hormones driving it.
The aldosterone again.
Exactly. The 1999 Orleans trial, the randomized aldactone evaluation study, completely redefined our approach here. They took patients with severe class 3 and 4 heart failure and added a very low dose of spironolactone on top of their standard therapy.
Spironolactone being an aldosterone receptor antagonist.
Right. And the results were so dramatic they had to halt the trial early. Spironolactone reduced the risk of death by 30%.
30%. You don't get a 30% mortality benefit in advanced heart failure just from blocking 2% of sodium reabsorption.
You don't. The benefit was almost entirely uncoupled from diuresis. Aldosterone does more than just tell the kidney to retain sodium.
What else does it do?
In a failing heart, Aldosterone directly promotes cardiac fibrosis, collagen deposition, and fatal ventricular remodeling.
Oh, it scars the heart.
Yes. So spironolactone acts by competitively binding to those mineralocorticoid receptors in the myocardium itself, basically halting the structural degradation of the heart.
So it's acting as a molecular shield for the myocardium, preventing it from scarring itself to death. Its identity as a water pill is almost incidental at that point.
It really is a disease-modifying drug masquerading as a diuretic. And, we should probably clarify the two distinct mechanisms in this class.
Right, because they aren't all hormone blockers.
Exactly. Spironolactone and eplerenone are receptor antagonists. They block the hormonal signal. But drugs like amiloride and triamterene, they ignore the hormone entirely and just physically plug the ENAC channel in the lumen.
Like a cork in a bottle.
Pretty much.
But regardless of whether you block the hormone or plug the pore, the physiological consequence is the same. By preventing sodium from entering the cell, you destroy the electrical gradient needed to secrete potassium.
So they spare potassium.
Which means the primary risk pivots from hypokalemia to life-threatening hyperkalemia.
A risk that escalates drastically, by the way, if the patient is on concurrent ACE inhibitors or taking potassium supplements.
Which perfectly brings us to the clinical reality of managing these drugs. We've mapped out the incredible, precise power these molecules have over hemodynamics.
But that power comes with immense vulnerability.
Yeah, especially when mismanaged in the outpatient setting. One of the most insidious presentations nurses and doctors see is the triple whammy.
Oh, yes. A textbook example of iatrogenic hemodynamic collapse.
You see this constantly in elderly patients who have, say, hypertension, heart failure, and osteoarthritis.
A very common combination.
Right. So they were prescribed an ACE inhibitor, a diuretic, and then their joints hurt, so they just start taking an over-the-counter NSAID like ibuprofen.
Which seems harmless to them.
But combining those three destroys the kidney's ability to maintain its own glomerular filtration rate.
The mechanism there is just a perfect storm of pressure loss. The kidney relies on prostaglandins to keep the afferent arteriole dilated, ensuring blood actually flows in.
And NSAIDs block prostaglandins.
Exactly. So the NSAID constricts that inlet. Meanwhile, angiotensin II keeps the afferent arteriole constricted, which provides back pressure for filtration.
But the ACE inhibitor blocks angiotensin II, dilating the exit.
Right.
So the NSAID chokes off the incoming blood supply, the ACE inhibitor opens the exit valve so there's zero back pressure, and the diuretic lowers the total systemic blood volume.
The glomerulus is completely starved of pressure from all three angles, filtration drops to zero, and the patient goes into acute renal failure.
It's terrifying how easily that happens.
It really raises an important question about how carefully we monitor polypharmacy.
Right.
Because that same vulnerable demographic often runs into another lethal interaction, digoxin toxicity.
Oh, right. The classic exam interaction.
Digoxin and potassium compete for the exact same binding sites on the NACI-AT pace pump in cardiac tissue.
It's like a game of musical chairs.
That's a great analogy. If a patient is on a loop or a thiazide diuretic, they are actively dumping potassium. That hypokalemia leaves all those binding sites on the cardiac pump totally empty.
So if they take their normal dose of digoxin, it suddenly has zero competition for those chairs.
It hyperbinds to the tissue. It turns a therapeutic dose into a toxic arrhythmogenic dose.
Wow.
It is a critical pearl in medicine. A sudden cardiac arrhythmia in a patient on digoxin is a potassium problem until proven otherwise.
And these vulnerabilities are really exacerbated by environmental context, right? We have a massive aging population on baseline diuretics facing, frankly, unprecedented global heat waves.
That's a huge public health issue right now. The physiological reserve to handle extreme heat while you're pharmaceutically preventing the kidney from retaining water, it's virtually zero.
Dehydration and electrolyte collapse can happen in a matter of hours.
Absolutely.
And, it's not just the elderly who fall victim to the extreme manipulation of this assembly line. The deliberate abuse of diuretics in sports and aesthetics is this persistent, dark underbelly of this pharmacology.
Athletes abusing loops and thiazides for rapid weight manipulation.
Yeah. The most high-profile tragedy was in 1997, when 3 American college wrestlers died in a single month.
It's tragic.
They were using diuretics, saunas, and rubber suits to violently crash their fluid volume just to make lower weight classes.
And the hyperthermia combined with the electrolyte derangement caused fatal cardiac arrests.
It forced the NCAA to completely rewrite their weight certification rules.
And we see identical abuse patterns in bodybuilding, too. Competitors use severe diuresis to strip subcutaneous water for a dry vascular appearance on stage.
which frequently results in severe cramping and acute kidney injury right there on stage.
That's also exactly why the World Anti-Doping Agency, WADA, bans diuretics universally across all sports.
Not just for the weight classes.
No, it's because the massive influx of water into the tubule heavily dilutes the urine. Athletes use them as masking agents.
To drop the concentration of anabolic steroids below the testing thresholds.
Exactly. It is a profound weaponization of the kidney's homeostasis.
But even within legitimate medical practice, our theoretical grasp of these drugs constantly clashes with real-world outcomes.
Oh, constantly. The torsemide debate is a perfect example of this.
Let's talk about that. The Transform-HF trial.
Right. Published in 2023. We discussed furosemide earlier as the gold standard loop diuretic, but pharmacokinetically, it's actually quite flawed.
Its oral bioavailability is really erratic, isn't it?
Very. It ranges anywhere from 10 to 90% depending on the patient and the day. Torsemide, on the other hand, which is a newer loop, is pharmacokinetically elegant.
It has highly predictable oral absorption and a longer half-life.
So on paper, physiological logic dictated that torsemide should drastically reduce heart failure hospitalizations and mortality compared to furosemide.
It makes total sense. Better, more consistent drug delivery should equal a better heart.
Yet the trial demonstrated absolutely no significant difference in all-cause mortality between the two.
None at all.
None. It was a deeply humbling reminder for the cardiology community that a superior pharmacokinetic profile in a textbook does not guarantee a superior survival outcome in a human being.
We see that exact same tension between theory and outcome with the thiazides, too. There's always been this metabolic debate surrounding them.
Right, the side effect profile.
Yeah, thiazides inhibit insulin release and decrease peripheral glucose utilization, so they mildly elevate blood sugar. And they also compete with uric acid for secretion in the proximal tubule.
Which causes uric acid to build up in the blood, potentially triggering acute gout.
And in the ALHAD trial we talked about, the chlorthalidone group did show a slightly higher rate of new-onset diabetes.
It did.
So why do the guidelines confidently keep them as first-line therapies if we know for a fact they actively worsen glucose and uric acid metrics?
Because outcome data dictates the standard of care. Decades of follow-up have shown that the profound cardiovascular benefits of sustained blood pressure reduction, like the prevention of massive fatal strokes and myocardial infarctions, vastly outweigh the metabolic asterisk.
The big picture wins.
Exactly. The clinical strategy is to use the thiazide to save the vasculature and then actively monitor and manage the metabolic shifts if they actually occur.
Wow. Let's zoom out and just look at the whole assembly line one last time. We have the loop diuretics, our high-ceiling sledgehammers in the thick ascending limb, obliterating the lumen potential to dump sodium, potassium, calcium, and magnesium.
Right.
We have the thiazides in the distal tubule, gently wasting potassium while paradoxically hoarding calcium. And we have the potassium-sparing diuretics in the collecting duct, stepping in as molecular shields to block aldosterone and save the myocardium from fibrosis while navigating the razor's edge of hyperkalemia.
Together, this pharmacopoeia dictates the hemodynamic survival of millions of patients.
They are the absolute non-negotiable bedrock of nephrology and cardiology. So, what does this all mean for us today?
It's a shifting landscape.
It really is. We've spent this entire deep dive into the source material focused strictly on molecules designed to manipulate sodium transport, because that is the very definition of a modern natriuretic. But I want to leave you, the listener, with a final thought to mull over. Right now, the entire landscape of heart failure management is being revolutionized by SGLT2 inhibitors drugs like empagliflozin and dapagliflozin.
Ah, yes, the flozins.
The flozins. And the incredible part is that these were engineered strictly as diabetes medications.
Purely for blood sugar.
Right. Their mechanism is to block glucose reabsorption in the proximal tubule, forcing the kidneys to dump sugar into the urine to lower blood glucose. But by doing that, they pull massive amounts of water into the tubule via osmosis.
They induce a powerful osmotic diuresis.
Driven by sugar instead of salt. And that unintended diuretic mechanism has proven so incredibly cardioprotective that SGLT2 inhibitors are now a foundational pillar of heart failure guidelines, even for patients who don't have diabetes.
It's completely flipped the paradigm.
It forces us to ask,
Yeah.
are we witnessing the definition of a diuretic expanding once again? Moving from an era defined entirely by manipulating salt into an era defined by manipulating sugar.
It really makes you wonder what's next.
When you step back and look at that microscopic assembly line, Our understanding is constantly evolving, but the engineering behind it remains absolutely brilliant.
The deeper we look, the more complex the machinery reveals itself to be.
It really does. Thanks for joining us in this deep dive into the source material. See you next time.
So picture this. You walk into a hospital room, or, maybe you're just watching a medical drama on TV, and there it is.
Oh, yeah.
Right. The clear plastic bag hanging on that metal pole, just sort of slowly dripping liquid into a tube that disappears into someone's arm. It's like practically the universal symbol of modern medicine.
It really is.
And you look at it and you probably think, hydration. The tank is low, so they're just giving the patient some water.
Yeah, which is, it's the most natural assumption to make, right?
Right.
We all sort of carry this mental model of the human body as like a series of rigid pipes. So if a patient is sick or bleeding, well, the pipes are emptying out.
Exactly.
So you just hook up a bag of water to refill the plumbing. It just feels incredibly straightforward.
It does. But then you actually start digging into the science of those fluid bags, and suddenly that whole simple plumbing analogy just completely falls apart.
Oh, completely.
So welcome to the deep dive. Today, our mission is to unpack the fascinating and honestly highly counterintuitive world of 5V fluids.
Yeah, it's a wild ride.
Because what the sources reveal is that this is so much more complex than just, hydration. We're actually going to explore 3 genuinely surprising realities today for you. First, a fluid bag, clearly labeled isotonic, can actually act as a hypotonic water bomb once it's inside you.
Which is terrifying.
Right. Second, normal saline isn't actually physiologically normal at all. And third, the textbook standard for pediatric IV fluids was quietly harming children for 50 years before the medical community caught on.
Yeah, that one it's a really profound shift in perspective when you realize what is actually happening in that plastic tubing.
So where do we even start?
Well, to understand why those 3 things are true, we need to establish a foundational definition for you. At its core, an IV fluid is a sterile water-based solution infused directly into the bloodstream.
Okay, simple enough.
Right, but the single most important concept here isn't the water itself. It's a property called tonicity.
Tonicity?
Yeah. Tonicity basically describes how that specific fluid forces water to move across human cell membranes.
Okay, I want to spend some time here because, to understand how IV bags work, we really have to visualize this microscopic tug of war. It's happening between the fluid we're pumping into the vein and all the billions of cells lining those veins and making up the surrounding tissues.
Exactly. So there are 3 main classifications of fluids you need to know, and they're all based on this concept of tonicity.
Okay.
And we benchmark this against human blood plasma, which has a very specific, tightly regulated concentration of dissolved particles.
Like salt and stuff.
Yeah, mostly sodium, chloride, glucose, and urea. And that baseline concentration is roughly 275 to 295 milliosmoles per liter.
Okay, so 275 to 295 milliosmoles per liter.
That's the target. So the first type of fluid is isotonic.
Iso meaning same.
Exactly. This fluid has roughly the same effective solute concentration as your blood plasma. When you infuse an isotonic fluid into the bloodstream, the surrounding cells neither gain nor lose water. It creates a state of balance.
Got it.
The second type is hypotonic. This fluid has a lower concentration of solutes than the blood plasma.
Okay, so less stuff, more water.
Right. And because of the laws of physics, water naturally wants to balance things out. So the water actually leaves the bloodstream and forces its way into the more concentrated cells.
Oh, wow.
Yeah, and that causes those cells to physically swell up.
That sounds dangerous.
It can be. And then the third type is hypertonic. This has a higher concentration of particles than plasma.
So super salty or sugary.
Exactly. So in this case, water is violently pulled out of the surrounding cells to dilute the blood, causing those cells to physically shrink.
Okay, so to help you visualize this at home, I was actually thinking about an analogy while I was reading the sources.
Oh, let's hear it.
Okay, so imagine the dissolved solutes, like the salt or the sugar particles. Imagine them as the life of a great party.
Okay, I like this.
And the water. The water is the crowd. And, the crowd always wants to leave the empty, boring room and rush into the room where the party is actually happening.
That's spot on.
So if you inject a hypertonic fluid, you are basically throwing a massive concentrated party right inside the bloodstream.
Right.
So all the water inside the body's tissue says, hey, let's go out there, and rushes out of the cells to join the party, which shrinks the cells.
That paints a very accurate picture of the mechanism. And, For most of the 20th century, doctors basically operated under the assumption that these properties were simply fixed numbers printed on the bag's label.
Like whatever the label says is what you get.
Exactly. If the label said the party was a certain size, well, that was the end of the story.
Yeah.
But modern physiology makes this really sharp distinction that completely changes how we administer fluids.
Okay.
There is a massive functional difference between osmolarity and tonicity.
Okay, I'm going to need a timeout on this one.
Sure.
Because if the bag is manufactured in this highly controlled, sterile factory, how can the label be wrong? I mean, if it says it has a certain number of particles, aren't particles just particles?
Well, that's the trick. Osmolarity is exactly what you just described. It's the total absolute count of dissolved particles in the bag per liter.
Right.
You measure that in a chemistry lab, and the factory label is 100% accurate about that exact number.
Okay.
But tonicity is the effective osmotic pull that actually drives water movement across a living biological cell membrane.
Oh, I see.
Yeah, and those two concepts are not always synonymous because some particles are sneaky.
Sneaky how?
They can just pass right through a cell membrane without any resistance. Urea and ethanol are like classic examples.
Oh, so they don't trap the water.
Exactly, because they cross freely. They don't force water to move at all. They add to the osmolarity number on the factory label, sure. But inside a human being, they have zero tonicity.
Wow. Which actually brings us directly to that first major revelation from the intro, the D5W paradox.
Yes.
I was reading this section and trying to map it out in my head. So D5W is 5% dextrose in water.
That's right. And if you read the bag, its osmolarity sits perfectly in that 275 to 295 range.
So on paper, it's an isotonic fluid.
Exactly. It looks like it should just sit nicely in the blood vessels and maintain balance.
But dextrose is literally just a form of sugar.
Mm-hmm.
And the cells in our body constantly need sugar for energy. So if we pump this supposedly balanced sugar water into a vein, the patient's cells are going to rapidly consume all that dextrose.
Right.
They basically eat the party.
They devour the salutes entirely.
Mm.
And once the body metabolizes all that dextrose, what is left circulating in the patient's veins?
Just plain water.
Plain free water. So a fluid bag that was clearly labeled and manufactured as isotonic actually behaves as a hypotonic solution once it interacts with human metabolism.
That is wild.
It drops the concentration in the blood and sends all that free water rushing into the patient's cells.
Which, okay, knowing that we can manipulate water like this, forcing it in or out of cells by changing the guest list to this cellular party, it raises a major clinical question for me.
What's that?
Why would a clinician ever want to intentionally force a patient's cells to swell or shrink? I mean, shouldn't the goal always be to maintain that perfect isotonic balance?
Well, maintaining balance is absolutely the goal for basic resuscitation.
Right.
Like if someone is rushed to the ER with severe blood loss from a car accident or massive fluid loss from a gastrointestinal infection, their blood pressure is plummeting.
So you just need to refill the pipes.
Exactly.
Yeah.
You need to refill the pipes just to keep the heart pumping and oxygen flowing. Clinicians use isotonic fluids here because they want that fluid to stay inside the blood vessels. You definitely do not want it shifting into the surrounding tissues and causing complications.
But the sources discuss the use of hypertonic fluids, and I had a really hard time wrapping my head around this.
Yeah, it sounds backward.
Right. Under what circumstances would you ever want to intentionally dehydrate and shrink a patient's cells?
The primary application is for cerebral edema, which is severe swelling of the brain.
Oh, wow.
Because the brain is a really unique organ. It's completely encased in a rigid, unforgiving bone box. The skull.
Right. There's no room.
None. If brain cells begin to swell due to a traumatic injury or a stroke or a tumor, they have nowhere to expand.
Yeah.
So the physical pressure inside the skull starts building rapidly.
And if that pressure gets too high, it eventually just crushes the brainstem, right? Which controls breathing and heart rate. It's basically fatal.
It is. So to prevent that, a critical care team will push a highly concentrated hypertonic solution, usually like a very strong saline, into the bloodstream.
Ah.
So following your analogy, they throw an aggressive party inside the blood vessels of the brain.
And the water leaves the brain cells.
Exactly. The water that is dangerously trapped inside the swollen brain tissue is drawn across the blood-brain barrier and into the bloodstream to dilute that massive salt load.
That is incredible.
It physically shrinks the brain cells, a cellular process known as crenation, and it relieves that deadly mechanical pressure inside the skull.
The physics of water being used to literally decompress a brain. That is just wild to think about.
It's elegant, honestly.
So, Okay, on the flip side, when do we use hypotonic fluids? Like, when do we intentionally swell cells?
Hypertonic fluids come into play when a patient is suffering from profound intracellular dehydration.
Okay.
A prime clinical example of this is diabetic ketoacidosis, or DKA.
Okay, I've heard of that.
Yeah, in severe DKA, the patient's blood becomes so thick with unmetabolized glucose that the blood itself acts like a hypertonic fluid,
Oh. So the blood is sucking the water out of the body.
violently sucking water out of the patient's own tissues. Their cells are effectively shriveling up.
Wow.
So once the medical team stabilizes the patient's blood sugar and initial volume, they will often introduce a hypotonic fluid to gently push free water back into those parched cells to rehydrate them.
But there has to be a dark side to this, right?
What do you mean?
Well, if you are pushing water into a cell with a hypotonic fluid, isn't there a point where the cell just, I don't know, just can't take it anymore, like overfilling a water balloon?
Oh, absolutely. It is a critical risk factor.
Yeah.
If you administer too much hypotonic fluid or if you push it too fast, you can trigger RBC hemolysis.
Hemolysis, meaning what exactly?
It means the red blood cells circulating in the veins swell up with so much free water that their structural membranes simply cannot hold the tension. Yeah, they rupture and burst open directly in the bloodstream, which is a catastrophic event.
Wow. This requires like a surgical level of chemical precision.
It really does.
Which naturally makes me wonder about the history here. I mean, how did humanity figure out this exact benchmark? The 275 to 295 milliosmoles thing. Like, how did we learn to manufacture these safely?
The origin story in the sources is fascinating because it wasn't just a single scientific breakthrough.
Right.
It was a collision of two vastly different worlds over several decades. On one end of the spectrum, you had the 19th century physicists and physical chemists.
Okay.
Men like Wilhelm Pfeffer and Jacobus Henricus van Hoff.
Right.
And they operated in these pristine, quiet laboratories, meticulously studying plant cells and deriving the fundamental mathematical equations for osmotic pressure.
Doing the math.
Exactly, mapping out the invisible laws of how water behaves.
But calculating osmotic pressure in a quiet lab is worlds away from, keeping a dying human being alive.
That is exactly where the clinicians enter the picture. And their environment was the exact opposite of pristine.
Yeah, I bet.
In the 1830s, Europe was devastated by horrific cholera pandemics.
The Blue Terror.
Right, the Blue Terror.
Yeah.
Cholera causes such violent, relentless diarrhea that patients literally dried out.
Ugh, that's awful.
It is. Their blood would lose so much water, it turned into this dark, thick sludge that the heart could barely even pump.
Wow.
And a Scottish physician named Thomas Latta read theories about injecting water and salts directly into the veins. Driven by just sheer desperation, he began experimenting on dying patients.
So he didn't have all those fancy equations.
He didn't have Van Hoff's equations at all. He was basically just trying to mimic the salty taste of blood.
It was raw trial and error on human physiology.
Entirely. Latta and subsequent pioneers like Sidney Ringer and Alexis Hartman, they would inject various concoctions of boiled water, salt, and eventually sodium lactate, just to see what combinations kept people alive.
Without causing convulsions or that hemolysis we talked about.
Exactly. So over decades, the rigorous, pristine physics of the laboratory finally merged with the messy, desperate clinical survival data from the cholera wards.
And that gave us the formulas.
Yep, eventually yielding the precise 5E formulas we rely on today.
But here's where the narrative takes a really sobering turn, I think.
Yeah.
Because we often think of modern medicine as this steady, unimpeachable march of progress. But the sources highlight a terrifying complacency that eventually set in.
He did.
The medical establishment got comfortable, and they got some major things wrong. Which brings us to the holiday cigar failure.
Yeah, this is one of the most sobering case studies in modern pediatric medicine, honestly.
It really is.
In 1957, two well-respected doctors, Holliday and Cigar, developed a formula to calculate the daily maintenance IV fluids required for children who couldn't eat or drink.
Okay.
Their formula was mathematically brilliant for calculating the volume of fluid a child needed based on their weight. But the type of fluid they recommended to fulfill that volume was heavily hypotonic.
Right, because they based their fluid composition on the electrolyte profile of healthy breast milk and cow's milk.
Which sounds logical, right?
It sounds totally logical at first glance.
It sounds logical until you realize that healthy milk is processed slowly by the gastrointestinal tract of a healthy infant.
Oh, right.
It is not injected directly into the systemic circulation of a sick, stressed child lying in a hospital bed.
Yeah, that's a huge difference.
When a child is hospitalized with an illness or undergoing surgery, their body naturally panics. It releases a flood of stress hormones, specifically antidiuretic hormone, which screams at the kidneys to stop producing urine and hold on to every drop of water possible.
So the kid's body is already aggressively hoarding water.
Exactly.
And then the medical team pumps bags of hypotonic fluid, which, as we established earlier, leaves behind a massive load of free water directly into their veins.
The result was severe dilution of the blood. The sodium levels in these children would plummet to dangerously low levels.
Wow.
It's a condition called hospital-acquired hyponatremia.
And if the sodium in the blood drops too low, the blood becomes hypotonic compared to the brain cells.
Yes.
So the water rushes into the brain, causing the exact cerebral edema we talked about earlier.
Exactly. And for over 50 years, the undisputed textbook standard for pediatric maintenance fluids was quietly causing neurological damage, seizures, and in several tragic cases, death.
Just from the routine fluids.
Simply from the routine IV fluids ordered upon admission. It wasn't until 2018 that the American Academy of Pediatrics finally, officially reversed this half-century-old standard.
2018, that was practically yesterday.
I know. They issued strict guidelines that isotonic fluids must be the standard for pediatric maintenance.
50 years of standard practice, it is genuinely unsettling.
It is.
And it underscores just how delicate the body's sodium balance really is. Because the sources point out another complication of fluid mismanagement, and I actually had to read this section twice just to process the severity of it.
Oh, osmotic demyelination syndrome.
Yes.
Yeah, if you zoom out and look at the bigger picture of tonicity, osmotic demyelination syndrome is the devastating consequence of trying to fix a complex problem too quickly.
How so?
Well, if a patient comes into the emergency room with severe chronic hyponatremia, meaning their blood sodium has been dangerously low for days and their brain cells have slowly absorbed water and swollen to adapt to this new environment, a clinician might look at the lab results and think, I need to give them highly concentrated hypertonic saline right now to fix this number.
Right. I mean, the tank is low on salt, so just dump the salt back in.
But if you correct that sodium deficit too rapidly, you radically shift the tonicity in the opposite direction.
Oh.
The hypertonic saline violently sucks the water back out of the adapted brain cells. It shrinks the cells so rapidly and aggressively that it physically tears the myelin sheath.
Which is the insulation, right?
Exactly. It's the protective fatty insulation wrapping around the nerve fibers in the brainstem. You are effectively stripping the insulation off the brain's wiring.
That sounds horrific.
It causes irreversible neurological damage, locked-in syndrome, or even death. It is a permanent reminder that in fluid resuscitation, the velocity of the fluid shift is just as dangerous as the shift itself.
Wow. So with all these historical blind spots and microscopic tightropes that clinicians have to walk, you would think we have it all perfectly mapped out now.
You would think.
But I noticed a huge ongoing conflict in the critical care sources. It seems like a modern group of doctors started demanding massive trials to challenge the fluids we use every single day.
Yeah, the science of critical care fluid therapy is far from settled. If you look at the modern landscape, 2 massive clinical trials have completely disrupted the status quo.
The SAFE trial and the SMART trial.
Exactly.
Okay, let's tackle the SAFE trial first because this gets into the debate between crystalloids and colloids.
Right.
Everything we've discussed so far, saline, dextrose, these cheap bags of dissolved salts and sugars, those are crystalloids.
Correct.
But the sources define colloids as fluids containing massive molecules like human albumin, which is like a large protein derived from blood plasma. But from what I understand, the argument for using these expensive proteins all comes down to the Starling equation.
Yes, it does.
I want to try explaining this, actually, because it really changed how I view the cardiovascular system.
Oh, go for it.
Okay, so we tend to think of our blood vessels as solid rubber pipes, but the capillaries are actually semi-permeable.
Right.
So they're more like porous soaker hoses in a garden. Water can easily leak out of them to the surrounding tissue, causing severe swelling.
Exactly.
But according to the Starling equation, the giant proteins naturally floating in our blood act like water magnets.
Yes.
They are physically too large to leak out through the pores of the soaker hose, so they stay inside the blood vessel and hold onto the water with a pulling force called oncotic pressure.
That is a phenomenal way to explain oncotic pressure.
Thanks.
And that was the fundamental theory behind using colloids. Clinicians argued that if a patient is critically ill and their blood vessels are leaking, we shouldn't just pump in cheap salt water that will immediately seep right into the tissues.
That makes sense.
They thought we should pump in expensive colloid proteins to act as massive magnets, pulling the water back into the pipes and keeping it there.
Okay.
So the SAFE trial was this massive international effort designed to finally prove that colloids were superior for saving lives in the ICU.
But the results didn't exactly match the theory, did they?
They did not. The SAFE trial demonstrated that, for the vast majority of critically ill patients, resuscitation with cheap, basic crystalloid salt water resulted in the exact same mortality rates as the expensive albumin colloids.
Wow, really?
Yeah. While there are still very specific niche uses for colloids, like in certain liver failure patients, the trial proved that for everyday critical care, the basic physics of salt and water are sufficient.
Which brings us to the SMART trial and our final mind-bending fact from the beginning of the deep dive.
Yes.
The myth of normal saline.
Yes. So 0.9% sodium chloride is universally referred to as normal saline.
Right, you hear it all the time.
It is the most ubiquitous, heavily utilized IV fluid on the planet. But from a purely physiological standpoint, it is incredibly abnormal.
Wait, really?
Yeah. Human blood plasma has a chloride concentration of roughly 100 milliequivalents per liter. Normal saline contains 154 milliequivalents of chloride per liter.
That is over 50% more chloride than the human body is designed to handle.
Exactly. And when a trauma patient or a sepsis patient requires massive volume resuscitation and you pump liters upon liters of normal saline into their veins, that immense unnatural chloride dump wreaks havoc.
I can imagine.
The heavy chloride load constricts the blood vessels inside the kidneys, starving them of oxygen, and it actually induces a state of metabolic acidosis.
Oh, wow.
So the SMART trial was designed to confront this exact blind spot. It compared traditional normal saline against balanced crystalloids.
Balanced meaning what?
Fluids like lactated ringers, which are specifically engineered with buffers to closely mimic the actual electrolyte balance of human blood.
And the results of the SMART trial are actively changing how hospitals operate today, right?
Absolutely. The evidence clearly shows that using balanced fluids instead of normal saline leads to significantly fewer kidney injuries, less need for dialysis, and lower overall mortality in critically ill patients.
That's huge.
We are watching a real-time paradigm shift as modern medicine finally questions the normal saline we've relied on for over a century.
It really emphasizes that no medical intervention, no matter how ubiquitous or seemingly simple, should ever be exempt from rigorous questioning. So let's synthesize everything we've covered today. We have dismantled the plumbing analogy. We've seen that IV fluids are absolutely not just water.
Not at all.
They are highly calculated chemical tools governed by the strict physical laws of tonicity. We explored the d-phi-W paradox, where an isotonic label disguises a hypotonic effect.
Yep.
We talked about the life-saving physics of intentionally shrinking brain cells or swelling dehydrated tissues. And we unpacked the historical tragedies and modern trials, from the 50-year holiday cigar pediatric error to the ongoing movement away from normal saline.
Right.
Which all proves medical science is always, sometimes painfully, evolving.
The main takeaway for you as a listener is that the next time you are in a hospital or you see that clear plastic bag dripping on a medical drama, you're going to look at it with completely new eyes.
Definitely.
It isn't just hydration. It represents a microscopic, calculated manipulation of the physical laws of water inside the human body. Every single drop interacting with millions of cells, governed by equations that took centuries to map out.
I love that. And, I want to leave you with one final thought to mull over. Building on these rules of water movement.
Okay.
We have spent this entire discussion exploring how tonicity and hydrostatic pressure force water to move in a gravity-bound human body.
Right.
But what happens when we leave the planet?
Oh, wow.
Right. In the microgravity of space travel, astronauts lose the normal hydrostatic pressure that pulls blood into their legs. Their bodily fluids naturally shift upward into their chest and head, which is why astronauts often have puffy faces in orbit.
Yeah, I never thought about that.
Yeah, and as we prepare for long-duration missions to Mars, aerospace medicine is having to completely reimagine IV fluid resuscitation.
That is fascinating.
How do you manipulate tonicity, and where does the water decide to go when the fundamental pull of gravity is removed from the equation? It turns out the final frontier medicine might just be relearning how to hydrate a human cell in the stars. You know, usually when we talk about a medical diagnosis, there's this expectation of precision.
Right, like a math problem or something.
Exactly. It feels like engineering. Like you break your arm, the X-ray shows a jagged white line, and the doctor just points at it and says, there it is.
Yeah, you fix the part or you replace the part.
Right. But what happens when the part you need to replace isn't a bone, but a profoundly complex chemical processing plant inside your own body? Like, what does it actually mean to mechanically replace a human organ?
It's a monumental task.
Yeah.
And honestly, it is one we are still trying to perfect, even decades into doing it.
Which is exactly why we are taking you on this deep dive today. We've pulled together this massive stack of sources, so everything from modern nursing protocols and nephrology history to some incredibly intense medical ethics case studies.
There's some really heavy stuff in there.
Oh, absolutely. And our mission today is to understand exactly how we artificially replicate kidney function, the split between hemodialysis and peritoneal dialysis, and really the frontline nursing care that literally keeps these patients alive.
Yeah, the nurses are doing incredible work.
But before we get into the plumbing of it all, we need to debunk a massive misconception. Because when you hear dialysis, the first thing you tend to think is that it's just an artificial kidney that cleans the blood and boom, cures kidney failure.
Right. And nephrologists are very careful to push back on that exact framing because a native biological kidney does far more than just, filter out the garbage.
It's doing other things simultaneously.
Exactly. It acts as a whole endocrine organ. It produces erythropoietin, which is the hormone that tells your bone marrow to make red blood cells. It activates vitamin D for your bone health. It finely tunes your acid-base balances and your electrolytes minute to minute.
Wow.
And dialysis doesn't do any of that hormonal work.
So it is purely replacing the filtration and the fluid removal.
Only the filtration and fluid removal. And it does so intermittently, like in bursts, rather than continuously. This is why a patient on dialysis still needs a ton of medications for anemia and bone disease.
Because the machine isn't doing the hormone part?
Right. In modern nephrology, they measure how much kidney function has been replaced using this quantitative target called KTV.
Okay, let's unpack this. KTV. What do those letters actually represent when we are talking about a patient sitting in a clinic?
Well, it's a mathematical formula for clearance. So the K stands for the dialyzer's clearance rate. Basically how fast the machine can process the blood.
Got it. And the T?
The T is time, meaning how long the session lasts. And the V is the volume of water distributed throughout the patient's body, which is what actually holds the toxins.
Oh, I see. So it's personalized to the patient's size.
Exactly. The goal is to ensure enough blood is cleared relative to their specific volume, and a common target for a single hemodialysis session is about 1.2.
Okay, 1.2. And if a patient hits that target perfectly, how much of their normal native kidney function have we actually replaced?
Roughly 10 to 15%.
Wait, really? Only 10 to 15%?
Yeah, that's it.
Man, if 15% is the gold standard of what our modern machines can do, how did humans ever figure out how to replicate even that much of a biological organ?
The underlying chemistry actually goes way back to the 1850s. There was a Scottish chemist named Thomas Graham, and he described dialysis as this separation technique.
Okay, 1850s. But putting that into a person is a whole different ballgame.
Oh, completely. Applying that theoretical chemistry to a living human body took decades. The first attempt at hemodialysis on a human was in 1924 by a German physician named Georg Haas.
What kind of equipment was he even using in 1924? Like, they didn't have synthetic plastics or advanced medical tubing back then?
No, they didn't. He had to improvise with what was biologically available, so he used animal membranes for the tubing. And to keep the patient's blood from clotting outside the body, he used hirudin.
Hirudin? Wait, isn't that...
It is an anticoagulant derived directly from leeches.
Oh, wow. He pumped leech extract into a human's bloodstream to keep a machine running.
It was literally the best anticoagulant available to him at the time.
That is wild.
But unfortunately, Haas only dialyzed patients for very brief periods, and none of them survived long term. The technique was largely abandoned because it just seemed impossible to execute safely.
So it just stalls out.
Right, until World War II. In the Nazi-occupied Netherlands, there was a Dutch physician named Willem Kalf, and he was just agonizing over these young patients dying of acute kidney failure.
Right.
He believed if he could just clear the toxins from their blood temporarily,
Right.
their native kidneys would have the time they needed to actually recover.
So he decides to build his own machine, but he is in the middle of a literal war zone.
Yeah, he built a rotating drum artificial kidney out of whatever he could scavenge. So he used sausage casing, specifically cellophane tubing, wrapped around a wooden drum, and he rested it in a bath of fluid made from orange juice cans.
Sausage casings and orange juice cans? That is incredible. And the
Right.
sources note that the first 15 patients he tried this on died.
Yeah, but he didn't stop. In 1945, his 16th patient, who was a woman in a uremic coma, recovered. She was the first documented patient saved by an artificial kidney.
Wow.
And Kolff actually refused to patent his designs. He wanted this life-saving technology to spread globally as fast as possible.
Which is amazing.
It really is. It allowed others, like this Swedish nephrologist Nils Elwall, to iterate on the design. Elwall added controlled negative pressure so they could adjust fluid removal separately from waste removal.
Okay, I am trying to visualize this process in the body. If we're using cellophane and pressure, is it essentially just a macroscopic wooden Brita filter? Like you just push the blood through a sieve and the bad stuff gets caught?
Not exactly. The Brita filter analogy actually falls a bit short of the physics involved.
Oh, really?
Yeah, a water filter is just a physical sieve. You push water through tiny holes and the big particles get stuck. But dialysis relies on two specific physical principles working across a semi-permeable membrane. The first is diffusion.
Which means the waste doesn't just get trapped, right? It moves on its own.
Exactly. Molecules of waste, like urea and potassium, naturally seek equilibrium. So they move from an area of high concentration, which is the dirty blood, to an area of low concentration, the clean dialysate fluid on the other side of the cellophane.
Okay, making sense.
And then the second principle is ultrafiltration. This is where you use a pressure gradient, or osmosis, to actively pull excess water out of the blood. What's fascinating here is that Kolff solved the chemistry of pulling waste and water out, but his therapy still had a massive fatal flaw.
Which was what?
It could only cure acute kidney failure, someone who just needed to be hooked up once or twice.
Because they couldn't keep hooking them up over and over again.
Right. In the 1940s and 50s, accessing a vein or artery meant surgically cutting into it. If you do that a few times, the vessels scar shut or they clot.
And once you run out of viable veins, the treatment ends.
Exactly. Chronic, lifelong dialysis was medically impossible because you simply couldn't keep connecting the patient to the machine week after week.
So we have this functioning machine that can save a life, but a permanent bottleneck in how to actually connect it to the human body.
Yep. And that bottleneck was solved in 1960 by Belding Scribner, a physician in Seattle. He developed a Scribner shunt.
The Scribner shunt, what was that?
It was a small U-shaped Teflon tube that connected an artery and a vein outside the skin, and it was just left in place between treatments.
Oh, so they didn't have to keep cutting.
Exactly. That little Teflon tube allowed repeated, painless access to the bloodstream. It made chronic hemodialysis a reality.
And that unlocks the mechanics of modern hemodialysis, or HD. Which, crazy.
Wait.
Today, blood is pumped out of the body at a rate of, 300 to 500 milliliters per minute?
Yeah, that's right.
And it goes into a dialyzer, which is this canister packed with thousands of microscopic, hollow synthetic fibers.
And the most crucial detail of that modern dialyzer is something called countercurrent flow.
Countercurrent flow.
Right. The blood flows inside the fibers in one direction, while the dialysate fluid flows around the outside of the fibers in the totally opposite direction.
Hang on. If the blood and the clean fluid are flowing in opposite directions, why is that better? Like, I'm not seeing the physics of why that speeds up the cleaning process.
Okay, think about it like this. If the blood and the fluid flowed in the same direction, the waste concentrations would just balance out halfway down the tube.
Oh, and diffusion stops.
Exactly. Remember, diffusion relies on a gradient. Once the fluid is just as dirty as the blood, the waste stops moving. By flowing in opposite directions, the cleanest fluid is constantly meeting the cleanest blood at the very end of the line, while the dirtiest fluid meets the dirtiest blood at the beginning.
So you maintain a concentration gradient across the entire length of the dialyzer.
You got it. It maximizes efficiency.
Okay, so the mechanics are highly refined, but it still requires serious vascular access. A patient needs a surgically created AV fistula-like, a reinforced connection between an artery and a vein, or a synthetic AV graft, or a central venous catheter. And this requires the patient to sit in a clinic for 3.5 to 4 hours, 3 times a week.
It is a massive lifestyle disruption.
Yeah.
Going back to the early 1960s, the introduction of the Scribner shunt created an entirely new crisis.
Because suddenly everyone could theoretically live.
Right. Chronic treatment was possible, but the machines and the personnel were incredibly scarce.
So we have the technology to save lives, but a hospital might only have one machine and 50 patients who desperately need it.
Exactly. There was a guy named Clyde Shields, a machinist in Seattle in 1960, and he became the very first chronic hemodialysis patient. He lived over a decade on dialysis, proving this wasn't just a stopgap.
Wow, a whole decade.
But by 1962, the Seattle Artificial Kidney Center was completely overwhelmed. They had to form an anonymous committee of lay people to choose who would receive the life-saving treatment and who would be sent home to die.
Oh, man. The sources refer to this as the God Committee, which is a nickname given by Life magazine at the time. It's an agonizing piece of medical history. You have a panel of ordinary citizens like a lawyer, a minister, a housewife, a labor leader sitting in a room looking at anonymous patient files.
It remains one of the most studied cases in medical ethics regarding resource rationing because they had to weigh criteria like age, gender, marital status, number of dependents, income, net worth, and even church attendance.
That is incredibly heavy.
They were basically trying to determine social worth to allocate a scarce medical resource.
And the financial cost was also astronomical for the average person. This rationing and financial burden really reached a tipping point in 1971. A patient and activist named Shep Glazer went to Washington, D.C. He actually underwent dialysis physically on the floor of a congressional committee room with a needle in his arm. He wanted to visually demonstrate to politicians that ordinary Americans were dying simply because they couldn't afford access to this machine.
And that demonstration profoundly impacted the legislature. It directly led to the 1972 Medicare End-Stage Renal Disease Program.
Which is wild because it is the only disease-specific entitlement in U.S. healthcare history. If you have kidney failure in the United States, Medicare covers you, regardless of your age. The government basically just absorbed the cost.
Yeah, the funding was secured, which expanded access immensely.
Mm-hmm.
But the medical field was still figuring out how to deliver the therapy safely. They initially assumed that if someone's blood is full of lethal toxins, the goal should be to clean it as rapidly as possible. Just run the machine on the highest setting.
I mean, that seems like common sense. Get the poison out quickly.
Here's where it gets really interesting, though. It led to a severe complication we now call dialysis disequilibrium syndrome.
What happened?
Doctors didn't count for the unique physics of the blood-brain barrier. When you pull urea out of the blood extremely fast, the blood becomes clean very quickly. But the urea trapped inside the brain tissue takes much longer to cross back into the bloodstream.
So you end up with a high concentration of waste in the brain, but a low concentration in the blood.
Which creates a massive osmotic gradient. Water always follows solutes, so water literally rushes from the blood into the brain tissue to try and balance out that concentration. Yeah, this causes the brain to swell rapidly, cerebral edema. Patients experience severe headaches, confusion, and in the worst cases, seizures and coma.
Wow. The cure was moving too fast for the body's compartmentalized chemistry, so how is that prevented today?
A patient's first few dialysis sessions are deliberately shortened and run at a much slower speed, just allowing the brain time to equilibrate with the blood.
That makes total sense.
They also had to learn infection control through some tragic trial and error. In the 1960s and 70s, many centers reused dialyzers and tubing across different patients just to save money.
Because sterilization protocols weren't what they are today.
Exactly. And it sparked massive hepatitis B outbreaks among patients and staff.
Which fundamentally reshaped modern CDC infection control protocols. It's the primary reason hepatitis B vaccination is absolutely mandatory and heavily tracked for dialysis patients and staff today.
Definitely. And, throughout all this development in hemodialysis, there were researchers asking a completely different question. Is there a way to do this without a blood circuit at all, like without ever removing blood from the body?
And this brings us to peritoneal dialysis, or PD.
Right. In 1968, a surgeon named Henry Tankoff developed a durable, implantable silicone catheter. Then in 1976, researchers Popovich and Moncrief described a continuous ambulatory method.
But how exactly do you filter the blood without pulling it out of a vein?
You use a filter the patient already has inside them. The peritoneal membrane.
Yeah, the abdominal lining.
Yes. It is the thin lining of your abdominal cavity, and it is richly supplied with tiny capillary blood vessels. So in PD, sterile dialysate fluid containing dextrose, which is sugar, is infused into the belly through that permanent Tankoff catheter.
And it just sits there?
Yep, it just sits there, or dwells in the abdomen. The sugar in the fluid creates an osmotic pull, drawing waste and excess water out of the surrounding capillaries and right into the fluid. After a few hours, the dirty fluid is just drained out and discarded.
And patients can do this manually about 4 times a day, or they can use a machine called a cycler that does it automatically overnight while they sleep. It completely removes the need to sit in a clinic 3 days a week.
It's a game changer.
But looking at the modern landscape, you have these two totally different systems: the blood circuit of HD and the abdominal fluid of PD. For a long time, there was a debate over which one was actually better.
Right. Yeah, there was this pervasive misconception that PD was just a lesser backup if the patient's veins couldn't handle HD. But when you look at large registries today, survival rates are comparable.
Really, they're about the same.
Basically, yeah. The difference lies in the shape of the lifestyle trade-off. PD better preserves any residual kidney function the patient still has left. Because it's continuous, it avoids the harsh fluid and chemical swings of HD. It also offers immense autonomy since it happens at home.
While HD offers intensive, heavily supervised clearance where medical professionals manage the entire process.
Exactly. The choice today really hinges on the patient's lifestyle, their other medical conditions, and their caregiver support at home. It's not a question of medical superiority.
And because dialysis essentially outsources an automatic biological function to a highly periodic human-managed process, the actual day-to-day survival of the patient falls incredibly heavily on specialized nursing care.
Oh, entirely.
Take hemodialysis nursing. A patient walks in, sits in the chair. What is the nurse looking for before they even turn the machine on?
The very first priority is the vascular access. If the fistula fails, the patient cannot get treatment. Period. So a nurse will assess an AV fistula by palpating it, feeling the skin over the vein for a vibration called a thrill.
Thrill!
Yeah, that vibration indicates turbulent, healthy blood flow. Then they use a stethoscope to listen for a bruit, which is the corresponding whooshing sound of that flow. If the thrill or the bruit is missing, the fistula may have clotted.
But how does a nurse even know if a newly surgically created fistula is robust enough to be used? Because those needles are massive.
Right, they use a clinical heuristic called the rule of sixes. For a fistula to be mature enough to withstand the thick dialysis needles, it should be about 6 weeks old, 6 millimeters in diameter, no more than 6 millimeters deep under the skin, and have a blood flow of about 600 milliliters per minute.
6s across the board, got it. And during the actual session, the nurse is fighting the physics of the fluid removal. Like they have to monitor for intradialytic hypotension, which is a sudden, dangerous drop in blood pressure.
Because the machine is pulling fluid out of the vascular system faster than the body can refill it from the tissues.
Exactly. And between sessions, the patient is given strict fluid limits. You can't just drink a gallon of water because your body has no physical way to excrete it until you sit back down in that chair 2 days later.
Not just fluid either. It's strict potassium and sodium limits as well.
Right.
Now contrast that highly monitored clinic environment with peritoneal dialysis nursing, where the patient is managing their own care at home.
The risks there must be completely different since there is no blood circulating through a machine.
Completely different. The core priority for a PD nurse is teaching meticulous sterile technique. Because the patient is repeatedly accessing their own abdominal cavity, peritonitis, which is an infection of the peritoneum, is the absolute greatest risk. It is to PD what vascular access failure is to HD.
And the sources mention that the primary warning sign for peritonitis is something the patient has to watch for every single day when they drain the fluid.
Yes, cloudy effluent. When the dialysate is drained out of the belly, it should be clear. If it is cloudy, that indicates the presence of white blood cells, meaning an infection has started.
And that's dangerous.
Very. Untreated peritonitis can scar the peritoneal membrane so badly that it permanently destroys the patient's ability to use PD ever again.
Wait, because the PD fluid is packed with dextrose to create that osmotic pull, do patients absorb that sugar?
They do, which means nurses have to constantly monitor for hyperglycemia, especially in diabetic patients. And there's another mechanical complication that is highly emphasized in PD nursing: constipation.
Constipation seems incredibly minor compared to blood infections or brain swelling.
I know, it sounds minor until you visualize the anatomy. A full bowel can physically press against the internal silicone catheter. It kinks the tubing inside the abdomen, preventing the fluid from draining out. A simple GI issue can literally bring the entire life-saving therapy to a halt.
Wow. When you step back and look at all of these moving parts, dialysis isn't just a machine you plug into. It is a massive, collaborative lifestyle overhaul. I mean, we started with Willem Kalf spinning sausage casings and orange juice cans in a wooden drum.
Yeah, we've come a long way.
We really have. We explored Belding Scribner's simple Teflon tube that made chronic treatment possible and the ethical weight of the God Committee that followed. We broke down the opposing physical mechanisms of HD and PD and the vital, highly technical world of dialysis nursing, where thrills, brutes, and sterile techniques dictate survival week after week.
This raises an important question as we look forward. Dialysis represents our ultimate, ongoing attempt to mechanically hack human biology. But the dialysis population is aging, and it's growing, driven largely by global rates of diabetes and hypertension.
It's expanding rapidly.
Right. We have to ask ourselves, how sustainable is it to rely on a system that requires humans to manually replicate an organ's job perfectly week after week for the rest of a patient's life? Are we pushing toward a future where we must innovate beyond the machine entirely?
It brings us right back to the beginning. We've built an incredible machine to replace the part, but it's still a machine trying to do the work of a biological masterpiece. Thank you for joining us on this deep dive. Take a moment today to appreciate those two bean-shaped marvels working quietly in your lower back, keeping your chemistry perfectly balanced without you ever having to think about it. We'll catch you on the next one. Imagine your heart right now just beating in your chest. Usually it's this perfect, reliable metronome, tick, tock, squeeze, release.
Yeah, completely in the background.
Right. It's this masterpiece of biological engineering, and it quietly does its job without you ever having to think about it.
And we take that predictable rhythm entirely for granted. I mean, the moment you start actually feeling every single heartbeat, something has fundamentally changed.
Exactly. But imagine that metronome suddenly shatters. It just breaks and turns into this chaotic, quivering storm. It starts firing completely out of sync, totally unpredictable. That is atrial fibrillation.
Or what you'll usually hear called a fib.
Yes, a fib, which is what we're diving into today.
It's the absolute definition of electrical chaos inside the human body.
It really is. AFib completely rewrites the rules of how the heart is supposed to function, changing it from this organized pump into an erratic, trembling muscle. And so today, we are exploring the clinical and historical notes on a fib, specifically focusing on the nursing and medical angle. We're calling this deep dive the irregular rhythm that throws clots.
I like that title. Very accurate.
Thanks. We're going to unpack what it is, why it quintuples your risk of a stroke quintuples, and how the medical understanding of this condition has flipped like multiple times over the decades.
And understanding this is so crucial for you listening because AFib is not some rare medical anomaly. It is one of the most common sustained arrhythmias on the planet.
Yeah, it's everywhere now.
It really is. Our global population is aging, which means prevalence is just skyrocketing. I mean, millions of people now have smartwatches buzzing on their wrist with these irregular rhythm alerts.
Which is terrifying to wake up to, I'm sure.
Oh, absolutely. So whether you're a nursing student cramming for the NCLEX or a medical professional or just, someone trying to track your own heart health, a fib is something you will inevitably encounter.
And it's wild to think we're now getting wrist alerts for something doctors spent literally centuries trying to decipher just by touching a patient's wrist.
Right. The history here is fascinating.
The historical notes show physicians were noticing these highly irregular pulses long before they had any clue about the underlying mechanism.
Yeah, you can actually trace it back to 1749.
1749, that's what, George Washington was a teenager?
Basically, yeah. There was this French physician named Jean-Baptiste de Sénac. He was feeling the pulses of patients with severe mitral valve disease and documenting this highly irregular, rapid pattern.
Just by touch.
Just by touch. But the terminology really became evocative, I'd say, in 1876. That's when a clinician named Carl Wilhelm Hermann Nothnagel described the phenomenon simply by feeling it at the bedside.
And he gave it a great name.
He did. He coined the term delirium cordis.
Delirium of the heart.
Exactly.
That is just an incredibly vivid way to describe a pulse, but purely descriptive, right? I mean, they had absolutely no mechanistic explanation for why the heart was delirious.
Isn't it all? To move from feeling a delirious pulse to actually mapping an electrical storm, that required a massive technological leap.
Enter the early 1900s.
Yes. A Dutch physiologist named Willem Einthoven invented the string galvanometer.
Which sounds like a steampunk instrument.
It kind of was. This was the first real electrocardiogram, the ECG, and it actually won him the 1924 Nobel Prize.
I always wonder how they actually pulled that off before modern computers. Like, how do you visualize human electricity in the early 1900s?
Well, it was a brilliant piece of analog engineering. Einthoven suspended this microscopic silver-coated quartz string,
Wait, an actual physical string?
the physical microscopic string. He suspended it between two powerful electromagnets. And when the tiny, almost imperceptible electrical currents from a patient's heart passed through that string, the magnetic field caused it to twitch and move.
That is unbelievable.
Right. And he shined a bright light on it, so the moving string cast a shadow onto a scrolling roll of photographic paper.
So the shadow of this twitching string physically drew the electrical waves of the heart.
You got it. The very first ECG tracings. Einthoven captured these early recordings showing a chaotic, undulating baseline where the normal, organized electrical wave, what we now call the P wave, was just entirely missing.
Just gone.
But it was British cardiologist Sir Thomas Lewis who put the puzzle together around 1909. He connected Einthoven's visual tracings to that delirium cordis that clinicians had been feeling for, well, 150 years.
And he coined the modern term, right?
Close. He coined the term auricular fibrillation.
Oh, because atria were called auricles back then.
Exactly. But he proved that the irregular pulse was the surface signature of disorganized electrical activity.
So let's talk about that disorganization, because under normal conditions, you have the SA node, the sinoatrial node, that's your heart's natural pacemaker. It sends one clean, sweeping electrical wave down through the upper chambers, the atria, to trigger a coordinated squeeze.
One clean wave.
But in a fib, that clean wave is completely hijacked.
It is. Instead of one wave, you have 400 to 600 disorganized microwavelets firing simultaneously every single minute.
400 to 600 impulses a minute is terrifying.
It's pure static.
If those all went through, the heart would just vibrate itself to death, wouldn't it?
It would be entirely unsurvivable, which is why the AV node, the atrioventricular node, is so critical here.
The biological gatekeeper.
Right. It sits between the upper and lower chambers. The AV node gets bombarded by these 600 impulses, but it just refuses to let them all pass.
Yeah.
It only lets an irregular, unpredictable subset of them through to the ventricles.
Which is why the hallmark physical finding of a fib is that irregular pulse. There's no repeating pattern in timing or strength.
None.
It makes me think of a frantic bouncer at a nightclub.
Oh, I like that analogy.
Yeah, so you have this unruly mob of 600 people outside the doors just pushing and shoving, and the bouncer is totally overwhelmed. He's just randomly grabbing people. You can go, you stay, you go, you go, you stay. He's only letting a random few through the door at a time. And the result on the dance floor, the ventricles, is completely unpredictable.
That is perfectly put. The ventricles are only responding to whichever impulses the AV node lets pass the velvet rope.
But diagnosing this isn't just about feeling the chaos anymore.
No, to formally diagnose this chaos, the American Heart Association, the Heart Rhythm Society, and the European Society of Cardiology all require a very specific threshold. You need to see this chaotic activity on an ECG for at least 30 seconds to officially call it a fib.
Wait, why 30 seconds?
Good question.
Like, what if my heart quivers for 28 seconds? Is 30 just a neat round number someone made up to make medical textbooks look organized?
It sounds arbitrary, I know, but shorter runs of atrial irregularity are actually quite common in human beings, and they're usually clinically insignificant.
Oh, really?
Yeah. The 30-second cutoff was specifically chosen because that's the threshold where the finding becomes highly reproducible on clinical monitoring and, more importantly, clinically actionable.
Meaning that's the point where a patient's risk profile demonstrably starts to shift.
Exactly.
And that risk shift is huge because if the heart is just quivering and not doing that nice clean metronome squeeze, the blood itself is not moving properly.
No, it's not.
And that mechanical failure leads directly to the deadliest consequence of a fib.
The clot.
The clot. To understand this clot risk, the notes bring up a 19th century concept called Virchow's triad.
Yes, Rudolf Virchow. He outlined the three perfect conditions for thrombosis or blood clotting: stasis, endothelial injury, and hypercoagulability.
And all three of these play out with devastating precision inside a fibrillating atrium.
They really do. Let's start with stasis. Because the atria are quivering like a bag of worms instead of firmly contracting, the blood doesn't get squeezed out efficiently.
It just sits there.
Right. And there's a very specific anatomical spotlight here: the left atrial appendage, or the LAA.
Right. The notes describe it as looking like a small, wrinkled, ear-shaped pouch hanging off the left atrium.
That's a good description. It has a narrow opening and a trabeculated, which means highly ridged interior.
So when the atrium stops squeezing, the LAA basically turns into a stagnant puddle. the blood just pools in those ridges.
And because that blood is stagnant, it triggers the other two parts of Virch's triad. The stagnant blood physically irritates and inflames the lining of that patch. That's your endothelial injury.
Okay, that's two.
And on top of that, the state of a fib itself is independently associated with elevated levels of clotting factors in the bloodstream. So, boom, there's your hypercoagulability.
The perfect storm.
Exactly. This stagnation and inflammation trigger what is known as the coagulation cascade. Specifically, the body starts producing fibrin proteins. These proteins weave together into this sticky net that traps passing red blood cells, creating massive fibrin-rich clots.
These are often referred to as red clots, right? Because of all those trapped red blood cells.
Yes, red clots. And the result of this perfect storm is a striking statistic. 90 to 95% of atrial clots in non-valvular AFib form, right there in that one tiny little pouch, the LAA.
90 to 95%. That is staggering.
It's almost all of them.
And it's not just that a clot forms, it's where it goes once it breaks free. Because when one of these massive red clots dislodges from the LAA, it shoots out of the heart right through the aorta, and it has a terrible tendency to go straight up the carotid arteries into the brain.
A direct flight to the brain.
It's not just throwing a pebble into the plumbing, it is sending a massive boulder straight toward the brain's main highways.
That's why these strokes are so severe. These clots are unusually large because they've been forming in that stagnant pouch. When they lodge in the brain, they block large proximal cerebral vessels.
Which is why the data from the famous Framingham Heart Study proved that AFib does not just raise your stroke risk, it quintuples it.
5 times the risk. And these specific cardioembolic strokes are significantly more fatal and more disabling than strokes from other causes, precisely because of the size of the clot.
So, since these strokes are so catastrophic, clinicians have to figure out who needs blood thinners without causing everyone to bleed out unnecessarily, right?
It's a delicate balance.
To solve this, they use the CHA or VASEC score to tally up a patient's risk factors.
Let's break that acronym down for the nursing students listening.
Right, so congestive heart failure, hypertension, age 75 or older, diabetes, prior stroke or TIA, vascular disease, age 65 to 74, and sex category specifically being female.
And each of these factors independently raises the baseline stroke risk. Generally, a score of 2 or more in men or 3 or more in women warrants putting the patient on a blood thinner. It's really a brilliant example of applying epidemiological data to risk stratification right at the bedside.
So you tally up the score, you hit the threshold, and you get a prescription. That seems incredibly straightforward until someone's Apple Watch chimes at 2 a.m.
Yes. The wearable tech disruption.
Sure. Modern technology is completely disrupting that neat scoring system. Historically, you either had a fib or you didn't. You went to the doctor, they hooked you up to an ECG, and boom, you were diagnosed.
Right, binary.
But now, implantable loop recorders and smartwatches are finding subclinical atrial high rate episodes, or AHREs, tiny episodes lasting just a few minutes.
And because of that, we have a flood of otherwise healthy people getting alerts on their wrists.
Right. And if my watch says I had a 3-minute episode, but I feel completely fine, like no palpitations, no dizziness, why would I take a risky blood thinner to treat a math equation on my wrist?
I hear this all the time.
Yeah.
But we have to firmly bust the myth that if you can't feel it, it can't hurt you.
Okay, let's bust it.
A substantial portion of all AFib, up to half in some populations, is completely silent. You feel absolutely nothing.
Wow, to half.
But silent AFib carries a stroke risk that is comparable to symptomatic AFib. The forming clot does not care if you felt your heart flutter. The CHED, your Graf score, does not care if you felt it.
But still, treating a 3-minute silent flutter with heavy-duty anticoagulants feels like an extreme escalation, doesn't it?
And that right there is the most heavily debated topic in cardiology right now. We recently had 2 major clinical trials, Artesia and NOAA-AFNET 6, designed specifically to answer this question about smartwatch-detected microepisodes.
And what did they find?
Well, they showed a modest reduction in stroke when treating these patients, but it was heavily balanced against a higher risk of severe bleeding from the drugs.
So a trade-off.
A huge trade-off. The medical community has not settled on a definitive threshold yet. The definition of a fib is quietly shifting from a binary diagnosis to a much murkier spectrum of electrical instability.
This tension, knowing the immense danger of a clot but fearing the complications of the intervention, it really explains why medical guidelines for a fib have flipped so dramatically over the years, especially when you look at the debate between rate versus rhythm control.
Oh, the great rate versus rhythm debate. Yes. There are two fundamentally different philosophies for treating a fib.
Oh.
Rate control basically accepts that the atria are broken and will keep fibrillating.
It just surrenders to the chaos.
Basically. It simply uses drugs like beta blockers or calcium channel blockers to slow down the AV node.
It's essentially telling that nightclub bouncer to slow down and let fewer people through so the ventricles aren't racing at a dangerous, exhausting speed.
Exactly. Keep the bounce. Rhythm control, on the other hand, refuses to accept the chaos.
It fights back.
It fights back. It uses antiarrhythmic drugs or electrical shocks called cardioversion to literally force the heart back into a normal sinus rhythm.
Or they use catheter ablation.
Right. In 1998, a French electrophysiologist named Michel Haït-Séguier revolutionized this by realizing the rogue electrical signals often start in the pulmonary veins. So electrophysiologists go in and literally burn or freeze the tissue to electrically isolate those veins.
And logically, you'd think everyone assumed forcing the heart back to normal would obviously be better. Normal has to be better than broken, right?
That was the universal assumption. Until 2002.
The AFFIRM trial.
The AFFIRM trial. It was massive, and it shook the cardiology world because it showed that aggressive rhythm control, hospitalizations, and adverse effects.
Okay, but how is forcing the heart back into a normal rhythm actually worse for the patient?
It came down to two major issues. First, the antiarrhythmic drugs available at the time were highly toxic. They successfully stopped a fib, sure, but they sometimes triggered other far deadlier ventricular arrhythmias.
Oh, so the cure was sometimes worse than the disease?
Literally. Second, the patients in the AFFIRM trial had often been in a fib for years. When the atria quiver for that long, they physically stretch out, scar, and remodel.
So you can't just electrically shock a permanently warped fibrotic chamber and expect it to behave perfectly.
Exactly. The hardware is damaged.
So for nearly 20 years, the medical consensus was to just leave most patients in a fib and slow their heart rate down. But then the eStaffNet-4 trial in 2020 flipped the guidelines again.
It did. eStaffNet-4 added a critical nuance that we missed. They found that early rhythm control does help reduce cardiovascular death and stroke, provided you catch the patient soon after they are diagnosed.
Catching it before the structural damage is done.
Yes.
If you stop the chaos before the atria permanently stretch out and scar, fixing the rhythm actually works. The timing is the treatment.
Precisely.
Yeah.
But whether you choose rate or rhythm control, you still have to deal with the stroke risk.
Right.
Which brings us to the blood thinners. And the most famous one has an origin story that honestly sounds like a Hollywood thriller. Warfarin.
This is my favorite part of the notes. This drug was not invented in some pristine pharmaceutical lab. It started in a pasture.
A literal field.
In the 1920s and 30s, farmers noticed their cattle were mysteriously bleeding to death. It turned out the cows were eating spoiled sweet clover, which contained a natural anticoagulant.
Is naturally occurring in the clover.
Researchers in the 1940s isolated the compound, decumerol, and they initially marketed a highly potent derivative of it as rat poison.
Yes. It was incredibly effective at causing the rodents to hemorrhage. But eventually, researchers realized that in carefully controlled human doses, it was a life-saving medicine.
Which is crazy to think about.
For 60 years, warfarin, derived from cattle-killing clover and rat poison, was the only oral drug we had to prevent fib strokes.
The journey from a dead cow to a rat trap to the gold standard of cardiac care, it's just unbelievable.
It's an amazing story. It worked by blocking the liver from using vitamin K to produce clotting factors, effectively starving the coagulation cascade. But it was notoriously difficult to manage.
It's because of the diet restrictions, right?
Right. Because it targeted vitamin K, if a patient ate a big salad full of leafy greens, the sudden influx of vitamin K would completely blunt the drug's effect.
So it required constant, tedious blood tests to ensure the blood wasn't too thick, leading to a stroke, or too thin, leading to a hemorrhage.
Which is why the cardiology world basically threw a parade in the early 2010s when the DOACs arrived, the direct oral anticoagulants.
Trials like ARLE-A, ROCKET-AF, and Aristotle proved these new drugs were a massive paradigm shift.
Massive. Instead of starving the body of vitamin K, DOACs act like chemical snipers. They target a single specific enzyme in the coagulation cascade like factor XA or thrombin and block it directly.
So patients can eat all the spinach they want because the drug doesn't care about vitamin K.
Exactly. And they prove to be just as effective and generally safer regarding catastrophic bleeding into the brain without needing constant blood draws.
But there are still patients who simply cannot take any blood thinner, right? They have a high bleeding risk, perhaps due to a history of gastrointestinal bleeds, but they also have a high stroke risk. What happens to them?
That is where the mechanical fix comes in. Remember that left atrial appendage, the LAA, where 95% of the clots form?
The little ear-shaped pouch?
Yes. Biomedical engineers asked a very simple question. Why thin the blood in the entire body when we can just plug the one pouch causing the problem?
Which is brilliant.
They developed LAA occlusion devices,
Yeah.
like the Watchman. The Protect AF trial showed you can deploy this little parachute-like plug right into the LAA, mechanically sealing it off.
So the blood can no longer pool in the ridges?
Right. The stasis is eliminated, and the risk is structurally removed.
So with treatments ranging from freezing the heart's veins to prescribing rat poison derivatives to implanting tiny parachutes, it is no wonder patients and even clinicians fall victim to dangerous misconceptions. Let's clear those up based on the clinical notes.
Let's do it.
Rapid fire. Myth number 1, AFib is basically the same thing as a heart attack.
Completely false. A heart attack is a plumbing issue, a blocked coronary artery starving the heart muscle of oxygen. AFib is purely an electrical issue in the upper chambers. You could have a perfectly clean plumbing system and still suffer a massive electrical short. They are mechanistically completely distinct.
Good to know. Myth number 2. If my doctor shocks my heart back into a normal rhythm, or I get an ablation, I can finally stop taking my blood thinners.
Okay, this is perhaps the most deadly misconception of all. Even after successful cardioversion or ablation, the atrium can remain electrically and mechanically stunned for weeks.
So you think you're fine, but you're not.
Right. Silent recurrences happen frequently. Your need for blood thinners is dictated strictly by your CHA risk score, not by whatever rhythm you happen to be in today. If your risk score is high, you stay on the thinners. Period.
That's a crucial takeaway. Myth number 3, and this is a big one for anyone studying pharmacology. I don't want to take heavy-duty blood thinners, so I'll just take a baby aspirin every day. It's a safe, gentle alternative.
The Avero's trial definitively closed the door on this. Aspirin is meaningfully less effective at preventing AFib strokes, and it still carries a real bleeding risk. Current guidelines have largely abandoned it for AFib.
As a conceptual clarification for the nursing students listening, you have to understand why aspirin fails based on what we discussed earlier. Aspirin targets platelets. It works beautifully on platelet-rich white clots that form when arterial plaque bursts.
Yes, the white clots.
But an AFib clot is different. As we established, it is a fibrin-rich red clot born out of stasis and the coagulation cascade in the LAA.
It's a completely different structure.
Using aspirin for a fibrin-rich AFib clot is like bringing a sponge to a grease fire. A sponge is a great cleaning tool, but it is fundamentally the wrong chemical tool for the makeup of the problem.
I love the grease fire analogy. You need true anticoagulants, the DOACs or warfarin, to target the fibrin cascade, not antiplatelet agents.
So, to summarize this wild journey we've been on, we started in the 18th century with a physician feeling a delirious pulse at the bedside.
Jean-Baptiste de Sénac.
We moved to Willem Einthoven, visualizing the electrical chaos with a twitching string. We uncovered the exact ear-shaped pouch where 95% of these massive clots form, and we talked about calculating the risk with the CACOYO VASC score.
And we are now in an era of modern debates sparked by Apple Watches, realizing that AFib is a complex spectrum of electrical instability.
It's not just a simple switch anymore.
No, and if we connect all this wearable tech back to the bigger picture, it raises a rather profound question.
Oh, I like where this is going.
Think about it. If smartwatches are now revealing that huge numbers of perfectly healthy, asymptomatic people occasionally have these brief, silent flutters of AFib.
Right, the silent episodes we talked about.
Yeah, it makes you wonder about the future of human health. When we reach a point where we can monitor every single electrical impulse of the body 24/7, will we discover that normal does not actually exist? Maybe everyone is just a little bit irregular.
I mean, if you look closely enough at any metronome, maybe none of them are truly perfect. That is something to think about. Thank you for joining us on this deep dive. Keep questioning the things you take for granted, keep learning, and don't forget to check your pulse. You know, it is completely wild to think about, but just a century ago, gardening was essentially an extreme sport.
It really was. I mean, a simple scratch from a rose bush or, a blister from a stiff new pair of shoes
Could literally be a death sentence. You get a little dirt in a cut, the area gets red, streaks start traveling up your arm, and, well, that was it. Game over. You just hope your affairs are in order.
Right. There was absolutely no safety net. Human beings lived entirely at the mercy of microscopic organisms. We were losing a massive invisible war that we didn't even fully understand yet.
But then we found the ultimate safety net, right? Antibiotics. And because they worked so miraculously well, we basically immediately started taking them for granted. Which brings us to our mission today. We are taking a deep dive into the fascinating high-stakes world of these life-saving drugs.
Yeah, and we're going to look at them specifically through the lens of the people on the front lines of healthcare. So, nurses, clinical pharmacists, the people actually administering these medications to you.
Exactly. We need to understand how these drugs actually hunt down bacteria, why the safety net is suddenly fraying, and why that golden rule you grew up with, always finish your prescription, is suddenly at the center of a massive medical debate.
Yeah, because the era of just casually throwing a Z-Pack at every sniffle, that era is rapidly closing.
Okay, let's unpack this. Before we get into the looming crisis, we really need to figure out what an antibiotic actually is. And from what I understand from our sources, the definition itself is a bit of a moving target.
It has shifted quite a bit, actually. Originally, an antibiotic was strictly defined as a weapon used in microbial warfare.
Microbial warfare?
Yeah. So it had to be a natural compound made by one living microbe to kill another living microbe. Think of like a mold in the soil fighting off a nearby bacterium for resources.
Right. So under that strict old school definition, if a scientist creates a germ-killing drug entirely from scratch in a chemistry lab, it's not technically an antibiotic.
Precisely. Historically, strict pharmacology textbooks would insist that fully synthetic drugs were antimicrobials or antibacterials, but not antibiotics. But in modern clinical and nursing fields, the term has completely broadened.
Oh, okay.
Today, it essentially means any drug used to treat a bacterial infection inside the body, whether it was found in a damp forest or, built molecule by molecule in a lab.
Good to know. So we don't get tripped up by old textbook definitions if we're reading the literature. Now, the story of how we actually found these things, it is full of drama. When you read the history, it's not just neat scientists in pristine white coats having quiet eureka moments. It's a lot of dirty petri dishes, massive egos, and stolen credit.
The ego and sheer stubbornness that drove these early discoveries is incredible. Take Paul Ehrlich in the early 1900s. He established this revolutionary concept of the magic bullet.
Magic bullets.
Right, the idea that you could find a chemical to selectively kill a pathogen without killing the patient. He's trying to cure syphilis, and he systematically screened hundreds of toxic arsenic-based compounds.
With arsenic, the thing famous for, poisoning people.
Exactly. And it wasn't until the 606th compound that his team found one that worked without immediately killing the host.
Wow.
It was marketed as Salvarsan in 1910. He actually coined the word chemotherapy for this, though back then it just meant the chemical treatment of any infection long before it became synonymous with cancer.
606 tries. That is a level of persistence I just cannot fathom. But then there's the story that sounds like it was written for a Hollywood movie Gerhard Domack in 1932.
Yes, Domack. He was a German pathologist working for a chemical company, and he discovers that a synthetic red dye called Prontosil protected lab mice from lethal streptococcal infections.
A red dye.
Yeah, but the real drama happened when his own daughter, Hildegard, developed a life-threatening infection.
From a sewing needle prick, right. Just like the rosebush scratch. And he's a scientist watching his daughter actively dying, and he takes this massive gamble to give her this experimental industrial red dye.
And it saves her life.
Unbelievable.
The human body actually metabolizes Prontosil into a compound called sulfanilamide, making it the ancestor of all the sulfa drugs we use today. Domack won the Nobel Prize in 1939 for this, but the story takes a really dark turn. Nazi Germany actually forced him to decline it.
Wait, really?
Yeah, he was arrested by the Gestapo for a week just for being awarded the prize. He didn't receive his actual medal until 1947, long after the war.
That is wild. A literal miracle cure wrapped up in global fascism. But when most people think antibiotic origin story, they immediately think of a very messy desk in London.
Right, Alexander Fleming in 1928. He goes on a summer holiday, leaves his laboratory petri dishes out, and comes back to find a mold. Penicillium notatum had contaminated a dish of Staphylococcus bacteria.
Just left it out.
Yep. But what he noticed was a clear halo, a ring around the mold where the bacteria had been completely wiped out.
The ultimate task failed successfully moment in human history.
It really was. Though it's worth noting, Fleming couldn't actually purify it into a usable drug himself. It took a brilliant team at Oxford, Howard Florey, Ernst Boris Chain, and Norman Heatley to figure out the incredibly fragile chemistry and scale up penicillin to make it a functional medicine during World War II.
And then we have Selman Waksman, who actually coined the modern word antibiotic in 1941. He was systematically screening soil bacteria looking for these chemical weapons.
Yes, and this is where the dark side of academic credit really rears its head. Waxman's graduate student, a man named Albert Schatz, was the one who actually isolated streptomycin in a basement lab in 1943.
Which was a big deal.
A huge deal. It was the first drug that could cure tuberculosis, a massive world-changing discovery. But Waxman took all the credit and eventually the Nobel Prize, entirely alone.
Ouch. I mean, as a grad student, doing the literal dirty work in a basement to watch your boss take the Nobel for your discovery, that is brutal.
Schatz actually did the unthinkable for the time. He sued his mentor.
Oh, wow.
He sued Waxman in Rutgers University. He won formal recognition as a co-discoverer and a share of the patent royalties, but he was essentially blacklisted in the academic community for speaking up. It remains a classic cautionary tale that historians point to about power dynamics in science.
So we have this arsenal of miracle compounds born from arsenic, red dye, moldy dishes, and bitter lawsuits. But here is the fundamental question. You mentioned Ehrlich's magic bullet. If these drugs are essentially microscopic poisons designed to violently kill living cells, why don't they kill our cells when we swallow them?
That is the absolute cornerstone of pharmacology. It's a concept called selective toxicity.
Selective toxicity, meaning it's toxic, but only to a select target.
Exactly. To work safely, the drug has to exploit a specific structural or biochemical difference between a bacterial cell, which is a simple organism called a prokaryote, and a human cell, which is a more complex eukaryote.
Right.
If the drug can find a biological target that the bacteria absolutely relies on, but that human cells don't even possess, it can slaughter the invader while leaving the human host completely unharmed.
So it's like targeting the exhaust port on the Death Star. You are finding the one architectural flaw the enemy has that we don't, and dropping the torpedo right there.
That is a brilliant analogy. And for nursing education and clinical practice, organizing these drugs by which specific exhaust port they target is the fastest way to understand how they work, predict their side effects, and manage drug interactions.
Instead of just memorizing a list.
Exactly. Instead of just memorizing complicated names, you look at the spatial journey into the bacterial cell.
Yeah.
There are 5 major mechanisms or buckets we need to explore.
Okay, let's take that journey. If I'm an antibiotic attacking a bacteria, the first thing I hit is the outer defenses, the deflector shield.
Precisely. That's our first bucket cell wall synthesis inhibitors. Bacteria have a rigid outer wall made of a highly cross-linked substance called peptidoglycan. It's like a heavy suit of armor.
And human cells don't have that.
Nope. Human cells do not have this wall at all. We just have a soft membrane.
So how do the drugs break the armor?
They don't just break it. They stop the bacteria from maintaining it. Penicillins, for example, have a specific chemical structure called a beta-lactam ring. This ring perfectly mimics the natural building blocks the bacteria uses to build its wall.
Oh, sneaky.
Very. When the bacteria's enzymes grab the drug thinking it's a brick, the drug jams the enzyme permanently.
Wow. So the bacteria is trying to build its wall with fake bricks, the machinery jams, and then what? Does it just sit there?
No, it dies violently.
Yeah.
Bacterial cells are highly pressurized on the inside. Without that rigid wall holding everything together, the bacterial cell literally bursts open under its own internal osmotic pressure.
It just pops like an overinflated balloon.
Exactly. This is the largest, most clinically important group of drugs. It includes the penicillins, it includes cephalosporins, which are organized into generations.
Wait, generations? Like an older and newer version?
Yes. As you move from first to second to third generation, the drugs trade their ability to kill gram-positive bacteria, which have very thick outer walls, for the ability to kill gram-negative bacteria.
What's the difference?
Gram-negative bacteria have a thinner wall, but they have an extra sneaky outer lipid membrane that makes them incredibly hard to penetrate. The newer generations were designed to slip past that extra membrane.
Ah, so it's upgrading the torpedo to pierce different types of shielding. What else is in this first bucket?
You have carbapenems, which are incredibly broad-spectrum, heavy hitters.
Yeah.
These are often locked away in the pharmacy, reserved as the absolute last-line therapy for severe hospital infections to prevent resistance.
The big guns.
Right. Then you have monobactams, which are crucial because their chemical ring doesn't trigger allergic cross-reactions, making them safe for patients with a true severe penicillin allergy. And finally, glycopeptides, like vancomycin, which is chemically different but attacks the same wall. Historically, that's our last resort against superbugs like MRSA.
Okay, so bucket one pops the deflector shield. Let's say the bacteria doesn't have a thick wall or we need to attack it differently. We breach the perimeter and go for the inner lining.
That brings us to bucket 2 cell membrane disruptors. Instead of stopping a wall from being built, these drugs, like the polymyxins, act almost like detergents. They punch physical holes directly into the existing bacterial cell membrane. The cell leaks its vital contents and dies.
I have to stop you there. If human cells also have membranes, you said earlier we have soft membranes instead of walls, wouldn't a drug that punches holes in membranes punch holes in our cells too? Isn't that friendly fire?
You've hit the nail on the head. That is exactly why selective toxicity isn't always perfect. Polymyxins are older drugs, and they are quite toxic to human kidneys and the nervous system.
So why on earth do we still use them?
Because they've been revived recently out of sheer desperation. For some superbugs that resist every single wall-destroying drug we have, especially those carbapenem-resistant organisms, these highly toxic hole punchers are literally the only things left that work.
That is terrifying. Okay, moving deeper into the cell. We've bypassed the wall and the membrane. Now we're inside the bacteria. What's the next target? Bucket 3.
The internal droid factories, protein synthesis inhibitors. Bacteria need to constantly manufacture proteins to survive, just like we do. They use cellular assembly lines called ribosomes. But bacterial ribosomes, called the 7DS ribosome, are structurally different from human ribosomes, which are ADS.
Hold on, 70S, ADS, you lost me. What does that actually mean and why should I care?
Oh, the S just stands for Svedberg units. It's a matter of how heavy and dense the molecule is. All you really need to know is that the bacterial factory is physically a different shape and size than the human factory.
Okay, that makes sense.
Because of that structural difference, these drugs can slip inside the bacteria and throw a wrench directly into the gears of the 7DS ribosome, completely halting bacterial protein production, while our ADS human factories keep chugging along right next door.
That is incredibly elegant. So what drugs are we talking about here?
Several major ones. Aminoglycosides are here. They are powerful against gram-negative bacteria, but require nurses to monitor drug levels in the blood closely because they can cause severe kidney and ear toxicity. You also have tetracyclines. These are fascinating mechanically because they strongly chelate or bind to calcium.
Calcium, like in our bones.
Exactly.
Yeah.
That's the primary reason we avoid giving tetracyclines to children or pregnant women. The drug binds to the calcium in developing teeth and can permanently stain them gray or brown, and it can even temporarily stunt bone growth.
That is a side effect you definitely want to remember if you're a nurse handing out pills.
Yeah.
What else jams the ribosomes?
It's macrolides. If you've ever had a respiratory infection and been handed a Z-Pack that's azithromycin, it has a long half-life in the body, which is why you only need a short 5-day course. This group also includes lincosamides like clindamycin, which has a notorious reputation we'll get to in a minute, and oxazolidinones, which are newer drugs used for deeply resistant superbugs like MRSA and VRE.
All right, so we've jammed the factories. What if we want to go straight for the central computer, the blueprints?
That's bucket 4. Nucleic acid synthesis inhibitors. These target the enzymes bacteria use to uncoil and copy their DNA and RNA. If they can't copy their DNA, they can't multiply. Fluoroquinolones, like Cipro, live here. They are highly effective, but they carry heavy FDA-boxed warnings.
Warnings for what?
They can cause spontaneous tendon rupture, like your Achilles tendon just snapping, and even aortic aneurysms in rare cases.
Tendon rupture from taking an antibiotic for a UTI. That is completely wild.
Yeah, it's a stark reminder that these are potent systemic chemicals, not candy. Another fascinating drug in this DNA-blocking group are the rifamycins, used heavily for tuberculosis. And here's a critical clinical pearl. They block bacterial RNA polymerase, but a hallmark side effect is that they turn bodily fluids, urine, sweat, and even tears a bright orange-red color.
Oh my God. Nurse, why am I crying orange tears? Yeah, a heads up would be nice there.
Exactly. Nurses have to proactively educate patients about this, or the patient will think they are sweating blood and go into sheer panic.
Okay, that brings us to the final mechanism. Bucket 5. We've hit the wall, the membrane, the factories, and the blueprints. What's left?
The supply lines. Metabolic pathway inhibitors. These drugs block specific steps in how bacteria process essential nutrients. The classic example is folic acid. Bacteria need folic acid to synthesize their DNA. Sulfonamides and trimethoprim block the specific enzymes bacteria use to manufacture folic acid from scratch.
But wait, human cells need folic acid too, right? My pregnant sister takes a folic acid supplement every day.
We absolutely need it. But human cells don't have the metabolic machinery to synthesize it. We have to get it externally from our diet or vitamins. Since we don't have the factory to make it, Targeting that factory in bacteria is a textbook example of selective toxicity. They often combine two of these drugs, like in the medication Bactrim, to block two different steps in the bacteria's supply line at the exact same time. It's incredibly effective.
Okay, so we have these incredibly precise tools. We've got torpedoes for the wall, the protein factories, the DNA, the membrane, and the metabolism. But I have to push back here, or at least play devil's advocate for you listening.
Go for it.
If I'm really, really sick, I have a high fever, I feel terrible, why wouldn't I just want the doctor to prescribe the absolute strongest, broad-spectrum antibiotic they have in the pharmacy? Just wipe everything out. Nuke it from orbit.
That is a very common and very dangerous misconception. People hear the term broad spectrum and think it means more potent or stronger. It doesn't. A broad-spectrum drug doesn't kill a specific bacterium any harder. It simply means the drug is chemically capable of attacking many different types of organisms at once.
And why is that a bad thing? If I don't know exactly what's making me sick, shouldn't I just cover all my bases?
Because of the friendly fire you mentioned earlier, your body is home to trillions of protective, normal flora. The good bacteria living on your skin, in your mouth, and especially in your gut. They take up space and resources so harmful, invading pathogens can't move in and set up shop.
Ah, I see where this is going. If I use a broad-spectrum drug unnecessarily, I'm basically carpet bombing my own internal defenses.
Exactly. You are wiping out the peacekeepers.
Oh.
And that collateral damage leaves you wide open for what we call superinfections. The most classic terrifying example in healthcare is Clostridioides difficile, or C. diff colitis.
Which you mentioned earlier is heavily associated with clindamycin.
Yes, as well as fluoroquinolones and broad-spectrum cephalosporins. When you wipe out the normal, healthy gut bacteria, this one toxin-producing, highly antibiotic-resistant organism, C. diff, survives the blast. With no competition left, it rapidly takes over the entire colon. It causes severe, sometimes fatal diarrhea that is incredibly difficult to cure. So a narrower targeted therapy, a sniper rifle instead of a grenade, is always preferred the moment you know exactly what specific pathogen you're fighting.
You want the sniper rifle. And while we're talking about massive misconceptions, let's clear up the biggest one. Viruses. If I have a terrible viral flu or the common cold, why won't a doctor give me a Z-Pack?
Because antibiotics do not work on viruses, period. Look at the mechanisms we just discussed. Viruses do not have a peptidoglycan cell wall. They do not have bacterial 70S ribosomes.
You can't target an exhaust port that isn't there.
Exactly. Taking an antibiotic for a viral infection does absolutely nothing to the virus, but it still detonates that grenade in your gut. It wipes out your good flora, exposes the surviving bacteria to selective pressure, and contributes to global drug resistance for zero benefit to you.
Which actually brings us to a massive contradiction. We just talked about minimizing collateral damage, minimizing exposure. Yet for my entire life, every doctor and nurse told me the golden rule. Never, ever stop taking your antibiotics until the bottle is completely empty, even if you feel 100% better on day 3. Doesn't taking them for 14 days cause more collateral damage than taking them for 5?
Here's where it gets really interesting. That dogma, the absolute holy grail of 20th century medicine, is being actively dismantled.
Wait, really? So stopping early doesn't create superbugs?
It's much more nuanced than we were taught. In 2017, a group of infectious disease experts, led by Martin Llewellyn, published a highly provocative paper in the BMJ arguing that the finish the course dogma was never actually supported by rigorous scientific evidence.
Yeah.
We literally just made up the durations, like 10 or 14 days,
Yeah.
because they were nice round numbers.
So what does cause the resistance, if not stopping early?
Their central point is that resistance is driven by total drug exposure. Think about it. When you take a long 14-day course, by day 12 or 13, the drug levels in your body are tapering off. You are exposing the surviving bacteria to low, sublethal concentrations of the drug for an extended period.
Oh, wow. So by taking more of the drug longer than I actually need to cure the infection, I'm essentially giving the surviving bacteria a low-stress training camp to figure out how to beat the drug.
Exactly. The longer the exposure, the higher the chance of selecting for resistant strains. Now, to be incredibly clear, the takeaway from modern research is not just stop taking your medicine whenever you feel like it.
All right, we don't want anyone listening to just start freestyling their medical care based on a vibe. I feel great today. Into the trash they go.
Please do not do that. Critics of the BMJ paper rightly pointed out that for serious, deep-seated infections like tuberculosis or endocarditis, which is an infection of the heart valve stopping early, is well documented to cause a deadly relapse. The expert consensus today is about precision, Course lengths need to be entirely evidence-based for the specific infection.
So why finishing the course still matters is because the course itself is changing.
Precisely. We now have clinical trials proving a 3-day course works reliably for an uncomplicated UTI, and 5 days is often plenty for community-acquired pneumonia. If your doctor prescribes 5 days based on the latest evidence, you absolutely must finish those 5 days. But we no longer need to blindly prescribe a 14-day supply for everything just because a textbook from 1980 said so.
But getting this right, matching the exact drug and the exact duration to the exact bug, it feels so urgent because this resistance crisis isn't some abstract sci-fi problem for the year 2100. It's happening terrifyingly fast.
It is immediate, and it's been happening since the beginning. Let's look at methicillin. It was a synthesized penicillin introduced in 1959, specifically because staph bacteria had already figured out how to chew up regular penicillin. Just 2 years later, in 1961, doctors in the UK identified the very first strain of MRSA, methicillin-resistant Staphylococcus aureus.
2 years. It took humanity thousands of years to find the drug, and it took a microscopic blob 2 years to completely outsmart it.
2 years. It is the clearest possible demonstration that resistance isn't a mistake. It is the built-in evolutionary consequence of using antibiotics at all. Alexander Fleming himself anticipated this. In his 1945 Nobel lecture, he explicitly warned that underdosing penicillin would cause resistant bacteria to survive and multiply. He predicted the crisis before resistance was even a widespread clinical problem.
And now, because we didn't listen, we have things like NDM1.
Yes. New Delhi metallobeta-lactamase 1.
Sure.
First described in 2008. It is a resistance enzyme that completely destroys carbapenems.
Wait, carbapenems, the ones you said were locked in the pharmacy as our absolute last resort. Bucket one.
Exactly. NDM1 neutralizes our last line of defense. But the true nightmare scenario isn't just that a single strain of bacteria mutated to have this enzyme. It's how they spread it.
What do you mean spread it? They don't just divide and pass it to their offspring.
That's vertical transmission. But bacteria can also do something called horizontal gene transfer. The genetic code for NDM1 sits on something called a plasmid. A plasmid is a small, mobile, circular piece of DNA that exists completely separate from the bacteria's main chromosome.
Like a little USB drive of genetic code.
That is exactly what it is. And bacteria can literally trade these USB drives with each other across totally different species. Resistance doesn't just spread when a bacterium reproduces. A completely unrelated bacterial species, say an E. coli in your gut, can bump into a Klebsiella bacteria and just hand over the plasmid.
Like swapping trading cards. Here, take this gene that makes you invincible to the strongest drug humanity has. Thanks, here's one for surviving tetracycline.
Exactly. They build multi-drug resistance shields in real time across species lines.
So what does this all mean for you, for the people listening? We are looking at a landscape where the World Health Organization has repeatedly warned that we are heading toward a post-antibiotic era. An era where common infections, routine surgeries, chemotherapy, even premature birth become deadly again, simply because the base assumption of modern medicine that there will be a drug that works is gone.
That is what makes antimicrobial stewardship the single most critical frontline job in healthcare today. Choosing the right drug, the sniper rifle at the right dose, for the exact evidence-based duration. It isn't just hospital paperwork. It is the only thing keeping modern medicine viable. Every time a nurse pushes for a culture before starting broad-spectrum therapy, or questions an unnecessarily long prescription, or educates a patient on why they aren't getting a Z-Pack for a cold, well, they are actively defending the safety net of humanity.
It really puts the responsibility on all of us, doctors, nurses, and patients, to respect these molecular tools. We can't just demand pills for a runny nose.
We can't. But I want to leave you with one final thought today, something to really explore on your own that builds on everything we've just discussed about how resistance forms. We've spent this entire deep dive talking about human medicine. Hospitals, prescriptions, nursing, fighting over a 5-day versus a 14-day course. But historically, a massive share of all antibiotics manufactured globally hasn't gone to sick humans at all. They are fed, by the ton, to completely healthy livestock.
Wait, healthy animals? Why would they give expensive drugs to animals that aren't even sick?
Because the agricultural industry realized decades ago that continuous low doses of antibiotics make animals gain weight faster, likely by altering their gut microbiomes to absorb more calories. Now, think about what we just discussed. If the major driver of antibiotic resistance isn't stopping early, but rather total drug exposure at long, sublethal concentrations, think about the implication.
Oh my God, the training camps.
Exactly. We have an invisible, massive pipeline of resistance genes and plasmids brewing in agricultural feedlots around the world. These invincible bugs are quietly multiplying in the soil, the water runoff, and entering the human food chain, long before a patient ever even sets foot in a hospital to ask for a prescription.
That is profoundly chilling. Suddenly, the idea of a simple scratch from a rosebush being a death sentence doesn't just feel like a quaint history lesson from 100 years ago. It feels like a very real reality we could be facing again tomorrow if we're not incredibly careful about how we use these tools. Thank you for joining us on this deep dive. Respect your microbes, think twice about that Z-Pack, and we'll see you next time.
Imagine someone intentionally designing, like a biological booby trap, inside a standard medical pill. A pill that, if you take it exactly as prescribed, safely delivers a life-saving medication. But if you try to crush it up and, inject it into your veins, this hidden chemical mechanism violently snaps shut.
Yeah, and it instantly sends you into severe physical withdrawal. I mean, it sounds like something out of a spy novel, right?
Totally.
Yeah.
But pharmaceutical companies actually use this exact mechanism every single day.
They do. And the wild part is that the trap doesn't rely on nanotechnology or like hidden microchips. It relies entirely on a quirk of your own digestive plumbing.
Which brings us to the mission for this deep dive.
Yeah.
We are unraveling a massive stack of medical and pharmacology notes today to decode a concept called first-pass metabolism, because it answers a question that affects every single one of you listening. Like, why can the exact same dose of a drug be totally life-saving or completely hopelessly useless, depending entirely on how it enters your body?
Exactly. The route of administration, whether you swallow a tablet or stick on a transdermal patch or get an injection, it is never just a matter of convenience. It's actually one of the most high-stakes mathematical decisions in clinical medicine.
Okay, let's unpack this plumbing, because looking through these anatomical diagrams in the notes, it's pretty clear the human body just wasn't designed with modern pharmaceuticals in mind.
No, definitely not.
There's this formal metric I keep seeing here called bioavailability, represented by the letter F. And the definition given is that it's the fraction of a drug that actually reaches your systemic circulation completely intact. So by definition, an intravenous injection, an IV, is 100% bioavailable. You push the plunger, the drug goes straight into the main bloodstream.
Yeah, and it travels to the brain or the heart immediately. That pathway is essentially a straight shot. But an oral pill takes a much more harrowing journey.
Right, because you swallow it, it goes to the stomach.
Down into the stomach and intestines, exactly, where it breaks apart and gets absorbed into the blood vessels lining your gut. But here is where the anatomy takes a really strange turn. The blood draining from your digestive organs does not go directly back to your heart to be pumped around the rest of your body.
Which is what you would intuitively expect, right? Blood goes out, picks up nutrients, and goes back to the heart.
You'd think so.
Wow.
But instead, all of those blood vessels from the stomach and intestines, they funnel together into this massive biological highway called the hepatic portal vein. And that vein delivers all that freshly absorbed, nutrient-rich blood directly into your liver.
The body's primary chemical processing plant.
Exactly. And to understand the why behind this detour, we have to look at our evolutionary history. The liver is incredibly dense with metabolizing enzymes, specifically the cytochrome P450 family. It evolved over millions of years as a mandatory detoxification checkpoint for literally everything we consume.
So the liver has no concept of modern medicine.
None at all. To those enzymes, a helpful synthesized blood pressure molecule is completely indistinguishable from, say, a deadly alkaloid toxin you just ingested from a poisonous berry. Its sole biological mandate is to neutralize unknown substances on this first pass through its tissue before they can reach your brain or heart.
Reading this, I just kept picturing the liver as a highly zealous, extremely suspicious airport customs agent.
That is a great way to think about it.
Right. Like if you fly domestically, meaning you bypass the digestive tract entirely by getting an IV, you never even see the customs agent. You arrive at your destination with 100% of your luggage. But if you fly internationally, meaning you swallow a pill, you are forced to land at the international terminal and pass through customs.
And that agent just ruthlessly goes through your bags.
Yes, confiscating massive amounts of your luggage before letting you into the country. You might arrive with 90% of your items, or you might arrive with 3%.
And it all depends on how strict those enzymes are with that specific chemical structure. The liver is essentially destroying the active drug before it can ever do its job. Though looking at the modern biopharmaceutics notes, the definition of this checkpoint has actually expanded significantly in recent years. The customs agent isn't solely sitting in the liver anymore.
I noticed that. The older science seemed hyper-focused on the hepatic pass, but the modern literature recognizes 4 distinct sites of pre-systemic elimination. It's basically a gauntlet.
It really is.
Right off the bat, there's the gut lumen itself. The hollow space inside your stomach and intestines is filled with corrosive stomach acid, harsh digestive enzymes, and massive colonies of gut bacteria. They can physically dismantle a fragile drug molecule before it even touches the gut wall.
Which is precisely why we cannot give insulin as an oral pill. The stomach acid would just shred the protein structure into useless fragments.
Oh, that makes total sense. So it has to survive the acid first.
Yep. Then, even if the drug survives the lumen, it hits the intestinal wall. The actual physical cells lining your small intestine contain their own metabolizing enzymes, like CYP3A4, which actively break drugs down right there.
And the notes mention those cells even have microscopic pumps that will grab an intact drug molecule and forcefully throw it back out into the gut lumen.
Yeah, it's wild. So it has to survive the acid, survive the intestinal wall enzymes, and then it takes the portal vein to face that massive hepatic liver pass we just talked about.
Wow. Oh, and for certain specific routes of administration, there's a 4th site too, right? A pulmonary or lung first pass.
Yeah, the blood has to travel through the massive surface area of the lungs before hitting the systemic arterial circulation. And lung tissue can extract highly fat-soluble drugs right out of the blood.
This entire system just seems incredibly hostile to medicine, which really makes me wonder about the history here. Since the body's checkpoint is so aggressive, how did doctors first figure out this invisible confiscation was even happening?
Well, looking at the historical timeline, this wasn't discovered under a microscope in a pristine lab. It was discovered through incredibly frustrating, terrifying failures at the patient's bedside.
Right, because you have to put yourself in the shoes of a cardiologist in the 1960s. It must have been a deeply confusing time.
Oh, absolutely. Clinicians kept hitting this invisible wall where they would administer a drug via IV, and it would work beautifully to stabilize a patient. But when they tried to transition that same patient to an oral pill version so they could go home,
The drug did absolutely nothing. Even when they gave massive oral doses, the patient's symptoms would just return. The chemicals seemed to just vanish into the ether.
exactly. And there are 2 famous case studies from that era highlighted here that force the medical community to formally recognize this.
The first one involves a drug called lidocaine. In 1971, a researcher named R.N. Boyes was trying to use oral lidocaine to treat severe heart arrhythmias. They set up the trials, gave the pills, and the drug proved completely dangerously useless.
Because the arrhythmias wouldn't stop. The liver's extraction ratio for lidocaine is just incredibly high. The hepatic checkpoint was stripping almost every single molecule of the drug out of the portal vein before it could even reach the heart.
Which totally explains why today you never see a lidocaine pill. If you need lidocaine, they give it to you through an IV in the ER, or the dentist injects it directly into your gums, or you rub it on your skin. You bypass the gut entirely.
Exactly. And the second story from the notes is about propranolol, which was one of the earliest beta blockers used to slow down the heart rate.
Right. In 1975, a clinical pharmacologist named David Shand finally demonstrated that if you actually wanted to lower a patient's heart rate using a swallowed propranolol pill, the dose had to be astronomically higher than the IV dose, just to ensure a tiny fraction survived that first circuit through the liver.
Yep, the liver was just chewing it up.
But wait, if doctors at the bedside clearly saw that the standard oral pills were failing, why didn't they just keep guessing and doubling the oral doses until it worked? Like, why did this require entirely new scientific studies to figure out?
Well, what's fascinating here is that trial and error with a human heart is lethal. You cannot just blindly double or triple a cardiac medication, hoping that this time enough slips past the liver.
Because if you guess wrong and the drug floods the system.
It stops the heart entirely. Exactly. You can't take that risk.
That makes sense.
So those bedside failures forced scientists, notably figures like Milo Gibaldi and Gerhard Levy, to step in and build a rigorous mathematical framework. They essentially birthed the science of pharmacokinetics.
So they didn't just observe the liver-destroying drugs. They built complex equations to calculate extraction ratios and exact bioavailability percentages.
Right. They gave clinicians a precise numerical language to predict that invisible confiscation process.
They essentially put a strict mathematical value on how much luggage the customs agent was going to steal.
Perfect way to say it. And once you can mathematically predict a biological process, you can manipulate it. Medical science stopped guessing and started intentionally hacking the checkpoint to save lives.
Let's look at how they do that, starting with what we could call hacking by route. The classic example in the notes is nitroglycerin, used for angina, which is severe, crushing chest pain.
Right, and nitroglycerin has an oral bioavailability close to 0. The liver destroys it completely on the first pass.
Which is obviously highly inconvenient for a patient currently experiencing an active heart attack. They don't have time for the drug to navigate the stomach, the portal vein, and the liver, only to be destroyed.
Precisely. And that is why doctors instruct angina patients to place the tiny nitroglycerin tablet under the tongue sublingually, or they prescribe a transdermal patch to stick on the chest.
So by absorbing the chemical directly into the superficial veins located in the tissue of the mouth or the skin, the drug completely dodges the stomach and the hepatic portal vein.
Exactly. It drains straight into the systemic circulation and hits the heart in seconds. It's an elegant physical bypass, but clinicians also engage in hacking by math.
Okay, and this is where things get incredibly dangerous if a healthcare provider doesn't respect the underlying biology. Let's look at that classic nursing trap involving morphine.
Oh, yes. Morphine undergoes a specific type of first-pass metabolism called extensive hepatic glucuronidation.
Okay, I saw that term in the notes, glucuronidation, and it sounds incredibly dense. What is physically happening to the morphine molecule there?
Well, inside the liver, there is a specific enzyme called UGT2B7. Think of this enzyme as a customs agent with a staple gun. As the morphine floats by in the portal vein, this enzyme physically staples a heavy, bulky sugar molecule, a glucuronide group, directly onto the morphine structure.
Oh, like slapping a massive, heavy luggage tag on a suitcase.
Exactly. And because that morphine molecule is now significantly heavier and bulkier, its physical shape has changed. It can no longer fit into the opioid receptors in the brain and spinal cord to relieve pain.
So the liver hasn't destroyed the morphine, but it has completely inactivated it.
Right. And because of this intense stapling process, the oral to IV conversion ratio for morphine is roughly 3:1. Oral morphine is mathematically 3 times less potent than IV morphine.
Meaning if a nurse is caring for a patient who is stable on 10 milligrams of IV morphine and the doctor says they are ready to go home on oral pills, the nurse cannot just hand them a 10 milligram pill.
No, if they do, that patient will be in severe agony within hours. The nurse has to drastically increase the oral dose up to 30 milligrams, specifically to feed the liver's stapling enzymes, ensuring that 10 milligrams survive to reach the brain.
Here's where it gets really interesting, though. I was reading the section on intentional drug design, and I have to ask about Suboxone. This goes back to the biological booby trap we mentioned at the start.
Yes, Suboxone. It's a medication prescribed for opioid addiction, and it's a combination pill. It contains buprenorphine, which stops the cravings, and naloxone, also known as Narcan, which is an aggressive antidote that instantly blocks opioids.
Right, so why would a pharmaceutical company put the cure and the antidote inside the exact same pill?
It is a brilliant piece of chemical engineering known as an abuse deterrent formulation. They literally weaponized first-pass metabolism.
How so?
Well, naloxone has almost 0 oral bioavailability. The liver's enzymes absolutely shred it on the first pass, but buprenorphine survives a bit better when absorbed in the mouth.
Oh, I see. So if a patient takes the Suboxone tablet correctly, letting it dissolve under the tongue, the buprenorphine absorbs and works to relieve their cravings.
Exactly. And whatever tiny amount of the naloxone antidote they happen to swallow goes straight to the liver and is completely destroyed. The patient feels fine.
But if someone struggling with severe addiction tries to misuse the medication by crushing the tablet, dissolving it in water, and injecting it directly into a vein to get a high,
the trap snaps shut. By injecting it intravenously, they have bypassed the liver entirely. The naloxone antidote hits the brain completely intact, violently ripping the opioids off the receptors and plunging the user into immediate agonizing withdrawal.
Wow. So the drug companies literally rely on the liver's destructive power to make the pills safe to prescribe. It's incredible.
It really is.
But reading through the rest of the outline, this highly predictable mathematical system has some serious vulnerabilities. Like, if we can mathematically predict what the liver will confiscate, what happens if the customs agent gets distracted or overwhelmed or sick?
Chaos. Total biological chaos. And it often starts with something as simple as breakfast.
The grapefruit juice incident of 1989. This is easily one of my favorite accidental discoveries in clinical medicine.
It's such a great story.
So a Canadian researcher named David Bailey was running a routine study to see how alcohol interacted with a standard blood pressure medication called felodipine. Because it was a blinded study, he needed a way to completely mask the taste of the alcohol so the control group wouldn't know what they were drinking.
And anyone who has tried knows that pure alcohol is notoriously difficult to hide in a beverage.
Right, so he decides to use grapefruit juice, assuming it's just a strong, bitter, completely harmless flavor profile. He runs the study, draws the blood, and the results make absolutely no sense. The phenolphthalein drug levels in the patients who drank the grapefruit juice had inexplicably skyrocketed to toxic levels.
Yeah, what Bailey accidentally discovered was that grapefruit juice contains specific chemical compounds that act as potent inhibitors of CYP3A4.
That's the metabolizing enzyme located in the wall of the small intestine we talked about earlier, right?
Exactly. The juice basically distracts and paralyzes the customs agents stationed in your gut. Because those enzymes are temporarily knocked out by the grapefruit juice, they can't break down the blood pressure medication as it passes through.
So suddenly, dangerously high amounts of the intact active drug just slip through the intestinal wall and into the bloodstream.
Yeah, and this is why today, if you take certain statins for high cholesterol or certain calcium channel blockers, the pharmacist will put a giant bright yellow warning sticker on the bottle telling you to avoid grapefruit juice.
Because if you drink it, you shut down your intestinal first-pass metabolism, which can lead to toxic overdose levels of the drug in your system.
Right, potentially causing severe muscle breakdown or kidney damage.
It is wild that a breakfast drink can hijack your pharmacology like that. But it's not just grapefruit, right? Alcohol itself is subject to first-pass metabolism, and the biology here is surprisingly sexist.
Yeah, it is. Most people assume this checkpoint only applies to complex prescription pharmaceuticals, but ethanol, beverage alcohol, is partially broken down in your stomach lining before it even has a chance to reach your bloodstream. This is handled by an enzyme called gastric alcohol dehydrogenase, or ADH.
In a landmark 1990 study published in the New England Journal of Medicine, proved that women naturally possess significantly lower levels of this gastric ADH activity than men.
Meaning that a woman's stomach lining is physically less capable of breaking down the alcohol on that initial first pass.
So if a woman and a man of the exact same body weight drink the exact same amount of alcohol in the same amount of time, the woman will actually absorb far more intact ethanol into her bloodstream.
Exactly. It is a fundamental biological difference in pre-systemic metabolism that directly dictates blood alcohol concentration.
Man, that is fascinating. I was looking at the mathematical models later in the notes, and the equations seem to suddenly break down when the doses of certain drugs get really high. It looks like the predictable percentages just stop working.
Look,
What is the saturable trap?
that is where nonlinear math catches even experienced clinicians off guard. For certain drugs, like the beta blocker propranolol, first-pass metabolism is not a flat, infinite percentage. The liver's enzymes can actually be saturated.
Like they just can't keep up.
Right. Think of a bouncer at a nightclub door. If 5 people try to rush the door, the bouncer can easily stop 4 of them, letting only 1 inside. But if 50 people suddenly rush the door at the exact same time, the bouncer is completely overwhelmed.
Oh, so he might still only stop 4 people, meaning 46 people suddenly burst into the club.
Exactly. If you double a dose of a drug with saturable metabolism, you don't just double the amount of drug in the blood, you overwhelm the liver's enzymes. The confiscation rate plummets, and a disproportionately massive surge of the drug escapes into systemic circulation.
Okay, speaking of overwhelming the liver, I have a question about a scenario that seems completely counterintuitive.
Okay, what is it?
If someone has severe liver disease, say advanced cirrhosis from years of alcohol abuse, their liver tissue is scarred and dying. Wouldn't that damaged liver struggle to process drugs, meaning the medication never gets activated, leaving them dangerously undertreated?
It's a very logical assumption, but it is actually the exact opposite for high first-pass drugs.
Really? How so?
Well, remember, for the vast majority of oral medications, the liver's job during the first pass is to destroy them, not activate them. If the liver is severely damaged by cirrhosis, it loses its ability to extract the drug. The customs agent is essentially asleep at the desk.
Oh, I see.
And furthermore, severe liver disease creates physical blockages. As the liver tissue hardens with scar tissue, blood pressure in the portal veins skyrockets. To relieve that pressure, the body literally builds new blood vessels, detour roads, to route the blood around the dying liver. This is called portosystemic shunting.
So the newly absorbed blood carrying the drug takes the detour and just skips the checkpoint entirely.
It never even sees an enzyme. So If a doctor absent-mindedly prescribes a standard oral dose of morphine or propranolol to a patient with severe cirrhosis, that drug completely bypasses the broken first-pass system.
Wow. So what is normally a safe everyday dose suddenly hits the brain with the force of an IV injection.
Exactly, causing a massive accidental overdose. This is why hepatic impairment requires drastic dose reductions for oral meds.
Because first-pass metabolism is so dynamic and clearly full of biological loopholes and detours, the sources point out that it's a massive breeding ground for dangerous medical assumptions. Let's do some rapid-fire myth-busting based on the nursing notes to clear those up. Myth number 1. A drug with a low oral bioavailability percentage is just a weak drug.
Completely false. Low oral bioavailability just means the oral route is a highly inefficient delivery method for that specific chemical structure. The drug itself might be incredibly powerful.
Right, like we discussed with naloxone. It gets shredded when swallowed.
Exactly. But if you inject a tiny amount intravenously, it is potent enough to rip heroin off a brain receptor and reverse a coma in seconds. The drug isn't weak, swallowing it is just a bad delivery strategy.
Makes total sense. Okay, myth number 2. Giving a drug via IV means it is safe from the liver forever. It completely avoids metabolism.
If we connect this to the bigger picture to understand why this is a myth, we have to distinguish between pharmacokinetics, which is what the body does to the drug, and pharmacodynamics, which is what the drug does to the body. Intravenous administration only skips the pre-systemic or first pass elimination.
Oh, so it just gets a free pass on the first lap.
Right. It hits the systemic blood, travels to the target tissue, and does its job. But the blood is constantly circulating. Eventually, that venous blood will carry the drug back around to the liver, and the liver will begin its normal systemic metabolism to clear the chemical from the body. 4V routing buys the drug immediate access. It doesn't grant it biological immortality.
Got it. And finally, myth number 3. Dose conversions between oral and IV forms are simple whole numbers. You just double it or have it in your head on the fly.
Absolutely not. As the morphine example showed with its complex stapling enzymes, conversion ratios are highly specific to the drug and rarely intuitive whole numbers. First-pass metabolism destroys a predictable but highly complex fraction of the oral dose. Relying on mental math instead of standardized conversion tables at the bedside is a critical patient safety risk.
So what does this all mean for you, the listener? Well, the next time you pick up a prescription at the pharmacy and see a bright yellow sticker warning you to avoid grapefruit juice, or the next time a doctor specifically instructs you to let a tablet dissolve under your tongue instead of swallowing it with a glass of water, you are interacting directly with your body's intricate first-pass metabolism.
You really are.
Yeah, you're navigating an unseen evolutionary checkpoint that is constantly shaping your everyday health. The route you take completely changes the dose you get. It is the unseen math shaping everyday health.
And as we wrap up, I want to leave you with one final provocative thought from the sources that hints at where this entire science is heading. We briefly mentioned earlier that the gut lumen, the physical space inside your intestines, is packed with bacteria, your microbiome.
Right, the trillions of microbes living inside us.
Well, we are now discovering that those bacteria possess their own metabolizing enzymes. They act almost like a pre-liver, dismantling drugs before they even reach the intestinal wall. And here's the profound part. Everyone's microbiome is completely unique, like a biological fingerprint.
Yeah, it changes rapidly, right? Based on your daily diet or stress, or if you recently took antibiotics that wiped out entire colonies of your gut flora.
Exactly. So if your personal, ever-changing gut bacteria are actively participating in first-pass metabolism, it means the confiscation rate is a moving target.
Oh, wow. So my dose might need to be different today than it was a year ago just because my gut flora changed.
Yes. It raises a massive question for the future of pharmacology. Could we be approaching a point where doctors can no longer just look at a patient's weight or liver health to prescribe a standard oral pill? Will they have to genetically sequence and map your specific gut microbiome on that specific day just to mathematically predict how much of the drug your personal bacteria are going to destroy?
We might have to rethink the entire concept of standardized oral dosing.
We just might.
That is a staggering thought. Your own personal bacterial colonies dictating whether your medication works or fails. We will leave you to mull that over on your own. Thank you so much for joining us on this deep dive into the unseen forces shaping our health, and we'll catch you next time. In the next few minutes, you are probably going to stand up.
Most likely, yeah.
Right. And the exact moment you do that, gravity is going to just rip a full pint of blood right out of your brain and chest, and it's going to pull it straight down into your legs and abdomen.
It is a massive fluid shift.
Yeah, and if your body is even, a fraction of a second late in responding to that shift,
Hmm.
you were going to hit the floor.
Ah.
Welcome to the deep dive. We take the sheer physics of walking around completely for granted, don't we?
Oh, absolutely. I mean, biologically speaking, every single time you rise from a chair, your body is essentially fighting off a miniature medical emergency.
A miniature emergency.
Hmm.
That is such a wild way to think about it.
But it's true. We are just walking around completely oblivious to this high-stakes physics problem that's, happening inside us dozens of times a day. Gravity is relentless. It pulls roughly the volume of, say, 2 standard water bottles out of your central circulation instantly. And when the internal system that fights that gravitational pull fails, well, it creates a major medical event, one that often goes completely unrecognized.
Which brings us perfectly to the mission for our deep dive today into the source material. We are looking at a condition called orthostatic hypotension, or OH.
Right. And the goal here is not just to learn some niche nursing vocabulary word, right?
Right.
We are going to deconstruct the actual mechanics of this invisible blood pressure drop.
Because it is a massive predictor of falls.
Exactly. We need to look at how it is consistently measured wrong in clinics and why this seemingly simple mechanical failure can actually serve as like a crystal ball for your brain health years down the line.
I love that framing.
Yeah.
Because understanding this phenomenon, it really bridges basic physics with incredibly complex neurology.
Orthostatic hypotension. It sits at the exact intersection of everyday clinical practice and, well, serious life-altering consequences. Recognizing the mechanics of it can literally prevent a devastating, life-ending injury for someone you love.
Okay, so before we can understand why the blood pressure drops dangerously in some people, we really need to look under the hood at the incredible mechanics of a normal human just standing up.
The baseline, yeah. Let's walk through the physiology of it.
So, picture it. When you are lying flat in bed, your blood is distributed evenly, right? Returning venous blood flows horizontally back to your heart.
It doesn't have to work against gravity at all. The heart is operating with minimal resistance.
But the instant you stand up,
boom, 500 to 1,000 milliliters of blood is just pulled out of general circulation.
wow.
It pools in the veins of your legs, your pelvis, and your abdomen. Specifically, there's a region called the splenic venous bed.
Okay, let's define that splanchnic bed because the sources point out it's not just some random collection of veins.
No, not at all.
It is a massive, highly expandable venous reservoir that's designed primarily to aid in digestion.
Right.
Think of it like a giant, stretchy balloon in your abdomen. When you eat, it dilates to hold extra blood so you can absorb nutrients.
But when you stand up, gravity pulls your blood straight down into that highly distensible balloon. And if it doesn't immediately tighten up, the blood just stays trapped there.
And that trapping effect immediately reduces the volume of blood returning to your heart.
Exactly. Which means the heart simply has less blood to pump out with the very next beat.
So your cardiac output just plummets.
And that drop in cardiac output causes your blood pressure to crash. I mean, if nothing else happened in your body, your brain would be starved of oxygen within seconds, and you would lose consciousness.
You just pass out.
You'd pass out every time you stood up. You only stay awake because of this microscopic, lightning-fast, rapid response system.
Yeah, let's get into that. You have these pressure sensors, they're called baroreceptors, located right in the walls of the carotid sinus in your neck.
And in the aortic arch near your heart.
Right, and they are literally stretch receptors.
Mm-hmm.
When the blood pressure drops, the vessel walls become, less stretched.
They get a little slack.
Yeah, slack. And the receptors detect that slack immediately and fire an electrical signal straight up to your brainstem.
They send that SOS signal to a highly specialized cluster of neurons. It's called the nucleus tractus solitarius.
Okay, that's a mouthful.
It is, but you can basically think of this area as the brain's central circuit breaker for blood pressure. It constantly monitors that incoming pressure data, and it dictates the outbound response.
So the central circuit breaker gets the signal that pressure is dropping. It instantly triggers a surge of sympathetic nervous system activity by releasing a flood of norepinephrine.
Norepinephrine, which is essentially adrenaline's cousin.
Right. And its specific job in this scenario is to bind to receptors on your blood vessels and just aggressively squeeze the pipe shut.
It forcefully constricts blood vessels throughout your entire body, including that stretchy splanchnic balloon we talked about.
While simultaneously ramping up your heart rate.
Yes. This entire continuous loop, I mean, the sensors, the circuit breaker, the chemical clamp, it's called the baroflex arc. In a perfectly healthy person, it fixes the pressure drop within about 30 seconds.
So fast.
Incredibly fast. Orthostatic hypotension only occurs when a link in that specific chain fails.
Okay, let's unpack this because the sources categorize those failures perfectly
Yeah.
using this plumbing versus wiring analogy, which I found super helpful.
It's the best way to visualize it.
Yeah. So first we have the plumbing, which covers the non-neurogenic causes. The sensory system and the brain's wiring are working perfectly.
Right, the brain is doing its job.
But there's a physical problem with the fluid or the pipes themselves. The tank is low or it's leaking.
Exactly. So a low tank is simple volume depletion. The patient is severely dehydrated or maybe bleeding, or they've been overprescribed diuretic medications that just flush way too much water out of their system.
They just literally don't have enough fluid to pump.
Right, but a leaky pipe scenario is slightly different.
That's where the pipes are too relaxed.
Yeah.
Usually because of medications.
That's exactly.
Like a lot of everyday blood pressure drugs, certain antidepressants, or even prostate medications, they act as chemical roadblocks. They literally block the norepinephrine from doing its job.
The brain is screaming to constrict the vessels, but the medications act like leaky valves. They prevent the pipes from tightening.
And prolonged bed rest causes another plumbing issue, doesn't it?
Oh, a huge one. If a patient is hospitalized and immobilized for weeks, that baroreflex literally atrophies from disuse.
It just forgets how to work.
Well, the body is ruthlessly efficient. If you don't use that reflex to fight gravity on a daily basis, your body just starts expending the energy to maintain it.
Wow. Okay, so that covers the plumbing. But then we have the wiring, which covers the neurogenic causes.
Right.
In this scenario, the fluid tank is completely full. The patient is perfectly hydrated. There are no leaky valves at all.
But the sensors or the signaling wires themselves are completely degraded.
So the brain never gets the message that the blood pressure is dropped in the first place.
Or the brain's command to constrict just never reaches the blood vessels. We see this a lot in conditions like Parkinson's disease or diabetic autonomic neuropathy.
And you can actually tell which of these two problems a patient has right at the bedside, can't you? By looking at one simple physiological clue.
Yes, their heart rate. It's such a brilliant clinical distinction.
How does that work?
Well, if a patient stands up and their blood pressure crashes because of a plumbing issue, let's say severe dehydration, their nervous system panics, right? The wiring is totally intact.
So the brain detects the crisis.
Exactly. The brain screams at the heart to beat faster to compensate for the dangerously low fluid volume, so their heart rate will just shoot up dramatically.
But if it is a wiring problem, the heart rate barely rises at all.
Right, because the baroreflex itself is broken.
So the blood pressure is plummeting, the brain is getting less oxygen, but the heart just keeps beating at this totally normal resting pace because the communication lines are completely dead.
It is a terrifyingly quiet response to a major physiological crisis.
Because the human body has so many different ways to fail at something as fundamental as standing up, the medical community spent like a century arguing over how to actually define and label the failure. Right?
Oh, absolutely. I mean, the condition was noticed for centuries, obviously. People fainting when they stood up wasn't exactly a secret.
Right.
But it wasn't isolated as a specific, measurable diagnostic entity until 1925.
Right. The sources mentioned two physicians, John Halley Bradbury and Charles Eggleston. They published this landmark case series of 3 patients, and they coined the term postural hypotension.
And the crucial distinction they made back then was separating this sustained pressure drop from just everyday fainting.
Because everyday fainting or, vasovagal syncope is what happens when someone locks their knees at a choir concert.
Yes, exactly. It is a transient, overactive reflex. The heart rate and blood pressure drop suddenly, the person falls down, gravity equalizes the blood flow, they wake up, and they are essentially totally fine.
But Bradbury and Eggleston's patients had a sustained mechanical failure. Their blood pressure fell dramatically upon standing, and it stayed dangerously low for as long as they remained upright.
Right. And eventually, the medical nomenclature evolved to orthostatic hypotension, just to be more precise about the actual act of standing upright and actively fighting gravity.
Which brings us to the modern definition. Fast forward to 1996, and then reaffirmed in 2011, the medical community decided they needed a strict, standardized yardstick for this mechanical failure.
They needed a number.
Yeah. A consensus statement defined OH as a drop of at least 20 millimeters of mercury in systolic blood pressure, or at least 10 millimeters in diastolic pressure within 3 minutes of standing.
The famous 2010 rule.
So what does this all mean? Let's apply some math to that, because having a rigid number in medicine always raises red flags for patient care, doesn't it?
It really does. It creates massive blind spots.
Right. Because if you have a patient with a high resting systolic blood pressure of, say, 180, and they stand up and drop to 155, they have dropped 25 points.
So they easily meet the 20-drop rule for the official diagnosis.
But at 155, they have plenty of pressure to perfuse their brain. They probably feel completely fine.
They are clinically asymptomatic despite meeting the diagnostic criteria perfectly.
But then, take a frail 80-year-old patient whose resting systolic is only 100. If they stand and drop 15 points down to 85, they do not meet the bureaucratic 20-point definition.
No, they don't.
But at a systolic of 85, they do not have enough pressure to pump blood all the way up to their brain, and they might literally fall over.
Doesn't a fixed one-size-fits-all number completely ignore the physics of the patient's actual reality?
It does. And it creates this massive tension between clinical researchers and bedside doctors. Geriatricians and the physicians who are actually catching these falling patients, they argue heavily for symptom-based or function-based criteria.
Because they actually see the falls happening.
Exactly. They care if the patient is dizzy, if their vision is blurring, or if they are actively losing their balance. The functional perfusion of the brain matters infinitely more to them than some standardized threshold. They're treating the patient, not the math.
Exactly. But the researchers who are studying the underlying autonomic diseases, they desperately need that fixed 2010 number.
Because of the data.
Right. If a scientist is running a global, multi-center clinical trial on a new drug, they can't log patient felt a bit woozy as a data point.
Yeah, that's a no.
They need a reproducible, comparable threshold to measure efficacy. So both camps are totally justified for their specific purposes, which means in the real world, the definition is just always a bit contested.
But, I mean, this entire debate over whether the drop is 15 points or 20 points is completely useless if we are measuring it wrong in the first place.
And we are.
Looking at the data in the source material, it seems we are getting it wrong almost every single time in standard clinical settings.
The measurement trap is honestly one of the most frustrating blind spots in routine medical care. There is a very strict clinical protocol required to capture this fluid shift accurately.
Walk us through it.
Okay, so the patient must rest flat on their back supine for at least 5 minutes. This allows the cardiovascular system to reach a true gravity-neutral baseline.
Right.
Then they stand up. The clinician must measure their blood pressure at exactly 1 minute, and then again at 3 minutes.
And the 3-minute mark is where the entire system falls apart, isn't it?
Completely falls apart.
Because a nurse or a clinician is running behind in a busy clinic. They only have, 15 minutes allocated per patient?
If they're lucky.
Right. So they have the patient stand up, they slap the blood pressure cuff on immediately, take a single reading, see that it looks totally normal, and they just move on.
Yep. And because they skip the 3-minute check, they completely miss what is called delayed OH.
Delayed OH. This is a mechanical failure where the blood pressure doesn't actually crash until somewhere between 3 and 10 minutes of standing.
Yes. We could think of it like a failing water pump in a basement.
Oh, I like this analogy.
For the first minute or two, the pump works furiously and actually manages to keep the water level steady, so the immediate blood pressure reading looks fine.
But the pump is burning out.
Exactly. By minute 4, the motor just fails, the pressure bottoms out, and the basement floods.
So by missing that burnout phase in the clinic, they generate a false negative. The patient's chart says their orthostatic vitals are completely normal.
But in reality, if that same patient stands in their kitchen cooking dinner for 5 minutes, their internal pump fails, they lose brain perfusion, and they black out.
It's scary because we often treat a drop in blood pressure upon standing as one singular monolithic event. But the sources point out the underlying mechanisms create a whole family of drops.
A whole family, yeah. You have classic OH, which is the 2010 drop within the first 3 minutes. Then you have initial OH, which is this exaggerated, massive drop in the very first 15 seconds of standing, but the body immediately self-corrects.
And standard manual blood pressure cuffs cannot even catch initial OH because the mechanical inflation just takes too long, right?
Right. You need continuous beat-to-beat arterial monitoring to even witness it happening.
We also have the delayed OH we just discussed. And finally, there is postprandial hypotension.
Yes. This is a related but distinct mechanical drop that happens specifically after eating a meal.
Which ties directly back to that Splanchnik balloon we discussed earlier.
Exactly.
The body redirects a massive volume of blood to the gut to aid in digestion. In older adults, especially, nursing home residents, that Splanchnik pooling is so severe that if they stand up immediately after a heavy lunch, their already taxed system just cannot fight gravity.
And their pressure completely bottoms out. It is a huge contributor to afternoon falls that a standard morning clinic check completely misses.
And measuring this wrong has devastating consequences.
Yeah.
We're not just talking about feeling a little lightheaded here.
No, not at all.
For vulnerable populations, OH is a major, highly modifiable contributor to traumatic brain injuries, hip fractures, or just the permanent loss of independence.
The nursing home tragedy outlined in our sources is arguably the most common and, frankly, heartbreaking scenario we see.
Yeah, let's paint that picture. Imagine an elderly patient in a care facility. A doctor checks their blood pressure. While they are sitting in a chair, it reads high. They have seated hypertension.
Right.
Doing their job to prevent a heart attack or a stroke, the doctor prescribes multiple blood pressure medications to get that seated number down.
And those medications often work by vasodilating, which is chemically forcing the pipes open or acting as diuretics to reduce fluid volume.
So we are intentionally inducing the leaky pipe and low tank plumbing issues we talked about earlier.
Exactly. We are creating the problem.
So later that evening, the patient stands up to go to the bathroom. Because of the heavy load of vasodilating medications, their body is chemically blocked from constricting those vessels to fight gravity.
Their blood pressure crashes, they lose perfusion to the brain, they get dizzy, and they fall, often shattering a hip.
And the real tragedy is what gets written on the chart.
Yes.
It gets logged as a mechanical fall, or it is blamed on unsteadiness, generalized aging, or even dementia. The fall is completely misattributed.
The very treatment that was intended to reduce their cardiovascular risk became a direct, immediate fall risk hazard. If someone had just checked their standing vitals at that 3-minute mark, they would have seen the numbers crash and they could have adjusted the medications.
It's so preventable. Another massive real-world example of the wiring failing is diabetic neuropathy, isn't it?
Oh, absolutely.
We always hear about how long-standing diabetes damages the nerves in the extremities, causing people to lose sensation in their feet.
Right, peripheral neuropathy.
But the exact same degradation is happening to the microscopic nerve fibers that carry the baroreflex signals. The chronically high blood sugar literally degrades the myelin sheath and damages the wiring of the autonomic nervous system.
So a diabetic patient can have totally normal blood pressure sitting down, but the moment they stand, the electrical signal simply never reaches the brain.
And that structural nerve damage leads directly into some incredibly dangerous clinical misconceptions in the real world.
It really does.
The biggest one being the instinct to treat the fluid tank instead of the wiring. You see a patient whose blood pressure is crashing when they stand, the immediate instinct is to assume they are just dehydrated. The logic is, give them a glass of water, run an IV of saline.
Which is misconception number 4 in the sources. 4V fluids will not fix a broken baroreflex.
Right.
If the patient has Parkinson's or diabetic neuropathy, their fluid tank is completely full. Their fluid status is normal.
Overloading them with saline does absolutely nothing to fix the degraded nerve wiring.
And it can actually push them into heart failure by overflowing the tank.
Wow. Another misconception is the assumption that OH always causes fainting. The flawed logic dictates that if a patient isn't actively passing out, they don't have the condition.
And that is so dangerous. A huge proportion of patients with chronic neurogenic OH are entirely asymptomatic.
Really?
Yes. Over months and years, their brains simply adapt to operating on a lower perfusion pressure. They might feel a little tired or, experience vague cognitive fog, but they don't faint.
So if a doctor waits for the patient to explicitly complain of dizziness before checking their orthostatic vitals, they will just miss the diagnosis completely.
Exactly.
Here's where it gets really interesting. This leads to an incredible paradox in treating these neurogenic patients. Let's say you properly diagnose a patient with severe neurogenic OH. Their standing pressure is dangerously low, and you want to fix it.
Right. You want to keep them safe on their feet.
You give them a medication like midodrine. Midodrine acts as a chemical clamp on the blood vessels, forcing the pressure high enough to keep them safely conscious where they're standing up. But what happens when they go to sleep? The pill doesn't know they laid down.
It creates the ultimate medical tightrope. We call it supine hypertension.
Okay, explain that.
So the patient's regulatory system is broken and cannot adapt to positional changes, right? You chemically clamp their blood vessels shut during the day. When they go to bed at night and lie flat, gravity is no longer pulling the blood down to their legs. The fluid is evenly distributed again.
But their blood vessels are still chemically forced open. Wait, chemically forced shut and pumping hard because of the midodrine still in their system.
Exactly. The exact same patient who was at risk of fainting from low pressure during the day is now at severe risk of a hypertensive stroke while they sleep
Oh my God.
because their lying down blood pressure has just skyrocketed against those clamped vessels.
It is a terrifying balancing act. The sources mentioned that sometimes the only safe solution is having the patient literally sleep with the head of their bed elevated on physical blocks, just to keep a little bit of gravity in the equation at night to prevent a stroke.
It underscores the golden rule of autonomic medicine. You have to treat the patient's function, not just a numerical target.
Which brings us to the final and perhaps most profound revelation in our source material. We have spent this entire time looking at how orthostatic hypotension causes mechanical falls today, right in the present moment. But in some patients, this vital sign is actually a warning siren for what is going to happen to the brain years from now.
This is where the science shifts from reactive mechanics to, honestly, visionary neurology.
Let's talk about Scheidegger syndrome, or what modern medicine now calls multiple system atrophy, or MSA.
Yeah.
This was first described back in 1960. It's a condition where severe OH is combined with Parkinson-like motor symptoms.
Yes. And for a long time, doctors just treated the blood pressure drop and the motor tremors as like separate issues that just happened to show up in the same patient.
But the clinical consensus eventually shifted as the pathology became clearer.
Right. Exactly. They realized MSA is a specific type of disease called a synucleinopathy.
Okay.
It is caused by misfolded alpha-synuclein proteins clumping together in the nervous system. These abnormal protein deposits physically gum up and suffocate the nerve cells.
And that is the exact same underlying mechanism as Parkinson's disease.
Yes. If we connect this to the bigger picture, delayed or neurogenic OH isn't just a quirky vital sign abnormality, it is often a prodromal clue.
Meaning pre-diagnostic.
Right. It acts as a pre-diagnostic signal pointing directly to a neurodegenerative disease long before the classic symptoms ever appear.
Because the autonomic wiring, the subconscious nerves controlling your blood pressure, your digestion, your temperature, it's all incredibly delicate, right?
Very delicate. Those autonomic nerves often succumb to the misfolded protein deposits years before the motor cortex does.
Yeah.
So years before a hand tremor or a shuffling walk ever becomes visible, the baroflex starts to fail.
So a simple, properly conducted vital sign check in a general medicine clinic might just be the earliest visible thread connecting a patient to a major neurodegenerative diagnosis a decade down the road.
It is quite literally a neurological crystal ball hiding inside a $50 blood pressure cuff.
That is just wild.
It really underscores why understanding the mechanics behind this basic low-tech screening tool is so incredibly powerful.
As we wrap up this deep dive, let's take a step back and look at the mechanical journey we just mapped out. We started with the sheer physics of it. The massive volume of fluid pulling into the splash-check balloon every time you stand, and the nucleus tractus solitarius frantically signaling the vessels to clamp shut.
The amazing baroflex arc.
We navigated the 2010 rule and why treating a fixed number ignores the actual perfusion of the patient's brain. We broke down the plumbing versus wiring distinction, separating the leaky pipes from the degraded nerves.
Right.
We covered the absolute necessity of that 3-minute check to catch the failing pump of delayed drops. And we explored the terrifying paradox of supine hypertension, where chemically fixing a fall risk can inadvertently create a stroke risk at night.
I want to speak directly to you listening right now. If you, an aging parent, or any family member ever complains of feeling dizzy or heavy when standing up, or if they're taking multiple blood pressure medications, you now hold a very specific, actionable piece of knowledge, to advocate for the full 3-minute orthostatic vital signs protocol. Do not let a rushed clinician check it immediately and move on. Insist on the 3-minute wait to ensure the internal pump isn't burning out.
Yeah.
It is one of the highest yield, lowest cost interventions in all of medicine. It takes exactly 3 minutes, and it can prevent a catastrophic, life-altering fall.
It is so empowering to realize how much control we can have over such a massive invisible risk. But before we go, I want to leave you with one final lingering thought to mull over. We have spent this entire time deconstructing what happens when the baroflex fails to respond to gravity.
Right, the pressure drops.
The blood pressure drops, the brain loses oxygen, and the system crashes. But what happens when the reflex doesn't fail, but instead goes into an absolute panicked overdrive?
Oh, this is fascinating.
There is a condition called POTS, postural orthostatic tachycardia syndrome. It is incredibly common in younger people, particularly women. When they stand up, their blood pressure doesn't drop at all,
The pressure stays perfectly stable.
but their heart rate absolutely skyrockets. It races out of control, maintaining an excessive, exhausting compensatory response just to keep them upright.
It is a fascinating mirror image of everything we just explored today.
And a perfect reminder of how incredibly delicate the balance of our autonomic nervous system really is. Until next time, the next time you push yourself out of a chair and walk across the room, take a second to appreciate the silent, split-second medical miracle happening inside your chest and your neck, actively fighting off gravity just to keep you on your feet. If you've ever been sitting in a hospital room, either as a patient or just watching a loved one get care, you probably know the ritual. A nurse walks in, they scan a barcode on your wristband, look you right in the eye, and ask you to state your name and date of birth before they hand over, like a single Tylenol.
Yeah, and they do it every single time.
Exactly. It can feel a bit repetitive, like bureaucratic overkill, especially when they just did the exact same thing 3 hours ago and clearly know who you are. But that tiny repetitive exchange is actually a surprisingly fragile safety net.
A very fragile one, yeah.
Right. And it's one with this ghostly, almost unscientific origin story that is currently at the center of a pretty heated medical safety debate. So, welcome to today's deep dive. We are unpacking what the medical world calls the rights of medication administration.
It sounds so formal, doesn't it? But it's essentially a critical checklist.
Yeah, a checklist designed to stand between routine medical care and fatal errors. We are going to explore how this checklist was born, why the original version of it is fiercely debated when things go wrong, and how this seemingly simple concept protects, or I guess sometimes fails to protect, every single one of us.
It's an incredibly important topic because the landscape of patient safety, it really forces us to look at how humans interact with complex systems. We're talking about something that is foundational to modern healthcare training.
It's basically drilled into them from day one, right?
Oh, absolutely. But when you examine the history and the underlying science of these protocols, you start to realize this mental checklist is carrying a weight it was never entirely designed to hold.
Okay, so let's get into what these rights actually are. Because any nursing student knows the classic checklist. It's the right patient, right drug, right dose, right route, and right time. The 5 rights. And reading through the source materials for this deep dive, I just assumed this list was a rigid, official, universal standard. But it turns out this golden rule is actually kind of a moving target.
Oh, it is entirely fluid. I mean, if you go to 5 different nursing schools today and ask how many rights there are, you will likely get 5 different answers.
Wait, really?
Yeah, you might hear 5, 6, 8, 9, or even 12 rights.
12?
Exactly. Over the last 30 years, educators and safety organizations have just organically bolted on new items to patch gaps that the original 5 failed to cover.
That is wild. I mean, the additions are fascinating, though. You have things like right documentation, which makes total sense in a litigious world. But then there's the right reason, meaning the nurse has to understand exactly why this specific patient is getting this specific drug.
Right. They can't just be a delivery system. They need to know the why.
And there's the right response, checking if the drug actually did its job without causing an adverse reaction. And one that really stood out to me was the patient's right to refuse. Because patients aren't just passive objects on a bed, right? They can say no, and the system has to document and respect that.
Yeah, that expansion of the list really reflects a growing recognition of how complex healthcare has become. But, the most surprising element of this whole foundational concept isn't how much it's grown, it's actually where it came from.
This is the part that blew my mind.
Right, because unlike almost every other major medical protocol, there is no founding paper.
No paper at all?
Nope. We don't have a specific randomized controlled trial we can point to and say, this study proved the 5 rights drop error rates by 80%. It just doesn't exist.
So it's basically a medical ghost story. How does an ironclad rule that dictates every single medication pass in every hospital just appear out of thin air? I mean, nursing students memorize this stuff as absolute gospel.
It's wild. I know. It really crystallized gradually in American nursing textbooks throughout the 1960s and 1970s. You have to look at the historical context, right?
Yeah.
Before World War II, the pharmaceutical arsenal was relatively small.
You had, penicillin and aspirin?
Pretty much. But after the war, the number of available drugs just exploded. Suddenly, hospital pharmacology got incredibly complex, incredibly fast. And the nursing profession, they just needed a cognitive scaffold to manage all this new complexity. So this checklist just sort of emerged as folk wisdom, a consensus among educators.
So this isn't a lab-tested formula at all. It's more like a family recipe for safety that just got passed down. Like somebody figured out how to not burn the roast, and then the next generation added a pinch of salt, and eventually everyone treats the recipe as absolute law.
That is the perfect analogy. It was a pragmatic reaction to a growing problem, not a scientifically validated intervention. And safety organizations today, like the Institute for Safe Medication Practices, they are very vocal about this. They emphasize that despite decades of universal teaching, there has never been robust empirical evidence proving that simply reciting these 5 rights measurably reduces errors.
Which is unsettling, honestly.
Yeah.
But even if it is just folk wisdom, the core ideas do make intuitive sense. I mean, stripping away the medical jargon, the guiding question behind the rights is essentially, what could go wrong right now, and have I tangibly ruled it out?
Exactly. It's a defensive mindset.
And when you look at the mechanics of what happens when these rights are violated, the risks are absolutely terrifying. So let's break down that core 5, starting with the right patient. Obviously, you need to ensure you aren't medicating the wrong person, but the sources are very clear that just checking a room number is completely insufficient.
Oh, room numbers are practically useless for identification. Patients are transferred, beds get swapped. Hospitals are incredibly dynamic environments. And you also have a massive issue with look-alike and sound-alike names.
Like 2 John Smiths on the same floor.
Exactly. Furthermore, the patient themselves cannot always be a reliable narrator of their own identity. Think about it. If someone is heavily sedated in the ICU, or they're experiencing dementia, or they're a toddler, or maybe they simply don't speak the dominant language of the hospital, you need objective confirmation.
Right.
That is why 2 unique identifiers, usually a full name and a date of birth, cross-referenced with a barcode scan that is the absolute minimum standard today.
Which leads directly to the right drug.
Yeah.
And this one highlighted a really crazy conflict between pharmaceutical marketing and patient safety. Because drug names aren't designed to be distinct, are they? They are engineered by marketing departments to sound memorable.
Yeah, and that marketing imperative creates massive vulnerabilities.
Yeah.
The classic example in the literature, the one everyone talks about, is insulin. You have Humalog, which is a rapid-acting insulin, and Humulin, which is an intermediate or long-acting insulin.
I mean, they sound virtually identical when spoken aloud in a busy hallway. Humalog, Humulin.
They do, and they sit in similar-looking vials in the refrigerator, but the mechanism of action is vastly different. So if a patient is prescribed the long-acting Humulin, right, to provide a steady baseline of insulin over 24 hours.
Just a slow drip, basically.
Exactly. But they accidentally receive the rapid-acting Humalog. Their blood sugar doesn't just dip slightly, it crashes immediately. They can go into severe hypoglycemic shock, leading to seizures or brain damage, simply because a single syllable was misread.
Just one syllable. That is so scary. Then we have the right dose. And the sources point out that pediatric and oncology dosing are where right dose failures become uniquely catastrophic, because we aren't talking about accidentally giving 2 Advil instead of 1.
No, not at all. The stakes are exponentially higher in pediatrics and oncology because medications are rarely standard, flat doses. You don't just hand them a pill. They're typically dosed based on a patient's weight in kilograms or their total body surface area.
So there's math involved every single time.
A lot of math. And the clinician has to calculate the exact dose while also factoring in things like renal function, which dictates how effectively the patient's kidneys can filter and clear the drug from their bloodstream.
Because if the kidneys are compromised, a normal dose just builds up to toxic levels in the blood, right?
Exactly. The clearance rate is critical. So when a clinician is doing this complex math, a simple decimal point error doesn't mean the patient gets a 10% extra dose. A misplaced decimal means a 10-fold or even a 100-fold overdose.
Oh my God. 100 times the intended dose of chemotherapy just from a misplaced dot on a chart. That is deeply unsettling.
It really is.
Which brings us to the right time. This is another one that seems straightforward but has complex mechanisms behind it. It's not just about the convenience of the nursing staff doing the rounds, is it?
Not at all. Time is intrinsically tied to pharmacokinetics, which is how the body absorbs and processes a drug over time. Let's say a patient is battling a severe systemic infection and is on IV antibiotics. Those drugs have a specific half-life.
Meaning they wear off at a very specific rate.
Right. They must be administered within a very precise window to keep the concentration of the drug in the bloodstream consistently above the threshold needed to kill the bacteria. If you are late by even a few hours, the blood concentration drops, the bacteria can multiply, and you risk breeding antibiotic resistance.
So timing is literally the medicine working or failing.
Exactly.
Okay, so the last of the core five is the right route. And I have to admit, when I first read the outline for this, I thought, wait, isn't right route just picking whether the patient swallowed a pill or gets an IV? How hard is that to check? But diving into the source material, I realized it is incredibly nuanced. It involves the exact physical site and the specific technique.
Oh, it is far more complicated than just oral versus intravenous. Consider an intramuscular injection, right? The medication is formulated to be absorbed slowly by muscle tissue, but if the clinician injects it into the wrong muscle group or, God forbid, accidentally hits a blood vessel instead of the muscle,
Then what happens?
the drug enters the bloodstream immediately. That is a route failure, and it alters the entire absorption profile. You get a massive spike instead of a slow release.
Wow. The sources also gave this example of feeding tubes versus central lines in an ICU, because a patient might be hooked up to a dozen different tubes, right?
Yeah, in intensive care, patients often have multiple access points. You might have a central venous catheter going directly to the heart, and then an enteral feeding tube going directly into the stomach.
And they look similar.
They're all just clear plastic tubing to the naked eye. So if a liquid medication formulated for the highly acidic environment of the stomach is accidentally connected to the port of the central venous line,
Oh, no.
yeah, you are injecting foreign, unsterile material directly into the central circulation. That kind of route failure is almost always fatal.
That is horrifying. And, knowing the theory behind the checklist is one thing, but the reality is that knowing the rules doesn't guarantee safety. We really have to pivot from the theory to the tragic real-world cases, because the history of modern patient safety is essentially written in blood.
Unfortunately, yes. These abstract concepts only became national priorities because of devastating real-world failures.
Right, and the danger of relying on this folk wisdom checklist really snapped into focus in the 1990s. We're talking about highly trained teams at top-tier institutions failing. Let's talk about the Betsy Lehman case in 1994, because that one is just heartbreaking.
It is. Betsy Lehman was a 39-year-old health columnist for the Boston Globe, and she was undergoing treatment for breast cancer at the Dana-Farber Cancer Institute, which is one of the premier cancer centers in the world.
The irony is just agonizing. She spent her career explaining medical science to the public, and her death became this defining moment for a right dose failure.
She was receiving a chemotherapy drug called cyclophosphamide. And due to a transcription error involving that complex math we discussed earlier, she was prescribed an absolutely massive dose, roughly 4 times the intended amount.
But the mechanism of the failure wasn't just one person making a math error in a vacuum, right? What struck me about this case was the diffusion of responsibility.
Yes, exactly.
Because the order was reviewed by multiple clinicians, pharmacists, nurses, doctors. But because it was a complex experimental protocol, everyone just assumed the other person had verified the math.
That's the trap. Individual vigilance failed repeatedly. She received that massive lethal overdose over 4 consecutive days before she died. No one caught it.
It's just devastating. And it shattered the illusion that we could rely entirely on individual human vigilance. It proved that if the system allows ambiguity, even brilliant, dedicated professionals will fail to catch an error.
Absolutely. And we see that same systemic failure moving upstream in the medication supply chain with the case of Emily Jerry in 2006.
She's a little girl, right?
Yeah. Yes. She was a 2-year-old girl who had successfully come through cancer surgery, only to die from a right drug and right dose failure. And this one happened far away from her hospital bed.
Right, this wasn't a bedside nursing error.
No. Emily's the fief bag was prepared in the hospital pharmacy by a pharmacy technician. The technician used a sodium chloride solution, essentially salt water, that was at roughly a 20% concentration. The standard, safe solution is a highly dilute 0.9%.
20% versus less than 1%. And to understand the mechanism of why that is so lethal, we have to look at osmosis. If you pump a 20% salt solution into the bloodstream, you create a massive osmotic gradient. The blood becomes so salty that water actually rushes out of the surrounding cells to try and dilute it.
It literally shrinks the cells in the brain, tearing blood vessels and causing massive neurological devastation.
It's a horrific physiological cascade.
Emily died days later. Her tragedy really underscored that the rights of medication administration don't just apply to the nurse at the bedside. The failure happened in the preparation stage, emphasizing that the entire supply chain must have built-in defenses. It actually led directly to state laws mandating the rigorous certification of pharmacy technicians.
It's good that laws changed, but the loss is just unfathomable. But perhaps the most haunting failures we read about were the vincristine deaths.
Oh, the vincristine cases are a perfect example of system design failure. Vincristine is a potent chemotherapy drug designed exclusively for intravenous use. If it is given intrathecally, meaning injected directly into the spinal fluid, the results are catastrophic.
It's invariably fatal, right?
Always.
Yeah.
When vincristine enters the spinal fluid, it rapidly destroys the central nervous system from the bottom up, causing a slow, agonizing, ascending paralysis.
Oh my God, that's horrific. But what I found staggering in the sources is the persistence of this specific error. I mean, if every single nurse and pharmacist globally is taught the right route checklist in school, how does this exact same fatal error keep repeating across different hospitals for half a century? The sources said there were over 120 cases worldwide. It defies logic.
It defies logic if you believe that a mental checklist is a robust system. But it is not. If you rely purely on human memory, eventually a clinician experiencing extreme fatigue or stress will grab the wrong syringe and make a lethal connection. The vincristine deaths forced the safety community to realize they needed forcing functions.
Forcing functions meaning a physical design change that removes human memory from the equation entirely, right?
Yes, precisely. The mandate became that vincristine could never be dispensed in a standard syringe. It had to be dispensed in a labeled mini bag.
Because you cannot physically hook a mini bag up to a spinal needle. It requires an entirely different connection port.
Exactly. You took an error that persisted through decades of mental checks, and you solved it by making it mechanically incompatible. A physical system redesign stopped the error where human vigilance had repeatedly failed.
And this brings us to the core of a very fierce internal debate within the medical community, heavily driven by the Institute for Safe Medication Practices, or ISMP. Because if you acknowledge that human vigilance is flawed, you have to rethink who actually gets blamed when a right is violated.
This is the crux of modern patient safety. The ISMP argues that the 5 rights describe the outcomes we want to achieve, the right patient getting the right drug, but they do not represent a reliable system for achieving those outcomes.
So treating them as a personal mental checklist places an unfair burden on one person.
Yes, they call it moral scapegoating. If you blame the nurse at the sharp end of the system, the person holding the needle, you are entirely ignoring the systemic failures at the blunt end.
Okay, let's define that for the listener. The blunt end being the environment that sets that nurse up to fail in the first place. We're talking about poor lighting in the pharmacy, chronically short-staffed shifts, a culture of being interrupted constantly while trying to calculate doses.
Or confusing order interfaces on the computer, or pharmaceutical companies designing look-alike packaging.
Exactly. The blunt end creates the conditions that make a sharp end failure practically inevitable. This sounds exactly like James Reason's Swiss cheese model of accident causation.
It is the defining model, yeah.
I love this analogy. So to apply it here,
Yeah.
think of every safety protocol in a hospital as a slice of Swiss cheese. A mental checklist is one slice. The pharmacy review is another slice. The computer alert is another. They all have holes in them because nothing is perfect.
Right. Humans make mistakes, technology glitches.
But usually, the holes don't line up, so an error gets caught by the next slice of cheese. But if the holes in all the slices align perfectly, say, a short staff shift on top of confusing packaging, on top of an exhausted doctor, the error drops straight through all the holes directly to the patient.
That was a brilliant way to explain it. A serious harm event almost always requires multiple system defenses to fail simultaneously. And one of the most famous historical examples of this alignment of holes is the Libby Zion case in New York in 1984.
Right, Libby Zion. She was an 18-year-old college student who went to the hospital with a fever and agitation. And she was tragically given a painkiller called meperidine, which most people know as Demerol.
And this became a fatal right drug failure because Libby was already taking a prescription antidepressant at home, an MAOI called phenelzine.
The mechanism of this interaction is a classic pharmacology nightmare. Phenelzine, the MAOI, works by inhibiting the enzyme that cleans up neurotransmitters like serotonin in the brain. Meperidine, the painkiller, triggers the release of a massive amount of serotonin.
It's a deadly combination.
Yeah, when you combine them, the brain is flooded with serotonin and has no way to clean it up. The result is serotonin syndrome, a cascading physiological crisis, causing a fatal fever and seizures.
The pharmacological interaction was the proximate cause of death, but the system failure was far deeper. It was a failure of medication reconciliation, which is the rigorous process of cross-checking a patient's home drug list against new hospital orders. And crucially, this failure was compounded by the blunt end.
The exhaustion, right?
Yes, exhausted, overworked resident physicians making critical decisions in the middle of the night after working unimaginable hours.
That tragedy sparked a massive public outcry. It led to the Libby-Zion law in New York, which finally placed strict limits on the consecutive hours resident physicians could work. The investigation recognized that the rights violation wasn't just simple carelessness. It was a symptom of a deeper systemic flaw, which was severe fatigue.
You cannot just tell a resident who has been awake for 36 hours to be more careful and expect the error rate to drop. Fatigue impairs executive function just as severely as alcohol intoxication. Recognizing that was a massive paradigm shift in medical safety.
So if human memory is inherently fallible and systemic exhaustion creates giant holes in the Swiss cheese, why hasn't modern technology completely solved this problem? I mean, everything has a barcode now, right?
Technology has certainly revolutionized the process, but it is not a silver bullet. Hospitals introduced barcode medication administration, or BCMA, and the theory is airtight. The nurse scans the patient's wristband, then scans the drug, and the software algorithm confirms the right patient, drug, dose, route, and time.
It sounds completely foolproof. The computer just takes over the mental load.
It does, but introducing technology also introduces new, unforeseen failure modes. Because humans are still involved in the physical administration, and humans under intense time pressure will always adapt. The research highlights a widespread phenomenon known as workarounds.
Oh, workarounds. What does a workaround look like in practice here?
Imagine a nurse on a night shift. The patient is finally asleep. The barcode scanner is tethered to a cart in the hallway, and the cord doesn't quite reach the bed. Scanning the wristband means waking the patient up, turning on the harsh lights, and pulling this clunky equipment into a cramped space.
Which nobody wants to do at 3 a.m.
Exactly. To save time and preserve the patient's sleep, a nurse might print an extra copy of the patient's wristband barcode and tape it to a clipboard, or even to the wall outside the room so they can scan it quickly without entering.
Wait, really? That scanning workaround sounds exactly like buckling a car's seatbelt behind your back just to stop the warning chime because you're in a massive hurry. The technology is actively trying to save you, but human time pressure defeats the safeguard entirely.
That is a perfect analogy. The tool becomes a hurdle rather than a safeguard. And compounded with workarounds is the issue of alert fatigue.
Alert fatigue.
Yeah, modern electronic health records are incredibly sensitive. They pop up with a warning for every minor, potentially irrelevant drug interaction. If a clinician sees 50 yellow warning boxes a shift that turn out to be harmless, they develop muscle memory to blindly click ignore on every pop-up.
Just clicking through terms and conditions.
Exactly. And eventually, they click right past a critical, life-saving red alert.
Which explains why for the most dangerous drugs, the high-alert medications like insulin, opioids, or chemo, they don't just rely on one nurse and a computer scanner anymore. They require extra independent double checks, forcing a second nurse to separately calculate and verify the dose.
Redundancy is the only proven defense. And all of these realizations from forcing functions to alert fatigue have really culminated in a modern healthcare management philosophy called just culture.
How does just culture change the environment on the hospital floor?
It attempts to resolve the tension between individual accountability and system design. Under a just culture framework, individuals are held strictly accountable if they engage in genuinely reckless behavior like charting a medication they never actually gave or coming to work impaired.
Sure, that makes sense.
But crucially, it mandates treating honest, foreseeable human error as a system design flaw to be fixed. If a well-meaning nurse makes a mistake because 2 drug vials look identical and the lighting is poor, you don't fire the nurse.
You change the lighting.
You change the lighting and mandate different packaging. It fosters an environment where clinicians feel safe reporting near misses, allowing the system to learn and adapt rather than burying mistakes out of fear of termination.
That is such a vital shift, because when you look at this entire landscape, from the ghostly origins of the 5 rights in the 1960s to the complexities of alert fatigue and workarounds, it really changes how you experience care as a patient. The 5 rights are a floor, not a ceiling.
Definitely a floor.
The Institute of Medicine's landmark 1999 report estimated that tens of thousands of Americans die every year from preventable medical errors, with medication-related errors making up a massive portion of that tragedy. And that's not an abstract number.
No, those numbers represent a profound loss of life that stems from incredibly complex systemic interactions, not just simple negligence.
They're real people, like Betsy Lehman and Emily Jerry. So, to our listener, the next time you are in a hospital bed and a clinician pauses, looks at your wristband, and asks for your name and birth date before handing you a medication, you realize you aren't just answering a repetitive question, you're actively participating in a decades-old system of redundant defenses.
You are acting as the final critical patch over a hole in the Swiss cheese. The patient is truly the final check in the system.
But there's a final kind of provocative thought I want to leave you with to mull over on your own. We have seen that human vigilance inevitably fails, even among world-class experts. And we have seen that digital barcode systems are regularly defeated by exhausted clinicians who are forced to create workarounds just to survive the pus of their shift. So maybe the ultimate future of patient safety shouldn't be about adding more checks to a mental list or installing louder alarms on a computer screen. Maybe the future requires entirely redesigning the physical tools of healthcare, just like they did with the vincristine syringe, so that making a fatal mistake doesn't just trigger a warning chime, it becomes mechanically impossible. Moving from a culture of be more careful to a system where it cannot be done wrong. Something to think about the next time you hear that familiar question. Can you confirm your name and date of birth for me? Until next time, keep diving deep. Imagine standing in an intensive care unit, right? And you're watching a nurse prepare to just remove a piece of plastic tubing from a patient's neck.
Right, which on the surface looks like the most benign task in the world.
Exactly. You'd think, you pull it out, apply some pressure, slap a dressing on it, and you're done.
But that is definitely not what happened.
No. Instead, the bed is abruptly flattened, the patient's head is tilted downward, the nurse leans in, instructing the patient to, take a deep breath, hold it, and bear down as if they're lifting something incredibly heavy.
Yeah, the tension in the room just spikes.
Because if the timing of this removal is off by
even a single second?
Right, a sudden hiss of air could get sucked into the open vein, travel straight to the heart, and cause, immediate cardiovascular collapse.
It's a phenomenal contrast. I mean, we see these lines sitting quietly taped to a patient's chest or arm for weeks, just blending into the background of standard hospital equipment.
Yeah, completely invisible almost.
But the physical laws governing them are just incredibly unforgiving.
And that is exactly what we are focusing on today. Welcome to our deep dive into central venous catheters, which are universally known as central lines.
A very fitting name, as we'll get into.
For sure. So our mission for you today is to completely re-examine this vital access point. You might look at a central line and assume it's just, a heavier duty version of a standard 5E.
Which is a super common misconception.
Totally. But today, we are breaking down the fascinating battlefield physiology of these lines, the hidden biological and honestly bureaucratic risks they carry, and the intense daily discipline required to keep patients safe.
Yeah, we have a really great stack of sources covering the core principles, the debates surrounding complication rates, and the meticulous care protocols required for these lifelines.
So to understand why a central line demands that level of respect, we first have to establish what makes it, central.
Right, and the defining feature has absolutely nothing to do with where the needle punctures the skin.
Okay, let's unpack this. Because framing the device entirely around its destination completely changes how we evaluate the risks.
Exactly. A catheter earns the classification strictly based on the final resting place of its tip. By definition, that tip must reside in one of the great vessels of the body.
Specifically, like the lower third of the superior vena cava, right?
Yep, right at the cavoatrial junction where it meets the right atrium of the heart.
So the destination dictates the fluid dynamics, which is kind of the entire point of the device.
Oh, absolutely. The superior vena cava is this massive conduit. Blood is rushing past that catheter tip at roughly 2 liters per minute.
2 liters a minute. That's just wild to picture.
It really is.
So if I can offer an analogy here to help visualize that flow rate, placing a standard peripheral IV into a small vein in your forearm and pushing highly concentrated medications through it. It's like dumping a bucket of harsh industrial chemicals into a tiny, slow-moving creek.
Right. The chemicals just linger there.
Exactly. It inevitably damages the banks of that creek. But a central line bypasses the creek entirely and drops that same payload directly into a roaring river.
That's a perfect way to look at it. The volume and the velocity of that flow instantly disperse whatever you're putting in. The sources actually highlight total parenteral nutrition, or TPN, as the classic example of this.
Right, IV nutrition.
Yeah. When a patient relies entirely on IV nutrition, the fluid is incredibly hypertonic. It's thick, heavily concentrated stuff.
And if you try to infuse that into a standard arm vein, the clinical guidelines cap the concentration at about 900 milliosmoles per liter, right?
Spot on. And the reason for that strict cap comes down to basic cellular osmosis.
Because if you put something that concentrated in a small vessel,
Right. The massive number of solute particles creates an osmotic gradient. It literally draws water out of the veins and endothelial cells just to balance the concentration.
oh wow, so it's basically dehydrating the vein from the inside out.
Precisely. Those cells shrink, which triggers this immediate inflammatory cascade, resulting in severe phlebitis.
And that inflammatory cascade is exactly what destroys the peripheral access, which forces the care team to constantly, hunt for new veins.
Yeah, it's a nightmare for everyone involved, but central lines bypass that limitation completely.
Because of that 2 liter a minute flow.
Exactly. You can safely run TPN at 1,800 to over 2,000 milliosmoles per liter through a central line.
Rather than double the peripheral limit.
Because it hits that roaring river, the hypertonic fluid is diluted into the systemic circulation instantaneously, long before that damaging local osmotic gradient can even form against the vessel wall.
That actually clears up a major misconception I hear from people. Folks who are somewhat familiar with the infection risks of central lines often wonder, why don't teams just default to standard IVs to play it safe?
Right, they think, just use the smaller needle, it's safer.
Exactly. But it's not a simple hierarchy of safety, is it?
No, not at all. It's about matching the tool to the therapy. Delivering a harsh, vesicant-like, highly concentrated potassium chloride or continuous vasopressors through a peripheral IV risks extravasation.
Which is when the drug leaks into the surrounding tissue, right?
Yes. And that can cause severe localized tissue necrosis. A central line neutralizes that specific devastating risk.
And this destination-based definition completely changes the calculus on things like PICC lines too. Peripherally inserted central catheters.
Oh, absolutely. The entry point for PICC is in the arm, usually the basilic or cephalic vein in the bicep.
Which feels psychologically very similar to a standard IV.
It does, but the catheter itself is significantly longer. It's threaded all the way through the shoulder, the axillary and subclavian veins, until the tip reaches that exact same caboatrial junction near the heart.
So clinically, biologically, and from a risk surveillance standpoint, a PICC is a central line.
100%.
Which is wild. So threading a piece of plastic all the way into the central circulation to harness that massive blood flow is an incredibly effective concept.
Brilliant.
But successfully navigating a needle and a wire deep into the chest cavity, mere millimeters from the lung and major arteries, that seems terrifying. How did we even figure this out?
Well, the push to solve that anatomical puzzle actually originated under really desperate circumstances. The foundational technique goes back to a French surgeon named Robert Aubagnac in 1952.
Okay, 1952.
Yeah, and he was operating in battlefield conditions, attempting to rapidly resuscitate soldiers who were suffering from profound hemorrhagic shock.
And when a patient is in profound shock, their peripheral veins shut down completely, don't they?
Exactly. The body aggressively clamps down on the veins in the arms and legs to shunt whatever blood volume is left to the brain and vital organs.
So you physically cannot thread a standard IV into a fully collapsed arm vein.
You just can't. So Aubagnac leveraged a crucial piece of human anatomy to bypass this. The subclavian vein, which is positioned just beneath the collarbone.
The clavicle, right?
Right. It doesn't collapse. It remains open even in severe shock because the vessel wall is physically tethered to the underside of the clavicle and the surrounding dense tissue.
So it acts almost like a rigid tent, holding the vein open regardless of how low the patient's blood pressure drops.
That's exactly it. The access point is permanently available.
But, stabbing a hollow needle blindly into the chest of a bleeding trauma patient still sounds like a remarkably blunt instrument.
Oh, it was. But the refinement of that blunt instrument came just a year later, in 1953, from a Swedish radiologist named Sven Ivar Seldinger.
Ah, the Seldinger technique.
Yes, and it is arguably one of the most elegant mechanical solutions in modern medicine. Instead of trying to force a large, stiff catheter directly through the tissue and into the vein.
Which sounds awful.
Yeah, super traumatic. Instead, you puncture the vessel with a very small gauge hollow needle. Then you thread a soft, flexible guide wire through the needle and down into the vein.
Okay, so the wire is in.
Right. Then you remove the needle, leaving only the wire in place. And finally, you slide a dilator and the actual catheter over that wire, which guides it perfectly along the established path.
It's like threading a needle, but from the inside out. That transforms a high-risk puncture into a really controlled, scalable insertion.
And we still rely entirely on the Seldener technique today.
But an emergency trauma line designed to pour in fluids for a few hours on a battlefield is fundamentally different from, say, a line placed in an oncology patient who needs aggressive chemotherapy for 6 months.
Totally different requirements. The leap to long-term central access didn't happen until the 1970s with John Broviac and later Robert Hickman.
Okay.
They were managing medically fragile patients, particularly those undergoing intensive bone marrow transplants. So they swapped out the stiff plastics for wider, softer silicone tubing that could live safely in the veins for months.
But the material alone wasn't the biggest breakthrough, was it?
No, their true innovation was this tiny little cuff made of Decrin, which is a synthetic polyester wrapped around the external portion of the catheter that sits cuddled under the skin.
I read about this in the sources. That Dacron cuff essentially tricks the body into accepting the foreign object.
Right. It creates a localized inflammatory response. The body's immune cells, like macrophages and fibroblasts, recognize the porous synthetic texture of the Decrin.
And then they just grow into it.
Pretty much. Over the course of a few weeks, those fibroblasts migrate into the cuff and lay down a dense collagen matrix.
So the tissue biologically integrates with the polyester.
Exactly. It locks the catheter in place and creates this impenetrable fibrotic barricade that physically stops skin bacteria from migrating down the outside of the tubing and into the bloodstream.
That is just brilliant.
Yeah.
But, given that we've been refining this tech and these anatomical approaches since the 50s and 70s, surely we figured out the absolute safest place on the body to put these things by now, right?
And you would think so.
Huh.
But the medical community is actually still heavily divided on the best approach because there is no universal safest site.
It's all about trade-offs, isn't it?
Strict geography of clinical trade-offs.
Ah.
We have really extensive data on this, most notably from the landmark 3 Sites trial, which was published in the New England Journal of Medicine in 2015.
Right. They looked at the 3 primary access points.
Yeah. The subclavian vein in the chest, the internal jugular in the neck, and the femoral vein in the groin.
Let's break down those trade-offs, starting with the Chestop-Baniak's original subclavian approach.
So the subclavian site boasts the absolute lowest rate of catheter-related bloodstream infections and symptomatic blood clots.
Because it sits on a nice, flat, clean portion of the chest.
Exactly. It's incredibly easy to maintain a sterile dressing there. But the trade-off is mechanical.
Because of the lungs.
Right. Because the vein rests intimately against the top of the lung, it carries the highest risk of insertion trauma. Specifically, there's a 1 to 2% risk of causing a pneumothorax collapsing the lung during the needle stick.
Which is a pretty terrifying complication. Conversely, the femoral vein in the groin removes the lung from the equation entirely, right?
It does. The femoral line is technically much easier to place, particularly during a chaotic code blue when the chest and neck are crowded with other providers.
And zero risk of hitting a lung.
0. But its anatomical location makes maintaining strict hygiene exceedingly difficult. The groin is just not a clean area. So the femoral site carries a vastly higher incidence of severe bloodstream infections and deep vein thrombosis if the line stays in place for more than a really short emergency window.
So it requires a critical care team to actively weigh the immediate mechanical risk of insertion against the creeping cumulative risk of infection, all based on what they expect the patient's clinical course to be.
It's the daily balancing act, yeah.
Although it's worth noting that the mechanical insertion risks across the board absolutely plummeted in the early 2000s when the standard of care shifted.
Yes, you're referring to the widespread adoption of real-time 2D ultrasound.
Driven heavily by those 2002 NCLEX guidelines. Yeah,
Exactly. For decades, physicians relied on the blind landmark technique, feeling for the collarbone, finding the pulse in the neck, and just advancing the needle based on where the vein should be.
Which sounds so antiquated now.
It really does. Using ultrasound to actively visualize the needle tip entering the vein on a screen vastly reduced the incidence of accidental arterial punctures and failed attempts.
But even with perfect ultrasound placement, securing the access is just the beginning of the timeline. Because the moment that line is active, the clock starts ticking. The body now has a permanent highway from the outside world directly to the heart.
Which leads to the most persistent battle in critical care.
Right. The long-term maintenance of these lines revolves almost entirely around preventing CLAS sign or central line-associated bloodstream infections.
CLABSIs represent a massive systemic threat in healthcare.
And this brings us to one of my favorite stories in medical safety. The Keystone ICU project, spearheaded by Dr. Peter Pronovost at Johns Hopkins, which was published back in 2006.
Such a game changer.
It really was, because he tackled these catastrophic infections not by engineering some fancy new antimicrobial polymer, but by introducing a rigid 5-item piece of paper, a checklist.
And the elegance of the intervention is in its simplicity.
Let's run through those 5 steps.
Sure. 1. Strict hand hygiene. 2. Maximum barrier precautions during insertion.
Meaning the doctor wears a sterile gown, mask, and cap, and the patient is covered entirely with the massive sterile drape, not just a tiny towel.
Right. 3. Skin antisepsis with chlorhexidine instead of the old povidone iodine. 4. Actively avoiding that femoral site in the groin for adult patients whenever possible.
Because of the infection risk we just talked about.
Exactly. And 5. A daily rigorous review of whether the line is actually still needed.
The results of standardizing those 5 steps were just staggering. The median rate of CLABSIs across the participating ICUs plummeted from 2.7 per 1,000 catheter days to 0.
Absolute 0.
This essentially free checklist decimated a leading cause of hospital-acquired morbidity. But the true genius of the Pronovost checklist wasn't just the physical steps. It was the cultural shift, right?
Definitely. The protocol explicitly empowered nurses to halt the procedure if a physician compromised the sterile field.
Anyone could speak up.
If we connect this to the bigger picture, the Keystone Project demonstrated that clinical safety is fundamentally an active continuous system. It's not a set it and forget it thing.
And sadly, the COVID-19 pandemic revealed exactly how fragile those active systems are.
It was a stark natural experiment. When ICUs were overwhelmed, patient-to-nurse ratios exploded, and severe patients required continuous prone positioning lying on their stomachs. The daily, meticulous maintenance of those lines became nearly impossible.
And hospitals that had proudly maintained 0 CLABSI rates for over a decade suddenly watched their infection numbers surge.
Because the safety net didn't fail due to bad science, it failed because the operational capacity to execute the checklist completely collapsed under the strain.
Which highlights a really significant friction point in clinical practice. When an infection happens, it's really easy to just blame the doctors or nurses, to assume someone must have skipped a step in the dressing change or contaminated a port.
And while breaks in techniques certainly do happen, blaming the staff ignores the fundamental biology of placing a synthetic object into the human bloodstream.
Because bacteria don't just float passively in the blood, do they?
No, especially ubiquitous skin flora like Staphylococcus epidermidis. When they encounter that plastic catheter, they adhere to the surface and begin secreting an extracellular polymeric substance.
It's like a dense, slimy matrix of sugars and proteins.
Yes, a biofilm.
A biofilm.
And this biofilm acts as an impenetrable biological shield. It firmly anchors the bacterial colony to the catheter wall.
And the matrix actually physically blocks the patient's white blood cells, right?
White blood cells and systemic IV antibiotics, they just can't penetrate it. Once a biofilm forms on a central line, you cannot simply push antibiotics through the tube to sterilize it. The infection risk compounds every single day that plastic remains in the vein, regardless of how flawlessly the nurses manage the external dressings.
That biological reality feeds directly into the really intense political and bureaucratic debates surrounding CLABSI reporting.
Oh, the surveillance gaming.
Yeah, because counting these infections isn't just an internal quality metric anymore.
No, in the United States, CLABSI rates dictate hospital reputation metrics and heavily impact financial reimbursement from organizations like Medicare.
Which creates a massive perverse incentive. The CDC's definitions for what technically counts as a CLABSI are incredibly complex, right?
Very complex. They rely heavily on ruling out other potential sources of the bacteria in the blood. And that complexity creates administrative loopholes.
So if a patient with a central line spikes a fever and their blood cultures come back positive,
hospital infection control teams are highly incentivized to meticulously comb through that patient's chart to find an alternative primary source.
so they'll look for anything else to blame.
Exactly. If they can clinically justify that the bacteria actually originated from, say, a suspected urinary tract infection or a developing pneumonia, the event gets reclassified. It's no longer a CLABSI.
Wow. So the hospital's dashboard stays green, the financial penalties are avoided, but the fundamental safety of the patient in the bed hasn't improved whatsoever.
It is the ultimate manifestation of Goodhart's law. When a measure becomes a target, it ceases to be a good measure.
That is wild.
Yeah.
But okay, let's assume the clinical team navigates all of this successfully. The patient's condition improves, they satisfy step 5 of the Pronovost checklist, and the doctor says, great, we can pull the central line.
The prevailing assumption for most people is that removing the device eliminates the danger. You pull the tube out, the infection risk drops to 0, and the patient is safe.
But here's where it gets really interesting.
Mhm.
It goes back to the very first thing we talked about today. The physical act of removing a central line is treated as a high-stakes, code blue emergency drill for nursing students.
Because of that destination near the right atrium.
Right. Explain why taking a simple tube out creates such a terrifying physical dynamic.
It all comes down to atmospheric physics and intrathoracic pressure. The central venous system, especially the superior vena cava near the heart, operates under very low pressure. During inspiration, when a patient breathes in, as the diaphragm drops and the chest cavity expands, the pressure inside the chest actually becomes negative relative to the outside atmosphere in the room.
It essentially creates a vacuum effect inside the vein.
Exactly. So if a nurse pulls a large bore central line out of the jugular vein in the neck, and the hole connecting the skin to the vein remains open for even a fraction of a second,
The pressure differential just takes over.
the vein does not simply bleed outward like you'd expect. Instead, atmospheric pressure forcefully pushes ambient air down the tract and sucks it directly into the central circulation.
An air embolism.
A sudden, massive bolus of air travels instantly into the right ventricle of the heart. The mechanical churning of the heart whips that air and blood into this frothy airlock.
And that blocks the blood flow.
It completely obstructs the pulmonary outflow tract. The heart continues to pump frantically, but no blood can reach the lungs. It induces immediate, often fatal, cardiovascular collapse.
Which perfectly explains the highly choreographed procedure we talked about at the start of this deep dive. When the nurse lowers the bed, they aren't just positioning the patient, they are actively battling a pressure gradient.
Right, the entire removal protocol is designed to artificially manipulate that pressure.
Yeah.
Placing the patient in the Trendelenburg position, which is tilted head down, uses gravity to increase venous pressure at the top of the chest.
And then having them bear down.
That's the Valsalva maneuver. Bearing down forces a massive spike in positive intrathoracic pressure. This guarantees that when the catheter slides out, the pressure inside the vein is higher than the pressure in the room, forcing blood out rather than letting air in.
And then they immediately slap on an airtight occlusive dressing to physically seal the hole.
Exactly. It's not just the insertion procedure in reverse, it's a completely different physiological battle.
It is just a remarkable sequence of events.
Yeah.
When you step back and look at the full life cycle of a central venous catheter, the takeaways are just profound.
They really are.
We define these lines not by how they enter the body, but by their destination in the high-flow central circulation.
Yeah.
A destination that allows for aggressive therapy, like TPN, but brings unique, lethal risks.
Right.
Placing them requires a calculated trade-off between mechanical lung punctures and cumulative infection risk. Maintaining them relies heavily on the rigid discipline of a daily checklist to combat the inevitable biology of biofilms. And finally, just discontinuing them requires a flawless manipulation of atmospheric physics to prevent a catastrophic air embolism.
And, this raises an important question, I think, about how we conceptualize safety protocols in high-risk environments.
Absolutely.
The history of the central line demonstrates that medical safety is not a permanent achievement you can just secure with better technology or a newer plastic. It is a fragile, active practice that must be relentlessly executed and defended every single day.
It absolutely does. And it leaves me with a final thought for you to explore on your own. We discussed how Dr. Pronovost's remarkably simple 5-point piece of paper eradicated central line infections in ICUs across the country.
Yeah.
It succeeded because it fundamentally democratized safety. It gave the frontline nurse the institutional authority to halt a highly trained physician if a basic standard was compromised.
Which is huge.
It really makes you look at the broader world and wonder, what other incredibly complex, high-stakes environments, whether in commercial aviation, corporate boardrooms, or even the daily operations of your own workplace, are currently vulnerable to catastrophic preventable failures simply because they lack a basic checklist that empowers every single person in the room to speak up?
It's a great question.
Think about that the next time you see a seemingly benign piece of plastic tubing taped to a patient's arm. It's never just plumbing. Thanks for joining us on this deep dive. We will catch you next time.
So welcome back to the deep dive. And, we know you're here because you want that really rigorous, aha-filled exploration of complex topics.
Right, without all the overwhelming medical jargon.
Exactly. And today, we are tackling a topic that, honestly, it sounds terrifying, but from a nursing perspective, it's actually this incredible masterpiece of clinical plumbing and physics.
It really is. We're talking about heart failure.
Yeah.
Specifically, what happens when the body's pump just, falls behind.
Right. And our mission for you today is to understand how to spot the really distinct signs of left-sided versus right-sided failure and why our basic human intuition about how to fix this broken pump has historically been completely dead wrong.
Yeah, but before we even get into all that plumbing, we have to dismantle the biggest misconception right out of the gate. Because when people hear heart failure, they usually panic.
Right, they think cardiac arrest, like flatline.
Exactly. But heart failure does not mean the heart has stopped beating.
Oh, thank goodness.
Right. I mean, the heart is still beating, sometimes at a totally normal or even like an elevated rate.
Mm-hmm.
Heart failure is a clinical syndrome. It's not a single disease.
So it's more like a broad category.
Yeah. It just means the heart cannot pump enough blood to meet the body's demands. Or, and this is crucial, it can only meet those demands by abnormally jacking up the pressures inside its own chambers.
Okay, let's unpack this. Because the way we understand this broken pump has fundamentally changed over the years, right?
Oh, massively. The definition of heart failure has been this huge moving target.
Which makes sense. I mean, historically, say, back with the 1971 Framingham criteria, doctors essentially diagnosed this by looking for the biological equivalent of a flooded basement.
That is a great way to put it. Yeah, in the 70s, it was purely about clinical signs. You'd literally go down a physical checklist.
Like, are the neck veins bulging out?
Right. Are the ankles swelling up? Can you hear crackles in the lungs with a stethoscope? It was entirely based on the visible physical backup of fluid.
It's like diagnosing a broken car engine in the 70s, Like, you see thick black smoke pouring out of the tailpipe, so you know it's broken.
Exactly. You didn't need a computer to tell you it was broken.
But today, that's changed. If you look at the 2021 universal definition from the Global Cardiology Societies, it's completely different.
Yeah, they changed the rules. Now, you still need those physical symptoms, but it requires objective evidence to back them up.
Meaning we're plugging the computer into the dashboard now?
Pretty much, yeah. We are looking for structural imaging or elevated biomarkers in the blood, like natriuretic peptides.
And I love this part because these peptides are essentially the heart's own internal distress signal.
That's exactly what they are.
Like when the actual muscle tissue of the heart gets physically stretched out from too much fluid pressure, the cells literally release these hormones into the blood.
Right. And finding that objective evidence became so important because the old 1971 criteria, the tailpipe smoke, was missing a huge chunk of patients.
The invisible patients.
Yes. The old checklist worked perfectly for what we call reduced ejection fraction cases.
Wait, let's quickly define ejection fraction for the listener because this is kind of the mathematical core of the whole thing.
Sure. So a healthy heart doesn't empty out 100% of its blood with every single beat.
Which is wild to think about.
It is. When your left ventricle squeezes, it only pumps out roughly 55 to 70% of the blood inside it. That percentage is your ejection fraction.
Okay, so 55 to 70 is normal.
Right. But in a classic failing heart, the kind with those dramatic 1971 symptoms, the muscle is weak, it's thin, it's floppy.
It just barely squeezes.
Yeah, so the ejection fraction plummets to like 35 or 20 or even 10%. That is heart failure with reduced ejection fraction, or HFrEF.
HFrEF, okay. But relying just on that floppy muscle model entirely missed a parallel condition, which we now call HFpEF.
Heart failure with preserved ejection fraction.
Right, and so the math here looks completely fine.
Exactly. The heart squeezes normally. The ejection fraction is 60%, but the underlying cellular architecture is totally messed up.
Because of things like chronic high blood pressure, right?
Yes, severe hypertension over years and years. The heart muscle bulks up to pump against that high pressure, gets really thick, and over time, this fibrotic tissue, collagen, gets deposited into the muscle.
So it goes from being this nice pliable balloon to like a stiff, hardened litter pouch.
That is the perfect analogy.
It squeezes just fine, but it cannot relax.
So it's a filling problem, not a squeezing problem.
Exactly. The walls are so stiff that the chamber can't expand to let enough blood in between beats. And here's the so what for you listening.
Yeah, why does this matter?
HFpEF makes up roughly half of all heart failure diagnoses today.
Wow, half.
Half. So if you are only looking for a weak pump, you are entirely blind to 50% of the people suffering from this syndrome. Okay, so if half these patients have a weak pump and half have a perfectly strong but stiff pump, how do we end up with the same catastrophic fluid backup? Like, where does the physics of this actually break down?
To understand that mismatch, we actually have to go way back, long before ultrasounds could show us a stiff ventricle.
Oh, you're talking about dropsy.
Yes, back in ancient Egypt and Greece, physicians saw this severe, unexplained swelling of the legs and abdomen, and they just called it dropsy.
And they had no idea the heart was the actual problem.
None. They were just looking at the end-stage fluid backup.
But wait, if they didn't know the heart was involved, how did they eventually stumble onto a heart medication?
Just meticulous observation. In 1785, this English physician named William Withering heard about an old folk remedy for dropsy that used the foxglove plant.
Which is pretty toxic, right?
Very. But he didn't know the mechanism. He just conducted these rigorous clinical studies, treating over 160 cases with a foxglove extract called digitalis.
And we still use derivatives of that today, like digoxin.
We do. It's amazing.
I mean, now we know it messes with the sodium-potassium pumps on the heart cells, right? It lets calcium build up inside, which forces the muscle to contract harder.
Right, but understanding the true physics of why the heart was failing in the first place, and why just forcing it to squeeze harder isn't always the right move, that took another century to figure out.
Okay, so bring us to the frog hearts.
Right, so 1895, this German physiologist Otto Frank is isolating frog hearts. And then a few years later, an English physiologist, Ernest Starling, sets up these dog heart-lung preparations.
And Starling basically attached a fluid reservoir to the dog hearts, right?
Yeah, he had a dial. He
Okay.
could manually increase the volume of blood flowing into the heart and literally watch the cardiac output respond in real time.
And what they found is the Frank-Starling law, which I always picture this like a rubber band.
I love the rubber band analogy.
Because, on a microscopic level, heart muscle is just protein filaments, actin and myosin. They grab onto each other and pull. So if you stretch a rubber band back just a little bit, it snaps back well. If you pull it back further, those protein filaments slide into perfect alignment and it snaps back much harder.
But, and here's where Starling kept turning the dial, he kept adding fluid, and he found the inflection point.
Where you stretch the rubber band way too far.
Exactly. You pull it too far, and the filaments literally lose their physical grip on each other.
The rubber band gets all warped and loose.
The output plateaus, and then it just plummets. This is the failing heart. It operates on the descending limb of that Starling curve.
So extra blood volume no longer buys you extra pumping force. The pump just cannot move the fluid forward.
And if it can't go forward, it has to go somewhere.
It pools upstream.
Yes. And because the human heart is a two-sided pump arranged in series, where that blood pools dictates the entire clinical picture.
This is the crux of it for nurses, right? Left-sided versus right-sided failure.
Exactly. They feed totally different vascular territories. Let's do the left side first.
Yeah.
The left ventricle's only job is to take fresh, oxygenated blood from the lungs and blast it out to the body.
So if the left ventricle is that overstretched, warped rubber band, it fails and the blood backs up into the lungs.
Right, the pulmonary circulation. Left-sided failure causes a respiratory crisis.
Because the pressure builds up so high that fluid physically pushes out of the capillaries and floods the air sacs.
Floods them. The primary sign you'll see is dyspnea, shortness of breath when they exert themselves.
But the really fascinating part is how that shortness of breath changes when they just change position, like orthopnea.
Right, orthopnea is breathlessness specifically when lying flat.
Because gravity plays such a huge role here.
A massive role. During the day when you're standing, gravity pulls all that excess fluid down into the bases of the lungs or into your legs.
So the top parts of the lungs are dry and can still exchange oxygen.
Yes, but when the patient lies flat in bed at night,
Gravity is neutralized.
exactly, a liter or two of fluid that was sitting in their legs suddenly shifts back into the central circulation. It rushes the heart, overloads that poor left ventricle even more, and the fluid just spreads evenly across the entire surface area of the lungs.
Oh, wow. So they literally feel like they're drowning?
Because internally, they are. They have to prop themselves up on 3 or 4 pillows just to sleep.
And in severe cases, you get PND, right? Paroxysmal nocturnal dyspnea, where they wake up gasping for air in a total panic.
It's terrifying for the patient. And if you listen to their back with a stethoscope, you hear crackles or rails. It literally sounds like fluid bubbling in the airways.
And you also might hear that extra heart sound, the S3 gallop.
Yes.
Which the acoustic physics of that are so cool. It's like a lub-dub-dub, and it's literally the physical sound wave of fresh blood crashing into a ventricle that is already bloated and overfilled.
Spot on. So that is the left side. Flooded lungs. Now let's look at the right ventricle.
Okay, so the right side's job is to receive the depleted blood from the body and pump it into the lungs to get oxygen.
Right. So if the right side fails, the backup goes in the exact opposite direction.
It backs up into the systemic venous system, basically the whole body.
Yes, every single vein trying to drain blood back to the heart gets congested. The signs of right-sided failure are the ones you can visually diagnose from across the room.
Like JVD, jugular venous distension.
Exactly. The neck veins visibly bulge out like ropes because the venous pressure is so incredibly high.
And the organs just take a massive hit, right? Like the liver.
The liver is heavily vascularized. So when those veins back up, the liver becomes entirely engorged with blood. The capsule around it stretches.
Which causes hepatomegaly, this enlarged, really tender liver.
And if you press firmly on that swollen liver, you trigger what's called the hepatojugular reflex. You physically force more of that trapped blood up into the neck, and you can watch the jugular veins bulge even further.
Wow. And just like in the lungs, when the pressure in the body's veins gets high enough, fluid just leaks out into the surrounding tissue.
Yes, you get dependent peripheral edema.
Like those severely swollen ankles.
Exactly. Pitting edema in the ankles and calves.
Yeah.
Or, if the patient is bedbound, the fluid pools in their sacrum.
And in the really advanced stages, fluid weeps into the abdominal cavity, which is called ascites. Plus, you see this really rapid weight gain.
Right, but here is the big twist.
Oh, right, because there's a huge clinical paradox here. If the left side exclusively drowns the lungs and the right side exclusively drowns the liver and the legs, how do we end up with patients who have both?
Right, you walk into a room and a patient has bubbling crackles in their lungs and severely swollen ankles.
How does that happen?
You just have to follow the plumbing loop. The single most common cause of right-sided heart failure is left-sided heart failure.
Wait, really? The left breaks the right?
Yes. The chronically high pressure transmits backward. The left side fails. Pressure builds up in the lungs. So now the lungs become this high-pressure zone.
And the right ventricle isn't used to that.
Not at all. It's used to pumping into a very soft, low-pressure lung environment. Suddenly, it has to shove blood against a literal wall of resistance.
So it bulks up, it tires out, and it fails too.
Exactly. The cascade completes itself. You get biventricular failure.
Okay, so seeing a patient in this state, gasping for air, their organs swelling, the most logical, intuitive human response is to look at that weak pump and say, let's give them a drug to force this pump to squeeze harder.
It is the most intuitive thought in the world.
But medical history showed us that following our intuition here is literally deadly.
It's one of the most sobering lessons in modern cardiology. Think back to the PROMISE trial in 1991.
This is the trial with milrinone, right?
Yes. Milrinone is an oral inotrope. It chemically bypasses the heart's natural regulation to force calcium into the cells. It commands the muscle fibers to snap together with immense force.
So they were essentially trying to fix the overstretched rubber band by chemically forcing it to act like a brand new one.
Exactly. And in the short term, it looked fantastic.
Monitors looked great, right?
The hemodynamics improved, the patients felt better, cardiac output increased.
But the final result of the trial was a staggering 28% increase in mortality.
They were dying significantly faster.
Because they were forcing a failing, energy-starved muscle to do way more work.
You are whipping an exhausted, starving horse. It will sprint for a mile and then it will just collapse. The drug raised the heart's oxygen demand so high, and that massive influx of calcium provoked fatal arrhythmias.
Wow.
It proved that treating a symptom, the weak squeeze, is fundamentally different from treating the underlying disease process.
Which brings us to the exact opposite phenomenon, the beta blocker reversal.
Oh, this is fascinating. For decades, beta blockers were strictly banned for heart failure.
Because beta blockers literally slow and weaken the heart's contraction.
Right, and the logic seemed bulletproof. If a patient's pump is already failing, giving them a drug that deliberately weakens the contraction even further sounds like malpractice.
Wait, yeah. How did doctors in the 90s even justify testing that on a patient?
They had to look beyond the mechanics and look at the broader biology. See, when cardiac output drops, the brain senses a drop in blood pressure.
And the brain panics.
Total panic. It activates the sympathetic nervous system, flooding the body with adrenaline. The body basically thinks it's bleeding to death, so it constantly whips the heart to work harder.
The body is making its own internal milrinone. It's whipping itself.
Exactly. And chronic sympathetic overdrive is intensely toxic to heart muscle cells.
Yeah.
It causes them to literally die off.
But trials like MERIT-HF prove that if you give beta blockers, you block that adrenaline.
Yes, you shield the heart cells from that toxic bath. Yes, the pump gets slightly weaker for the first week or so, but over months, shielded from the whipping, the muscle actually begins to heal.
It reverses the damage.
Beta blockers drastically reduced mortality. It was a complete triumph of data over intuition. They are now an absolute cornerstone of therapy.
Okay, so we figured out how to save the floppy, weak hearts. But what about the other half? The HFpEF patients.
The stiff hearts.
Yeah, the ones that squeeze fine but can't relax.
Well, the HFpEF debate was incredibly frustrating. For 20 years, the drugs that saved the weak hearts like beta blockers failed to show major mortality benefits for the stiff hearts.
Because the mechanism is just totally different. A stiff, fibrotic ventricle doesn't care if you shield it from adrenaline. It physically cannot stretch.
Right. But we recently had this huge surprise success with SGLT2 inhibitors.
Like in the Emperor Preserve trial. And these were originally diabetes drugs, right?
Yes, they block a protein in the kidneys to force the body to pee out excess glucose.
So how does peeing out sugar help a stiff heart muscle?
When the sugar goes into the urine, osmotic pressure forces water to follow it. So it acts as this profound, gentle diuretic. It slowly drains the excess fluid volume out of the blood, reducing the pressure on that stiff ventricle.
Oh, wow. And it doesn't trigger the body's panic responses.
Exactly. Plus, researchers think it alters the metabolism of the heart cells to burn energy more efficiently. It was a massive breakthrough.
Okay, so why does all of this matter to you listening today? Well, thanks to the Framingham Heart Study, we know the lifetime risk of developing heart failure for a 40-year-old is roughly 1 in 5.
1 in 5. And with populations aging and more people surviving massive heart attacks, which leaves them with scar tissue, they live long enough to develop chronic heart failure later.
It is a massive driver of healthcare spending, which brings us back to the nursing angle and self-monitoring.
Yes. 30-day hospital readmissions are a heavily tracked metric.
Okay.
Because this decompensation, it's often entirely preventable.
Right. Catch the supply and demand mismatch before the rubber band stretches too far.
Exactly. And something as simple as tracking daily weight is revolutionary. A rapid weight gain of just a few pounds in 24 hours is not fat.
It's fluid.
It is the real-time hydrostatic failure of the right ventricle. It signals fluid retention days before the patient ever feels breathless.
So the clinical team can just adjust their diuretics and keep them out of the hospital. Okay, so before we wrap up this deep dive, I know you have one final provocative puzzle to leave our listeners to ponder on their own.
I do.
Oh, yeah.
And it ties back to everything we just discussed. So we learned that the modern 2021 definition relies on objective evidence, right?
The natriuretic peptides. The heart's internal distress signal.
And those peptides are released when the heart muscle is physically stretched out.
Yeah, stretched by the excess fluid.
But we also learned that half of all heart failure patients today have HFpEF.
The stiff hearts.
A severely stiff fibrotic heart that doesn't relax or stretch well at all.
Oh, wait.
Right. So if our gold standard biological marker requires a stretching muscle, how many patients with uniquely stiff hearts might this diagnostic system still be struggling to capture?
Wow, that is a brilliant question. We might still be missing people. Well, something for you to explore on your own. Thank you for joining us on this deep dive into the broken pump. We'll see you next time. So picture this. You're standing at the bedside of a patient. They're sitting up, they're talking to you, and their skin color looks pretty much normal.
Right.
And the monitor above their head is flashing this perfectly textbook blood pressure. Like 120/80. By every visible metric, every standard alarm bell we rely on, this person is completely stable.
But they're actually not.
Exactly. Beneath the surface, their cardiovascular system is quietly, desperately pulling, like every emergency lever it has. They are maybe 15 minutes away from a complete hemodynamic collapse.
And their own body is actively masking the crisis. It really is the ultimate invisible emergency.
It's terrifying.
It is, because when the human body starts losing significant fluid, it doesn't just instantly wave a white flag.
Yeah.
It compensates. It hides the deficit so well that if a clinician doesn't know exactly what subtle physiological tells to look for, I mean, they'll walk right past a patient who is actively falling off a cliff.
And that terrifying clinical blind spot is our mission for this deep dive. Today, we are reading Fluid Loss Before the Crash. We're taking this stack of nursing textbooks, historical medical case studies, and modern clinical guidelines to really understand the hidden mechanics of fluid balance.
We want to figure out how the body loses fluid, right? And the elaborate biological smoke and mirrors it uses to hide that loss.
Yeah, and most importantly, how you can spot the crisis before the vital signs finally crater. So, okay, let's unpack this. We have to start with the vocabulary, because right out of the gate, the terms we use casually every day are actually fiercely debated in the clinical world.
Oh, heavily debated.
Specifically, I mean, the line between dehydration and volume depletion.
Yeah, the terminology is kind of a mess, but the physiology behind it is incredibly distinct. So, strictly speaking, true dehydration refers to a loss of pure, free water.
Like sweating in a desert.
Exactly. Imagine you're sweating intensely out in the sun without drinking anything. You're losing water, but your body is leaving the sodium behind. And because the water leaves and the salt stays, the concentration of sodium in your blood spikes.
Which triggers hypernatremia.
Right, high sodium. Now, volume depletion, on the other hand, is an entirely different beast. Also known as hypovolemia, this is what we call an isotonic loss.
Meaning the patient is losing both water and sodium at the same time, right, in proportional amounts.
That's the crucial difference. If someone suffers a severe hemorrhage or they have, prolonged vomiting or diarrhea, they're losing the entire fluid package. Water, sodium, the works.
So if we draw blood from that patient in the ER, their serum osmolality, which is the clinical measurement of how concentrated particles like sodium are in the blood, it might look totally normal.
Totally normal. They aren't technically dehydrated by the strict medical definition. Even if they're down like 3 liters of total fluid, they are volume depleted.
Yet, if you look at the charting on almost any med-surg floor right now, nurses and doctors alike are writing dehydration as this catch-all umbrella term for both scenarios.
Yeah, they use it interchangeably all the time.
And it's not for a lack of trying by major institutions to fix it. I saw in the sources that the U.S. National Institute on Aging held a major consensus workshop in 2004 specifically to force the medical community to separate these two terms.
Because they were terrified. Using dehydration for everything was leading clinicians to give pure free water to patients who desperately needed sodium-rich IV fluids.
Wow, yeah. And then the European Society for Clinical Nutrition and Metabolism tried again in 2015. They tried to rebrand the concepts as water loss dehydration versus salt and water loss dehydration.
Which is quite a mouthful.
Yeah.
And those institutional efforts largely failed to change bedside habits. Because in a high-stakes hospital environment, nurses just need an operational shorthand.
So for anyone listening to this deep dive, what's the working definition that actually matters today?
The one that dictates patient care is basically this: dehydration, in the colloquial clinical sense, happens whenever fluid output exceeds intake for long enough to cause measurable physiological compromise.
Okay, and to understand what that compromise actually looks like inside us, we have to look at the math of the human body.
The math is fascinating here.
We've all heard the statistic that an adult is roughly 60% water, but that water isn't just a giant unorganized reservoir sloshing around in there.
No, not at all. It is rigidly locked into specific physiological compartments. And this compartmentalization is where the unseen crisis actually happens.
Right, because 2/3 of that water is intracellular. It's trapped inside your actual cells.
And only 1/3 is extracellular, living in your blood plasma and the spaces between your tissues. So the type of fluid you lose determines which compartment gets drained first.
Going back to our definitions.
Exactly. If you suffer an isotonic loss, like bleeding, you drain that extracellular space directly. That immediately threatens your circulating blood volume.
But if you lose free water like true dehydration, the physics completely change.
They really do, because of the laws of osmosis. When you lose pure water, your blood becomes highly concentrated with sodium. And nature hates an imbalance.
It wants to equalize everything.
Right. So to dilute that increasingly salty blood, the body forcefully pulls water across the cell membranes. It drags fluid out of the intracellular compartment and into the blood.
You are physically draining the fluid from inside your own cells.
Yes. This is the underlying mechanism of why severe hypernatremic dehydration causes profound confusion, delirium, and eventually seizures. The osmotic gradient is actively shrinking the patient's brain cells.
Oh, wow. Visualizing the brain cells physically shrinking makes the stakes incredibly clear. It actually brings up an analogy I was piecing together from the source material.
Oh, what's the analogy?
Well, the body's biological response to sudden fluid loss operates remarkably like a massive corporation facing an unexpected bankruptcy.
Oh, I like that.
When the revenue stops flowing, the company doesn't just instantly shutter its doors, right? It goes into an aggressive, calculated survival mode.
Right. It cuts all the peripheral, frivolous spending to protect the core assets.
Exactly. And in human anatomy, the core assets, like the CEOs of the company, are the brain and the heart. The body will sacrifice almost anything else to maintain the blood pressure necessary to keep oxygen flowing to those two organs.
And it achieves this through a pretty brilliant two-tiered compensation sequence.
Yeah.
The first step is instantaneous. The sympathetic nervous system fires.
The classic fight-or-flight response. The body floods with adrenaline, driving the heart rate up.
Tachycardia, yeah.
And it slams the peripheral blood vessels shut to keep the pressure centralized.
Which is exactly why a patient in the early stages of volume depletion will often have skin that looks pale or mottled, and their hands and feet will feel cold to the touch.
Because the body has cut the budget to the skin.
Precisely. But because of this intense peripheral clamping, if you put a standard blood pressure cuff on their arm, the monitor reads normal.
The sympathetic nervous system is literally creating a mechanical illusion of stability.
And then the second tier of the survival mechanism kicks in to reinforce that illusion, the RAAS cascade.
The renin-angiotensin-aldosterone system.
That's the one. Within minutes to hours of sensing a drop in fluid volume, the kidneys release the enzyme renin, triggering this complex hormonal cascade. The ultimate goal of RAAS is to act like a biological dam.
It floods the system with aldosterone, right?
Yes. Instructing the kidneys to absolutely halt the excretion of sodium and water, it hoards every available drop of fluid to desperately maintain that central circulating volume.
And this is the crux of why checking blood pressure can be so dangerous if it's your only metric. The body fights so aggressively with vasoconstriction and the RAAS cascade that a sudden drop in blood pressure is actually a late-stage failure.
By the time that biological dam breaks and the patient becomes hypotensive, they've often already lost 15 to 30% of their total blood volume.
Which is a massive amount of blood.
It is. Relying on hypotension to diagnose volume depletion guarantees that you're already behind the curve. The physiological cliff is incredibly steep at that point.
Which necessitates a way to look past the body's smoke and mirrors. Our sources emphasize a low-tech, bedside assessment called orthostatic vital signs.
Orthostatics are brilliant. They use gravity to break the body's compensation mechanism.
Instead of taking vitals while the patient is lying flat in bed where the heart doesn't have to work very hard, you take their pulse and blood pressure, and then you have them physically stand up.
And standing forces a massive, instantaneous shift of blood down into the legs. If the patient has a normal fluid volume, their vascular system easily squeezes to push that blood back up to the brain.
But if they're secretly hiding a 20% fluid deficit,
then that sudden gravitational demand totally overwhelms their maxed out compensation system. If you see their pulse suddenly jump by 30 beats per minute, or their systolic blood pressure plummet by 20 millimeters of mercury just from standing,
you've caught the invisible crisis. You force the body to reveal its true deficit.
it's a masterful clinical tool. But, when you look at how beautifully complex the RAAS cascade and osmotic gradients are, it raises a fascinating historical question.
How did early physicians map out this invisible terrain of volume depletion centuries before we had the technology to measure serum osmolality or identify hormones like aldosterone?
Exactly. It's wild to think about.
Well, to answer that, the sources take us back to one of the most terrifying medical crises of the 19th century, the 1832 London cholera epidemic.
Cholera is a brutal disease. It's characterized by the sudden onset of rice water diarrhea, which drains massive, lethal amounts of fluid and electrolytes from the body in just a matter of hours.
And the mortality rate was staggering because the standard medical paradigm at the time was still heavily influenced by miasma theory.
The idea that bad air caused disease.
Right. Or they believed in humoral imbalances treated with bloodletting, which obviously only accelerated a cholera patient's death.
Absolutely. But during this 1832 outbreak, a young physician named William Brooke O'Shaughnessy took a completely different approach. He started performing primitive chemical analyses on the blood of cholera victims.
O'Shaughnessy discovered that the patients weren't just succumbing to a mysterious airborne poison. His chemistry showed that their blood was physically drained of a large proportion of its water and very specific neutral saline principles.
He fundamentally redefined cholera, taking it from a mystical affliction to a quantifiable mechanical loss of fluid and salt.
And that chemical revelation caught the attention of another physician, Thomas Letta. Letta realized that if the disease was mechanically removing salt and water from the blood, the cure must be mechanically putting it back.
Directly into the veins. He found a 44-year-old woman who was in the absolute terminal stages of cholera. She was pulseless, her extremities were blue, and she was entirely unresponsive.
And Letta injected a primitive heated saline solution directly into her basilic vein.
It is hard to overstate how radical this was. The concept of intravenous fluid resuscitation simply did not exist.
And the result of that first infusion was miraculous. Within 30 minutes of the saline entering her bloodstream, her pulse returned, her skin regained color, and she sat up and began speaking clearly.
It was the dawn of rational fluid resuscitation. Now, the ending of Lada's specific case was tragic.
Right. They didn't understand maintenance fluids yet.
Exactly. The medical establishment didn't understand continuous fluids. They stopped the infusion when she looked better, the cholera continued to drain her volume, and she died later that day. But the conceptual breakthrough had been made.
And if we fast forward 100 years to the 1930s, we see the systematization of that breakthrough. At Boston Children's Hospital, a pediatrician named James Gamble started rigidly measuring the exact chemical components lost in infants suffering from severe diarrhea.
He created these incredibly detailed visual charts, which became famous as Gamblegrams.
To map out the precise deficits of sodium, potassium, and chloride.
Yes, and Gamble's visual maps allowed the medical field to finally categorize dehydration into the three primary types we still reference today: isotonic, hypotonic, and hypertonic.
He provided the framework to tailor Thalavy fluids to the specific chemical deficit of the patient rather than just guessing.
Which was a game changer.
I do want to pose a question here, though. We're talking about Gamble doing this in the 1930s. Today, modern medicine has access to incredibly sophisticated laboratory testing. We can draw blood and measure a patient's exact serum osmolality down to the individual milliosmol.
Very true.
So why do modern nursing guidelines still heavily emphasize low-tech bedside proxies? Why are nurses pinching a fingernail to check capillary refill? Or making a patient stand up for orthostatic vitals instead of just waiting for the high-resolution lab chemistry to tell them exactly what is wrong?
That is a critical question, and it comes down to the velocity of the physiological crash.
The speed of it.
Yes. As we discussed earlier, the compensatory mechanisms hide the deficit until the very last moment. When a patient finally begins to decompensate, the cliff is incredibly steep.
So there's no time.
Exactly. If a clinician draws blood and sends it to the lab, the turnaround time for those results might be 45 minutes to an hour. In the context of a failing cardiovascular system, an hour is an eternity.
So bedside proxies like capillary refill and orthostatics exist because the frontline clinician literally cannot afford to wait for a lab result.
They need a real-time signal to intervene before the hypotensive crash occurs.
Which means the intervention itself has to be both immediate and chemically precise. And this brings us to one of the most counterintuitive themes in our source material.
The realization that in certain crises, giving a severely depleted patient a glass of plain water is the absolute worst thing you can do.
Yes. This is perfectly illustrated by the discovery of oral rehydration therapy, or ORT, in Dhaka during the late 1960s.
Researchers were trying to combat cholera in regions where widespread IV fluid resuscitation was logistically impossible.
Right. And they were dealing with a disease that completely paralyzes the gut's normal ability to absorb water. But they discovered that one specific microscopic gateway in the intestinal wall remains functional, even during severe cholera.
The sodium glucose link transporter, or SGLT1.
I love how the mechanisms work here. The SGLT1 acts like a biological dual-key security system on a bank vault.
That's a great way to picture it.
If you give a cholera patient plain water, the vault stays locked, and the water just passes straight through them as diarrhea. If you give them plain sodium, it stays locked.
But if you provide a highly specific ratio of water, sodium, and glucose,
the glucose and the sodium act as two keys turning simultaneously. It physically forces the transporter open, actively dragging the water across the intestinal lumen and into the bloodstream.
It is an elegant hack of human biology.
Huh.
By utilizing that transporter, clinicians could rapidly rehydrate dying patients without a single IV needle.
The Lancet famously referred to ORT as potentially the most important medical advance of the 20th century because it perfectly leveraged the body's own precise cellular mechanisms to save tens of millions of lives.
It really is an incredible story.
But here's where it gets really interesting. We have this massive triumph in the 1960s proving that fluid balance is a delicate mechanism of precise ratios.
Right.
Let's contrast that deep understanding of osmolality with the hydration culture of the 2002 Boston Marathon.
Oh, man. It is a devastating juxtaposition. For decades, the endurance sports community aggressively pushed a blanket hydration narrative.
Drink before you're thirsty, right?
Yeah, drink before you're thirsty and drink as much as possible to avoid collapsing. They basically treated the human body like a simple reservoir that just needed topping off.
Which, if you are a runner listening to this, you're probably mentally auditing every hydration station you've ever stopped at right now.
I know I am.
Because in 2005, a landmark study in the New England Journal of Medicine by Christopher Ullman analyzed the runners from that 2002 marathon. They discovered that a significant percentage of the finishers were suffering from hyponatremia.
Dangerously low blood sodium.
And tragically, this exact mechanism led to the death of a 28-year-old runner named Cynthia Lucero. She collapsed and died from water intoxication.
We have to look at the osmosis mechanism again and understand how drinking too much water becomes fatal. These runners were sweating out both water and massive amounts of sodium for hours.
But at every mile marker, they were replacing those losses with pure, free water.
Exactly. As they pumped liters of free water into their system, they drastically diluted the sodium concentration in their blood. Their serum osmolality plummeted.
Meanwhile, the fluid inside their brain cells maintained a higher normal osmolality.
And remember that nature hates an imbalance. The massive volume of free water in the blood violently rushed across the blood-brain barrier and into the brain cells to try and equalize the concentration.
So the brain cells physically swelled up with water. And because the brain is encased in a rigid, inflexible skull, that swelling quickly leads to catastrophic pressure, coma, and brainstem herniation.
It's horrific. It forced an entirely new paradigm in sports medicine. Fluid replacement is never just about dumping volume into the body. It's entirely dependent on the ratio of water to solute.
And that precise lesson wasn't just limited to marathon runners. The exact same foundational misunderstanding of free water caused a quiet, decades-long crisis in pediatric hospital care.
Up until very recently, the standard medical practice across the globe was to place hospitalized children on hypotonic 5E fluids.
Fluids that have a lower osmolality, meaning more free water and less sodium than normal human blood.
Right. The rationale was simple. Children are sick, they're insensible fluid losers, they need hydration.
Yeah.
But in 2018, the American Academy of Pediatrics issued a massive guideline change, completely reversing decades of standard practice.
What drove that reversal? Like, what was the physiological mechanism they were missing?
They realized they were fundamentally ignoring how the stress of illness alters a child's hormones. When a child is sick, whether from pneumonia, surgery, or an infection, their body naturally ramps up the secretion of antidiuretic hormone, or ADH.
And ADH is basically a chemical mandate sent directly to the kidneys telling them, do not, under any circumstances, pee out free water. Hoard it.
Exactly. So the children's bodies were biologically primed to retain water. When doctors then aggressively pumped their veins full of hypotonic 5E fluids, the ADH trapped all that excess free water inside their systems.
It created the exact same mechanism as the marathon runners.
Yes.
The free water diluted their blood, and the osmotic gradient forced the water into their brain cells, leading to fatal hospital-acquired hyponatremia.
Once the mechanism was understood, the clinical guidelines had to instantly pivot to mandate isotonic fluids as the new default, matching the AVI chemistry to the body's stressed physiological state.
It's a really sobering reminder that applying overly simplistic rules to a complex physiological system can be actively dangerous.
Which serves as the perfect transition into dismantling the pervasive, everyday hydration myths that the general public still largely believes.
Okay, let's start with the most entrenched myth of all. The 8-ounce glasses of water a day rule. We hear it everywhere, from fitness influencers to health blogs.
Oh, the 8x8 rule is a fascinating case study in how scientific data gets cherry-picked and distorted over time. The origin actually traces back to a 1945 recommendation of the U.S. Food and Nutrition Board,
which stated that adults require about 2.5 liters of water daily.
But the people quoting that number conveniently stopped reading halfway through the paragraph. The very next sentence of that 1945 report explicitly stated that the vast majority of that 2.5 liters is already contained in the prepared foods we eat every single day.
You extract significant water from apples, pasta, soups, vegetables.
Exactly. In 2002, physiologist Heinz Walton published a comprehensive review that completely dismantled the 8x8 rule as a biological requirement for healthy adults.
Because applying a rigid mathematical water quota ignores the massive variables of human physiology.
Right. A 200-pound construction worker in a humid climate has vastly different osmolality demands than a 120-pound office worker in a climate-controlled building.
So if 8 glasses is a myth, what do the clinical thresholds for actual danger look like?
To give it scale, let's look at an average 70-kilogram adult. A fluid loss of roughly 2 to 3.5 liters triggers the body's moderate warning systems.
Dry mucous membranes, thirst.
Yes, and their kidneys will concentrate their urine to conserve volume. The brain's osmoreceptors will trigger a strong sensation of thirst. But if that same adult drops 7 liters, which represents roughly 10% of their total body fluid, the compensatory mechanisms begin to fail.
This is a profound medical emergency characterized by lethargy, sunken eyes, virtually zero urine output, and in severe pediatric cases, the physical sinking of the fontanelles on an infant's skull.
It's severe.
Reaching that 10% threshold is catastrophic, and our sources highlight that one specific demographic is horrifyingly vulnerable to silently crossing that line: the elderly.
Dehydration is one of the leading causes of preventable hospitalization in older adults.
But I always assumed this was largely a behavioral issue. You figure older folks simply forget to drink, or they deliberately restrict their fluids to avoid having to navigate a difficult trip to the bathroom in the middle of the night.
Well, the behavioral and mobility barriers are absolutely real. Fear of incontinence drives a lot of voluntary fluid restriction, but the true danger is rooted in the degradation of their biological alarm systems.
What do you mean?
If you look at a standard first aid manual, it tells you to look for a patient complaining of thirst. But thirst is governed by osmoreceptors in the brain sensors that detect when the blood is getting too concentrated. As we age, those osmoreceptors physically lose their sensitivity.
Wow, so an elderly patient's blood can reach dangerously hypernatremic levels, and their brain physically will not generate the conscious sensation of thirst.
The alarm wire has literally been cut.
That makes the standard assessment tools incredibly unreliable. What about the classic pinch test? You know, the skin trigger test where you pinch the skin on the back of someone's hand to see if it snaps back instantly?
Skin turgor is another physiological trap when assessing the elderly. The snapback of healthy skin relies entirely on a matrix of collagen and elastin in the subcutaneous tissue.
And as humans age, that elastic matrix naturally breaks down.
Entirely independent of how much water is in the body. If you perform a turgor test on a healthy, perfectly hydrated 85-year-old, their skin might remain tinted for several seconds.
So if a clinician relies on PERBR or thirst to assess an elderly patient, they'll miss the volume depletion entirely until the patient ends up in the ER with confused mental state and a failing heart.
Which fundamentally changes how caregivers and clinicians have to approach this population. You can't just set an alarm to remind an elderly patient to drink if their kidneys can't concentrate urine effectively and their brain isn't sending thirst signals.
You have to rely on objective mechanical metrics.
Yes. You track daily weights on a scale to catch sudden, invisible fluid drops. And you meticulously check those orthostatic vital signs to see if the cardiovascular system is secretly straining against gravity.
So, what does this all mean for you as the listener? Let's synthesize the journey we've taken through the source material today. We started by dismantling our basic vocabulary, learning that a loss of free water shrinks the cells and spikes sodium.
While an isotonic volume depletion secretly drains the cardiovascular system, while the blood chemistry looks perfectly normal.
We uncovered the physiological deception of the body's survival mechanisms. We saw how the sympathetic nervous system and the RAAS cascade act as a biological dam, clamping down blood vessels.
And hiding a massive fluid deficit behind the illusion of a normal blood pressure reading.
We looked at the tragic consequences of misunderstanding osmolality. From the marathon runners drowning their own brain cells with pure free water, to the realization that sick children require precisely calibrated isotonic fluids to counteract their own stress hormones.
And this understanding isn't just an academic exercise. With global temperatures rising and heat waves driving unprecedented spikes in emergency room admissions, the ability to read fluid loss before the crash is a critical survival skill.
Whether it's a nurse on a chaotic med-surg floor catching an orthostatic pulse jump, or a caregiver recognizing the blunted physiological alarms of an elderly parent, Spotting the unseen deficit is what prevents a silent slide into cardiovascular collapse.
It is a high-stakes game played entirely beneath the surface of the skin.
Which brings me to one final, truly mind-bending concept from the clinical guidelines to leave you with. It's a physiological paradox known as third spacing.
Oh, third spacing is wild.
I want you to imagine a patient lying in an ICU bed. If you look at them, they appear massively overloaded with fluid. Their legs are swollen, their arms are puffy, their tissues are stretched tight with severe edema.
To the naked eye, this person is drowning in excess water.
But if you look at the unseen mechanics, something completely different is happening. Normally, proteins in your blood, specifically albumin, exert what is called oncotic pressure. These proteins act like microscopic molecular sponges, physically holding the water inside your blood vessels so the heart can pump it.
But in states of severe illness, sepsis, or malnutrition, that sponge fails. The capillaries become dangerously leaky.
The fluid physically seeps out of the vascular system. It leaves the blood vessels entirely and becomes trapped in the interstitial tissues, the third space, where it is completely useless to the brain and the heart.
So you have a patient whose body is visibly swollen like a water balloon. But inside their actual circulatory system, their vessels are bone dry.
They are actively crashing from severe volume depletion, starting for circulating fluid while literally drowning in their own tissue edema. Can you trust your own eyes?
You really can't.
It leaves you with a profound realization about the human body. When the stakes are life and death, you can rarely trust the surface alarms. You have to understand the mechanisms hidden beneath. Because as we've learned today, in the delicate mathematics of human physiology, what you see on the outside is almost never the whole story.
So I want you to imagine a really specific, incredibly high-stakes scenario right now. You are a triage nurse or maybe a clinical social worker, and you're sitting across a small room from a patient.
Right, under those buzzing fluorescent lights.
Exactly. And you are trying to predict this incredibly rare life or death event. You literally have to figure out if the person sitting right in front of you is going to survive the night.
It's an immense weight to carry.
It really is.
Yeah.
And honestly, how do they do it? Because usually when we talk about a medical diagnosis, there's this, this expectation of precision. Like you break your arm, the x-ray shows that jagged white line, and the doctor points and says, well, there it is.
Yeah, it's very binary. It's broken or it's not broken.
Yeah.
We really like things to be visible and neatly categorized in medicine. But in mental health, and especially in crisis care, that x-ray machine just doesn't exist. You are looking at a diagnostic landscape that is entirely invisible to the naked eye.
And that is exactly why today our mission on this deep dive is to unpack how clinicians actually navigate that invisible landscape. We are exploring a whole stack of fascinating clinical and historical sources to understand the science of suicide risk assessment. Basically, the science of asking the question that saves a life.
And this really matters for you right now listening to this because the whole landscape of mental health care is fundamentally shifting. I mean, back in July 2022, the United States launched the 988 Suicide and Crisis Lifeline, which was modeled directly on 9/11.
Right.
With that kind of infrastructure, universal screening is rapidly becoming standard practice. It's no longer just happening in locked psychiatric wards.
You see it everywhere now.
Exactly. If you go to a primary care clinic, a school counselor, or even just a general medical setting, these assessments are becoming just a normal part of the routine.
So we are going to give you a roadmap for how this actually works. We'll cover the pretty shocking origin of the field, the major medical misunderstandings that persisted for literally decades, and why a specific UK utility change completely altered how we view mental health.
It is really a history of trial, error, and some pretty massive paradigm-shifting discoveries.
But, before we can even understand how clinicians actually assess risk, we really have to clear up the biggest misconception that stops everyday people, and sometimes even professionals, from doing it in the first place.
Oh, absolutely.
I mean, I like to think of this old fear as being a lot like Fight Club.
Okay, Fight Club.
Yeah. Because, the first rule of Fight Club is you do not talk about Fight Club. And for a really long time, the unwritten first rule of suicide was that you don't talk about it.
Yeah.
People were just terrified that bringing it up would somehow plant the idea in someone's head.
Yes, that is the single most persistent myth in the entire field. It's this pervasive idea that asking someone directly if they are suicidal will, push a vulnerable person over the edge.
Right, which sounds logical if you're scared, but...
But the clinical sources are incredibly clear on this. It is empirically false. There was this landmark systematic review in 2014 by Doddsey and colleagues that looked at this exact question.
And what did they find?
They found absolutely zero evidence that asking about suicide increases suicidal ideation. Zero. In fact, they found the exact opposite.
So it actually brings the temperature down.
Precisely. It reduces distress. And if you think about the psychology of it, it makes total sense. I mean, a person in an acute crisis is often dealing with this immense shame and isolation.
Yeah, they feel completely alone.
Right. So direct, plain language questions, literally just asking, are you thinking about killing yourself, takes this terrifying, isolating monster in the room and turns it into a tangible thing you can actually discuss. Euphemisms just create more ambiguity. So breaking that taboo is really the fundamental first step in harm reduction.
Wow. So where did this practice of direct questioning actually start? Because from the sources, it didn't come from some pristine ivory tower. It traces back to a psychologist named Edwin Schneidman in the late 1940s.
Yes, Schneidman is a huge figure here.
Right. So he was asked to review Veterans Administration hospital records in Los Angeles, and he just stumbled onto this cache of actual suicide notes.
And those notes completely changed the trajectory of his work and really the whole field of psychology, because reading them made him realize that clinical theory at the time was just way too detached from the messy reality of an actual crisis.
So fast forward a bit to 1958, and Schneidman co-founds the Los Angeles Suicide Prevention Center with Farborough and Lippman. And this is widely regarded as the first suicide prevention center in the world. But they weren't just writing academic papers, right? They were fielding real, live crisis calls.
Yeah, and that is a crucial detail for understanding the DNA of suicide risk assessment. It was born on crisis phone lines. It was harm reduction in real time.
Not just in abstract psychiatric wards.
Yeah, exactly. These clinicians were on the phone with people right in the middle of a spiraling event, trying to figure out if they needed to send the police or just stay on the line, that they didn't have the luxury of time to, dance around the subject.
Right, they had to be direct.
They had to figure out what distinguishes someone who is deeply distressed from someone who is actually about to act. Schneidman even coined the term suicidology a bit later, in 1968, and the concept of postvention.
It was pure real-time triage. Okay, let's unpack this. We know we must ask, and we know from the data that we shouldn't be afraid to ask.
Yeah.
But for a huge chunk of the 20th century, the medical field took the answers to those questions and used them for the completely wrong goal.
Yeah, they really did.
They treated it like a perdition game.
That was the 20th century mindset, essentially. The historical framework in medicine was all about sorting patients into buckets, like low, medium, and high-risk tiers, and then you administer treatment based on that specific label.
I mean, it sounds totally logical. That's what you do in an emergency room for physical trauma, right?
Yeah.
The gunshot wound gets seen before the sprained ankle.
It makes sense intuitively, sure, but the data shows it was a massive failure for mental health. The real turning point in the literature is this massive 2017 meta-analysis by Joseph Franklin and his colleagues.
Oh, this study blew my mind.
It's incredible. They looked at roughly 50 years of research on suicide risk factors, half a century of data. And they found that predictive accuracy hadn't meaningfully improved in all that time. Categorizing individual patients into risk tiers performed only marginally better than chance.
Only marginally better than a coin toss. That is just wild.
And it gets worse. Researchers like Matthew Large pointed out a really dangerous side effect of this whole prediction mindset. He argued that formal risk categorization creates a dangerous illusion for the clinician. Well, think about what a low-risk label does to a busy triage nurse. It tells them they can step back, maybe under-monitor that patient, and focus on someone else. But the statistical reality is that the vast majority of suicides occur in people who were never flagged as high risk in the first place.
Because suicide is statistically rare to begin with, so high-risk categories are just tiny, tiny slices of the population.
Right. It's a low base rate event. A low-risk label is just a probabilistic statement about a massive group of people. It is not a safety guarantee for the specific, complex individual sitting right in front of you.
But wait, I have to ask, if we can't accurately predict who will attempt suicide, why are we doing assessments at all? If the sorting buckets don't work, what is that nurse even doing with that questionnaire?
What's fascinating here is how the field responded to that exact crisis of confidence. Leading organizations like the Zero Suicide Institute and the Joint Commission, they didn't just abandon the assessment. They fundamentally changed its purpose. They shifted the definition from prediction to risk formulation.
Risk formulation. Break that down for me. How is that actually different from prediction?
Well, prediction is about generating a label, high, medium, low, and essentially handing down a verdict. Risk formulation is completely different. It's an ongoing collaborative narrative. It's the clinician sitting down with the patient and identifying the specific modifiable drivers of risk for them in the specific moment.
So it's more of a partnership.
Exactly. The clinician isn't a judge anymore. They are a partner trying to build a concrete safety plan based on what is driving the pain today and what resources the patient actually has right now.
So if the goal is no longer slapping a label on someone, the actual tools used in the clinic had to evolve dramatically, right? Because some of the old practices were, looking back, just completely illogical. Take the no suicide contract.
Oh, right. Also known as the no harm contract. This was widely used from the 1970s straight through the 1990s.
Yeah, and this was a literal written or verbal promise where the patient agreed not to harm themselves before their next appointment. I mean, to me, this sounds like making someone sign a piece of paper promising their house won't catch fire.
That's a great way to put it.
Right. It makes the person holding the clipboard feel like they have legal comfort, but it does absolutely zero to stop the flames.
And that is exactly how the research evaluated it. Studies consistently showed these contracts had zero demonstrated protective effect. None. And worse, they created that dangerous illusion of safety we just talked about. A patient could sign the contract, look totally compliant, and get discharged while still having an untreated plan and full access to lethal methods at home.
So if a contract was just a hollow piece of paper promising no fire, what is the modern replacement?
It's called the Safety Planning Intervention. It was developed by Barbara Stanley and Gregory Brown in 2012.
But wait, isn't a safety plan just another piece of paper? How does writing down a strategy actually stop someone in an acute crisis?
Because it's not a hollow promise to a doctor. It is a personalized, concrete, step-by-step cognitive map for the patient. You see, during an acute suicidal crisis, the prefrontal cortex, the part of the brain responsible for logical planning and impulse control, it essentially just goes offline.
It just shuts down.
Right. So a safety plan does the thinking for them when they can't. It maps out their specific personal warning signs, internal coping strategies they can do alone, social settings that provide distraction, specific professionals to call, and crucially, steps for removing lethal means from their environment.
It's like actually buying the fire extinguishers and mapping out the emergency exits before the smoke even starts. That makes total sense.
Exactly.
And it wasn't just the contracts that failed. The old static risk checklists failed too. Like there was one in the sources called the SAD Person Scale from 1983.
Yes, the SAD Person Scale.
It was an acronym standing for demographic things like sex, age, depression, previous attempt. It was supposed to be this quick memory trick for emergency departments.
But studies, like the one by Cooper and colleagues in 2016, totally debunked it. They proved that these static scales performed terribly. And if you look at the mechanics of why they failed, it's pretty obvious. You just cannot sum up demographic data to capture acute human distress.
Right, because under that old acronym, a 45-year-old single man might score